We are also thinking of collaborating partners where we can the functions, the technical guidance, I want
on comments because we realized you can't do one or the other. Like, you can't be just implementation and just academics. You're kind of mixing it all together and bringing partners.
But I think we're
Partners and we have alliance.
sort of like childcare delivery system. So do you deal with the immunization programs also?
Sure, I can connect you with someone within the organization check.
Okay.
I've had one for colleagues
Probably I know one of your Sharma in NCDC and IDS.
This is an open trial. More than a third of all sewage in India flows here, and testing it through environmental surveillance could save millions of lives.
When I told my kids for the first time that I was testing sewage in this at the same time, they were fascinated. It was beauty in low-income sections for the ladies, where people's food converges.
So
first time that we see something that belongs to everyone. People can actually protect themselves.
Environmental surveillance has a huge potential because there are so many people who don't have access to regular testing.
Who disagree? Everybody knows, whether they're rich, they're poor. It's not just important for India, but for everyone.
To solve the world's most pressing problems, we need to trust those closest to the challenge. These are the solutions that make our world a better place for everyone. This is Rethinking Possible.
For anybody who walks around Bangalore, the first thing that you do see are the open drains. I don't think there are too many high-income countries with open drains. I would be very surprised in fact. I'm Varsha Sridhar. I am a molecular biologist and a biotechnologist. In the 60s, polio wastewater surveillance was basically the first large-scale public health wastewater surveillance. But after that, there hasn't really been any sort of ongoing research into what can wastewater be used to test for.
It wasn't until the urgency of the COVID-19 pandemic that interest in wastewater surveillance renewed. And after one study showed that underground wastewater surveillance could serve as an early warning system, it prompted the question, could it work in open drains too?
My name is Dr. Angela Chaudhary. I serve as Chief Catalyst of Swasthi. It's a global public health organization that serves some of the most marginalized populations. In March 2020, already many people were affected by COVID. We really wanted to know if open drains held some clues for us. So we had to prove for ourselves that this experiment would actually work.
I would not say we were winging it, but it was definitely not something that we had tested before.
We literally had a fishing rope with a plastic bottle tied at the end, and we just kept doing that.
We were just like, put the bucket into the water and carry it to the lab. But when we saw that first positive, I think we both freaked out. There was this kind of shriek, it's positive.
With the backing of Swasthi and a host of other health-interested collaborators, they created the Precision Health Platform, a public dashboard where wastewater test results could be viewed in real time and could inform communities to know an outbreak was imminent 7 days before hospitals started filling up.
This meant that government administrators could warn the hospitals. They could plan human resources, they could plan their staff, and they could plan for hospital beds.
Initially, I was not able to see the connection between what I thought would be an isolated research finding to a public health response that could actually lead to some kind of an actionable insight.
The moment there's a spike, our data was better than the...
Angela is an extremely experienced public health professional, and so she was able to see the next steps forward.
It all starts here, with the sewage collection. Through barcodes, they track where each sample is scooped up.
All these sites are geotagged. This is the bottle of the sample which was taken from this particular site. This represents a population of around 500 households on average.
Samples are then taken to Dr. Varsha's lab, where RNA is extracted and tested for various pathogens. Then that information is transmitted to the dashboard corresponding to each 500 household section of the city. It puts everyone, no matter of status or wealth or location, on a level playing field.
It's a lot about governance. Why shouldn't we have access to information like that? The platform itself is setting new standard in what should be a public good. I would like to know what risks are out there in a way that I understand so I can take care of myself.
People who live in slums in India often don't have access to proper healthcare. So with this information available to community leaders, health authorities, and journalists, it can be disseminated throughout communities, delivering on this massive public health challenge.
If they don't fall sick because they're protected by masks and other interventions, then they're able to lead their livelihoods without any concerns.
What I'm most excited about the future is the integration of environmental signals with community clinical data for conditions like antimicrobial resistance, tuberculosis, and new and emerging pathogens.
In addition to expanding their testing to other pathogens or compounds of public health interest, the Precision Health Platform is also expanding across India.
Their framework is available for any place with open drains.
We started with Bangalore, now we're in 5 cities across India, with interests from Cambodia and Philippines as well. Our dream is to see this scale up in as many cities as possible so that the cities are better prepared.
The years since 2020 have only sort of underscored that we are a bunch of slightly weird people who like to test gross things. I think what sort of drives me in this is the constant need for tinkering. We have evolved from a biomedical lab into a public health action on the ground.
Scientists, people who hold political posts, artists, all of these people came together to deliver health outcomes for some of the most marginalized people. Precision Health platform has shown me local innovations can help us plan and prepare for the next pandemic, perhaps even the next disasters that are going to hit us.
All right, with that, wishing you all a very, very good morning. Thank you. As we kickstart day 2 of the World Health Summit Regional Meeting, it is my pleasure to welcome you all to today's panel discussion titled From Wastewater to Action, Novel Approaches to Enhance Traditional Surveillance for Targeted Public Health Interventions. Our moderator for today's session, Dr. Angela Chaudhary, Chief Executive Officer of Swasthi. She needs no introduction. As you saw in the video, she designed and scaled Precision Health, an environmental surveillance platform integrating geospatial intelligence and community health data for real-time disease surveillance. Angela has 27 years of experience in global public health across Southeast Asia, and East Africa, and has led multiple transformative initiatives that translate public health science into community-driven action. She needs no introduction, but I had my speech prepared, so Angela, I had to say it out loud. I welcome you to the panel discussion and request you to take it forward.
Thank you so much. It's always a little embarrassing to see your face like so big on a video, but we had fun making that film. It's a real honor because exactly 4 years on this date, 26th April, is when we started our first scale up, the 5-city scale up of wastewater surveillance. And so it's like the loop has come together with all of you here who are in surveillance, and we're discussing how this still can be a great public health tool. And we have some cynics in the room that I look forward to hearing from later. So how many of you have actually participated in some form or the other in wastewater surveillance? If you put your hands up. And how many of you heard the word and was curious about what it is? If you could put your hands up. Awesome. And how many of you are active skeptics of wastewater surveillance and curious? Put your hands up. Just one? Oh, come on, a few more maybe? All right, well, yes, there's a couple more. Great, this is good. So, with Gates Foundation supporting wastewater surveillance for multiple pathogens and with WHO keeping us up to date with the latest standards and technical guidelines on wastewater surveillance, and with the global and regional forums like GlowaCon, the Asia Pathogen Genomics Initiative, and the Alliance for Pathogen Surveillance Innovations, keeping us united towards a common goal. We successfully integrated AI and robotics using drones for sample collection. And thanks to COVID Poops 19 efforts, we know that at least 72 countries have utilized wastewater surveillance. And using this tool for other things since the onset of pandemic. I mean, it's been used for polio, but very, very limited since then. And COVID-19 has again opened our eyes to the utilization of this efficient and equitable tool. You might wonder why a public health organization that is focused on community-driven action is into the space of surveillance, because most people who are in surveillance are from the government and highly technical experts. Can actually utilize that information into actionable insights and action, and that is what today's meeting is actually about. We will not be talking about hardcore technical stuff. Half of you in the room are going to say, well, I need to go back to college and understand what this is about. But really, it's a tool for equity. Because like you heard before, everyone poops, and the poop has so much information to give us that will help us in planning and save lives. And in that space, we want to talk about who are the stakeholders. One of the key things during COVID is that we didn't know who the key stakeholders were. Some of them were obvious, but many, many decision makers were not so obvious that we discovered. So what we're here to do today is bottle up those lessons and share it in a way that you can say, hey, this is a cost-efficient, fairly effective public health surveillance tool that one could deploy, and these are the roles of the various partners and players within public health. So with that, I want to, we have two key presenters today. We have 5 types of people in the room today. Most important, audience, that's you guys. Second, we have 2 presenters who will present and set the context for what we are about to speak about. Then we'll have an exciting panel. And then we have 2 key interveners. What is I don't know if you're familiar what an intervener is. An intervener basically takes the lessons and objectives and summarize it and adds their bit to it because they're experts of a particular field. And we'll have Q&A, and then there's a moderator who will say thank you. I'd like to introduce my co-host and partner, Dr. Karen Hart, who is with the World Health Organization Southeast Regional Office. She's got 20 years of experience and leads a communicable disease surveillance. Right now, she's developing a regional strategic framework for communicable disease surveillance. Over to you.
Thank you so much for the introduction, and it's a pleasure to have you all here. 9 a.m. It's not the ideal slot, I know, but it's a pleasure, and we would like to set the scene and get you started on this. So good morning to all delegates, colleagues, and friends. So I will dig into and just give a broad overview. What is wastewater surveillance and why is it so important? It's a non-invasive and cost-effective method in detecting pathogens in communities. And during the COVID-19 pandemic, it provided real-time data that was crucial for some of the public health responses. It is particularly useful in low-resource settings where clinical surveillance is particularly challenging. And what we know is that it complements other types of surveillance. It also has a number of key applications, so it can really detect emerging pathogens early and predict, or at least help us support to detect disease outbreaks. But it is also very important when we look into diseases that are close to elimination or eradication, for example, with polio. It helps us to monitor antimicrobial patterns, resistance patterns, and also to track various infectious diseases, including influenza. And there also, we want to really know what could be supplementing our vaccination strategies. What are the hotspot areas? Who should we prioritize in our vaccination efforts? So wastewater surveillance gained, as we heard from Angela already, gained significant attention during the COVID-19 pandemic, and also polio surveillance has made considerable progress. However, despite its proven benefits, wastewater surveillance is not yet routinely implemented for multiple pathogens at the national level in most countries. The real challenge really lies in scaling this up, and how can we best bring this into implementation into national programs. So this is also where we as WHO Zero in the region see our role. So we are supporting 11 countries in our region, and what we really try to do is to support the normative guidance, to really support countries in policy development, advocacy, and we also provide technical support for the integration into national routine surveillance programs. We also try to harmonize and scale the wastewater surveillance across the diverse different health systems. In addition, we provide country support by really adjusting the policies to the specific country context, and we develop frameworks on how to best integrate that into the respective countries' already existing systems. So we work on capacity building, also on innovative technologies. We materials and methods are really standardized globally for these polio laboratories. And also there's a strong monitoring systems in place, and the optimization is well established. So for example, the antivirus isolation rate is really one of the key performance indicators for the particular environmental surveillance site. We also have a number of external quality assurance schemes in place, and participation is mandatory on a global level. So we can really say that it's a very useful tool, but we also have to be cautious, because a negative sign does not mean that there is no circulation in the community. So I just wanted to give you an example on what the reports look like, what we, for example, get on a weekly or bi-weekly base. This is an example from India from last year, and you can see there are different polio sampling sites and the different states, and you can see either there is a signal or no signal, so we get this from all the different polio sampling sites, just as an example. So I would like to draw your attention on another pathogen, Salmonella typhi, which places a fairly high burden in our region. However, we have also a potent vaccine available. So the traditional surveillance methods, as many of you know, they really face some severe challenges which limit really the effectiveness in accurately monitoring and controlling the disease. First of all, we really have a lack of proper diagnostic tests. Bone marrow culture is rarely performed, and we know that blood culture has only 60% sensitivity, so this is not really not well used, and we have a lot of antibiotic use before patients actually to present to the hospitals. We have it in children, so it's really a problem that we get a lot of false negatives, and hence, of course, we don't get the proper reporting. However, we think that wastewater surveillance, or we know that it's a very valid complementary tool, because it provides us non-invasive community-level data, and it can identify high-risk areas of transmission. So as I said before, we don't know who is exactly the person who sheds the bacterium, but of course we can alert the other surveillance systems to have higher vigilance in that particular area. And also it helps us identify residual transmission pockets in case of already vaccinated communities. And it really offers real-time data for targeted interventions, and it supports us in the prioritization for immunization. Because often we get asked, who should we vaccinate first in a large country? Where are really the gaps? Where do we need to start? And this is really a useful tool where it can complement our other surveillance systems. And of course, later on, to identify potential asymptomatic carriers in the community. So we have currently started working on a project jointly with our WASH team and the European Commission HERA, where we, on a global level, the project aims to develop strategies and build capacity. We want to enhance data sharing and collaboration, and to support the multi-pathogen surveillance. So what we do right now in our region is that we are currently performing a systematic review on the lab methods for conducting wastewater surveillance for Salmonella typhi in our region, and really also to develop a protocol that works for us in our settings. We are also supporting and participating in expert networks, and as a next step, we want to field test the lab protocols in already established polio sampling sites. So we do not want to create new systems or silos or parallel systems, but we really want to use the structures that are already in place in many of our countries and use them for additional pathogens. We need to build capacity in some of the stuff, how to sample, how to really detect it in the ideal way in the laboratories. And we then later, of course, need to translate it into policy, scale it up, and we also want to try to replicate it for other pathogens or bacteria, with the option to further expand it to antimicrobial resistance and genomics. So I'm not going into the details here. So as we conclude, let's just recap on the key points about the importance and potential of wastewater surveillance. So it is really a crucial tool that complements traditional routine public health surveillance. It has been a useful tool to help us to prepare for the potential next pandemic, but also to support disease elimination and eradication. However, we also need more research regarding the utility and feasibility beyond the pathogens I just discussed, and how we can scale this up. We probably need some more enhanced capacity to how to best use the already established structures. And we are really committed in supporting countries in the wastewater implementation, as I mentioned before. And with this, I would really like to call you to action for policy support, and that we all, as we are here in the room, collaborate and bring all our experience together to scale this very important tool up. Thank you so much.
Thanks, Karen, for your very clear ask. The next presenter is Dr. Aruna Panda, Program Director, Alliance for Pathogen Surveillance Innovations India. She's a veterinary virologist and epidemiologist with over 24 years of experience in the field of infectious disease research. And she's focused now on utilizing environmental surveillance to predict infectious diseases outbreaks.
Thank you, Angela, and a very good morning to all of you. It's a pleasure to be here, and I'm going to talk about the role of environmental surveillance in One Health, a concept which has gained a lot of momentum due to the rise on zoonotic infections, the recent Zika, Ebola, and pandemic, the COVID-19 outbreaks have made us realize the importance to have robust surveillance programs. And environmental surveillance, as Dr. Karen just mentioned, can be a complementary tool to existing clinical surveillance programs. So I'm going to give two case studies. The first one was environmental surveillance of human pathogens. This was an initiative started in 2021 from generous support from the Rockefeller Foundation. A program was aimed towards upscaling SARS-CoV-2 genomic surveillance during the second wave of the pandemic. We formed a multi-city consortium of more than 25 plus research and clinical institutions, all focused towards forming an advanced surveillance platform incorporating genome sequencing and bioinformatic tools to basically detect the variants circulating in the country during that time. And we could sequence a large number of clinical samples, and these sequences were submitted both to the Indian SARS-CoV-2 Genomic Consortium, INSACOG, and GISAID. Hence, we were able to promote both national and global data sharing during this critical period of the pandemic. In phase 2, we saw the potential of environmental surveillance of the virus since it was found in wastewater, and we actually broadened these to different other pathogens of public health concern, like influenza, chikungunya, Zika, and bacterial pathogens which contribute to AMR, which is a global public health threat. The idea was to utilize standard protocols and create sustainable surveillance models that could be handed over to public health authorities to create sustainable surveillance program in India. Wastewater surveillance is a form of environmental surveillance which has several advantages which have already been discussed, and it really gives you a snapshot of community health and is cost effective versus sampling individuals. And it can be an early predictor of outbreaks as well as can identify many emerging threats. And this is a picture which basically shows you the correlation of clinical cases of SARS coronavirus 2 and the viral load in wastewater samples from Hyderabad over a 2.5-year period. You can see a very tight correlation between the two, as well as in March of 2023, when there was decreased or minimal clinical testing, we could see high loads of the virus in wastewater, showing the potential of such surveillance to detect silent waves. And through whole genome sequencing, we could identify various variants, the Omicron variants, over another 3-year period, and it really was very helpful to detect the virus in wastewater when no clinical testing was being performed. These are a large number of sites that we have established all across India. We work in 9 cities, and we have sequenced a large number of wastewater samples, sequences of which have been deposited in a repository which can be used for further research beyond APSI, the Alliance for Pathogen Surveillance Innovations, which is the program here. We have been able to form very robust, easy to understand protocols which have been submitted to the National Centers for Disease Control, which is the backbone of disease surveillance in India, and it is very happy to state that they have been utilized for developing a national guidelines document for environmental surveillance in India. And they are freely accessible on our website. And another component of this program was development of indigenous environmental surveillance kits, low cost, easy to use, quantitative multiplex kits which can detect multiple pathogens from one sample that can be tested to detect the verified across thousands and work very nicely in detecting environmental pathogens. We have sufficient funds for the development through a partnership with
now spearheading a new initiative, HOOPS, Proactive One Health Outbreak Prevention. Leveraging metagenomic surveillance of community animal waste water to broaden the detection scopes and accelerate response time to the One Health framework. And I invite co-moderator Karen to the stage. Am I audible? Great. We have country case stories and representation, and we have regional representation. And I would like to start with presentation. Question to you, Vincent, will be that based on Asia's PGI existing country agreement for West integration, what are the key system elements that have been identified that is essential for West integration?
Thanks very much, Dr. Angela. Before I address these very important questions, I would like to thank the organizer for inviting us on behalf of Asia Pathogen Genomic Initiative, as well as Center for Outbreak Preparedness within the Duke NUS Medical School. Very, very privileged to be part of these discussions. And thanks everyone for joining us for this panel discussion as well. So with that, based on our Asia Pathogen Genomic Initiative countries engagements activities so far, as a context, we are very thankful to Gates Foundation for providing us, support to engage country partners in Asia to enhance, expand, as well as empower them to integrate beyond, what they have done, either for SARS-CoV-2 pandemic wastewater surveillance work, as well as polio surveillance work. With those experiences that we have gained by supporting and co-organizing some of the workshops with them, we have learned there are at least 3 key system elements that are very important for not just implementation, but institutionalization and integration of wastewater surveillance into their national surveillance systems. And in short, I would like to offer these 3 key elements with 3 C's. First is communications, and then collaborations, and third is commitment. So I'll start off with the first in terms of communications. We have learned from those engagement activities that communications remains limited within some of these multi-sectorial required initiative of implementing and integrating wastewater surveillance into the national surveillance systems. And I think that there are a couple of reasons why there are still a number of challenges to communicate effectively between cross-sectorial approach organizations. They are very important for integrating and sustaining wastewater surveillance into the national surveillance systems. Either they can be too overwhelmed with their existing work, that wastewater surveillance is something that is actually very new to them still, that they are not part of before, even during pandemic, or they are already kind of like back to their key objective of looking at their organization's requirements for their preparedness work besides wastewater surveillance. So I think there are many other conflicting interests with regards to trying to advocate for wastewater surveillance into the national surveillance system. So I think to enhance the risk communications of between the stakeholders, there's a need to have regular engagements between one another, And I think with that, there's also a need to have these risk communication strategies by having, what we know, what we have learned so far using wastewater surveillance, the value of how it helps to relate and inform public health actions needs to be effectively also translated down to the community levels as well, to the community leaders, stakeholders, NGOs, who can actually do their part in some way or another to engage, a more confident community to adopt wastewater surveillance as part of the overall integration of wastewater surveillance system into the national surveillance system. So that's for communications. So in terms of collaborations, we are very mindful, and we learn from the workshops that we have co-organized and co-contributed, is that there are still always some missing stakeholders that we learn during the workshop that we have forgotten to invite or we actually miss out to invite. And upon hearing the workshop that we are organizing, some of these stakeholders are actually very proactive. They want to be part of it. And I think that's great. And I think we need to have this adoption of culture of inclusive collaborations. And I think that we also learned that there's a need to have a standardized checklist of who are the stakeholders in the respective country that we know will be able to contribute in one way or another, in the integration of these wastewater surveillance into the national surveillance system. And it's not just about Ministry of Health authorities, Ministry of Environment authorities. It could be also, academics. It could be Ministry of Water, Agriculture. It could be Ministry of Trade and Environment as well. So there are actually many other, organizations and entities beyond ministries that we need to know, and we need to find out who they are and how they can actually contribute in one way or another to the implementation and institutionalization of wastewater surveillance as part of the national surveillance system. So for my last point about the commitment, we learned that commitment sometimes don't last. What we need to build is a sustainable commitment. And the question is, so the question that we always ask ourselves during the workshop is, how do we sustain a lot of this commitment among stakeholders? You can form multiple consortium within the country, nationally, subnationally, and even down the district level. But I think the key question about forming sustainable commitment, it needs to be efficient as well, right? So we need to be very targeted. We need to prioritize pathogens. We need to prioritize at-risk groups, for example, neglected populations. And how do we define neglected populations? Is it populations that are having less accessibility to healthcare systems, less accessibility to medical care support, financial systems, populations which are less active towards health-seeking behavior? So we need to define all these as priorities to be very targeted and efficient to maintain the commitment of stakeholders. We can't do everything at one go. So we have learned that in the process of engaging the different stakeholders, as a group, we are all champions towards implementing institutionalization as well as integration of wastewater surveillance system. But we need to be very clear on our small baby steps with very clear public health outcomes. Is it to inform vaccination strategies, as Dr. Angela and Dr. Karen has mentioned earlier? We need to be very targeted in our immunization programs with very limited stockpile of vaccines. So what is the public health outcomes that we want to achieve, and what are the at-risk population or subpopulation at different at-risk geographical locations we want to help? I think we need to be very, very, we need to spend more time in strategizing our, thoughts and plans with limited resources. So I'll just end here for now. Thanks.
Thanks, Vincent. You spoke about sustained commitment. And one of the places that I have seen sustained commitment is actually the state of Gujarat. So Madhavi, why don't you jump right into that and talk about how that sustained commitment, how you've ensured that sustained commitment and some of the key enablers of your work. And if you could just introduce your work as well to the audience.
Yeah, thank you so much, Angela. And first of all, I would say that this is the World Health Summit. And having a panel discussion where, the people with a room full of audience discussing about the wastewater surveillance, how it can complement the public health action, that itself speaks about the global interest on this particular topic. Now, coming back to Gujarat's story, so basically I come from a state government research organization, which is based out of Gandhinagar, Gujarat. And the key, the task that we are given by the state government is to work on the societal challenges and provide solutions using biotechnology. So, incidentally, the institute operationalized in 2017, and we were just setting up the labs and all those things. And then in 2019, the pandemic came. And being a genomics-driven institute, we were all in for doing genomic surveillance, establishing RT-PCR assays, understanding the host pathogen interactions, everything except for environmental surveillance. And we didn't knew that such things also existed, right? So one of our colleague at IIT Gandhinagar, like he was so persuasive to do the wastewater surveillance for COVID, and these are the times, it doesn't feel like a constraint, but getting, the RT-PCR kits were also constrained. I'm talking about 2020, somewhere in June 2020. And then, somehow we managed to do a couple of samples, and we could see a very good lead of 14 days of early warning. And that's how, the story started. And we have been continuing since September 2020 till date. The main reason for sustenance, I would say, in case of Gujarat is because, you are able to demonstrate to a policymaker that this tool is effective. It has given some results. And just to cite you a very small example here, that every week we used to have a meeting at the level of Chief Minister to understand the pandemic situation and what are the measures that we should be taking and all those stuff. And every time, so this is post-Omicron, there were many waves that we have seen like XBB and other. And every time, there will be a rise in the clinical cases, and then, the health department would say that, okay, now we should reimpose social distance or reimpose making the mask compulsory in public places and stuff like that. Not less than the chief minister would ask that, what is the situation in wastewater? And if that situation is not very alarming, he would take decisions accordingly. So this was a very good use case, I would say, where because we were able to demonstrate that this can help in taking public health actions, we were able to sustain for COVID. But now, since we are out of the pandemic, really it's a time, Angela, to think that beyond SARS-CoV-2, I think as the WHO mentioned about for other pathogens, we have to really work hard together for understanding and making this environmental surveillance sustainable for other emerging epidemics which are not going to go away. They are there, and every time they are coming, and if we are able to gather intelligence for that, so that would be very useful. So maybe I'll just wrap up with one thing, that now the state government of Gujarat has started a surveillance where in the past 1 year, we have a baseline data of 25 locations of the wastewater network in 4 major cities, where we have surveyed them for all major viruses, bacteria, microeukaryotes, fungi, and pollutants. And I'm very happy to share at this platform that these activity will now also be continued in INSACOG phase 3.0. So I hope, I've given you a comprehensive answer on sustainability.
Thanks, Madhavi. I'll go over to Patipat. And you have a social enterprise and you're working on environmental surveillance with animals. Can you tell us about it and also share similarly what are some of the enablers of your work in Thailand?
Thank you very much, and thank you everyone for joining this session, especially like those who invited me to in this room. I'm very honored. My name is Patipat from Thailand, and my background is in engineering. But later I got public health degree, and also my goal is to hopefully stop the next pandemic before it starts. So we have been doing this through the mechanism of social enterprise called Open Dream in Thailand, and we try to work from bottom-up approach to enable the farmers to be disease detectives, because our hypothesis is if we can reduce the logistic and make the detection and response everything in the community level, it can reduce the time to detect, the health threat, and also time to respond to that particular health threat. And from the data, it shows that we can do that. So basically, we make the villagers, the farmers, to be the data collector They help us collect data. Previously, we have done that to the event-based surveillance. So we built a system that can report any observable symptoms of the human-animals interface in animals in backyard farms. And we built a system to help them do risk analysis and also send them preliminary guidance on what action they could do, like the farmers could do to reduce the risk of spreading of that sickness or spillover event. But later, we found out just by doing that, we reduced time to detection from traditionally in Thailand, it would take around 2 or 3 weeks to detect event in the community level. But with this approach, it can reduce to like at least 12 hours to detect the event. And for time to respond, traditionally in Thailand, it's never happened, like infinite or like many months. But with this approach, it can reduce time to respond to maximum 7 days. So from this we can hopefully like reduce the rate of epidemic curve and stop the pandemic at the community level. But later we challenge ourselves, like what would be the way to speed that up like even faster. And we have learned from some research and like, wastewater. Because like it shows that you can detect the pathogen of interest in wastewater weeks before the clinical symptom shows. So we tested that started from last year, and we think that, by the way, it's called POOPS, like Proactive One Health Outbreak Prevention System, POOPS. Thank you, Angela, for spelling that out. I was very nervous saying POOPS on the stage. So we still looking into the human-animal interface, but instead of like taking picture of sick animal or sick poultry, we asked the farmer to collect poops, to scoop the poop for us, and the poop came from animal pens. And like we try from various locations, like from the pen itself, from the drainage system, and like from the reservoir, and we found that we have detected signals of pathogen along those poop pathway, and once we know that work, we are now in the phase. It's very early stage, but we are now building the response mechanism. So basically, as I mentioned earlier, we want to turn the farmers into disease detective. That means they can collect data and take action on their own. We are building the similar protocol for that. That's once they scoop the poop, they know the result. We give them preliminary guidance on what to do. And also we work with local communities, local government, in terms of if they want additional response or resources, they can like work with local government to pool that resources and help them respond better. So, but sadly, we say it's like we are proactively One Health, but actually we are just like 2/3 health, because it's just human-centric animal. Human-animal interface. We still lack of environmental interface, and that's really challenging, because like no one cares about environment, right? And so like we talk about climate change, we talk about carbon footprint and all of this, but it's in the way it's really hard to grasp the idea on like why environmental health is important, and I think that's also one of the contributing factor on the sustainability, on like when people don't care, even the farmers doesn't care. So how can we build on that? And that's like the quick capture of what we have been doing. Thank you.
Thanks, Patipat. So it's summer season, and there are typhoid cases coming to the fore. your work on typhoid, if you could share with the audience and tell us how it's informed public health action.
Thank you, Angela, for the question, and thank you for having me. So my context is slightly different from the speakers who spoke before me. I am a microbiologist. I work in a private non-medical medical school in South India. So our concerns, our focus of research are very, very local. We don't have the scope to go beyond our district even. So the reason we got into wastewater surveillance was for the specific case of typhoid. So I work in an enteric diseases lab. We have carried out wastewater surveillance much earlier for rotavirus and other enteric diseases. In 2015 to 2017, there was a surveillance for enteric fever in India, and CMC Vellore led it. It was in 3 places in India: in Vellore, in Pune, and Delhi. And we found, much to our surprise, that Vellore had a incidence of 1,173 per 100,000 child years. So this was kind of stunning. So we knew that we had to do something for our community. So we wanted to implement the typhoid TCV vaccine over there, and we wanted to convince the government to adopt that in the immunization program. So that is how this all started. The other thing we learned that in order to do this, clinical surveillance for typhoid is very, very expensive. It is forbidding. I mean, we had support from the Gates Foundation, but if you want to adopt it all over India in small towns, it's not going to be feasible. You cannot set up. People think of PCR as very high tech, but PCR is basically an old technology in 1980s. Blood culture is much more harder to do. So then we thought, okay, what are the other methods? So we went into zero incidence. And the other methodology that we tried was wastewater surveillance. And we started implementing wastewater surveillance just before the pandemic. And when you compare wastewater surveillance for viruses are much more easier to do. We started out with SARS-CoV-2 because the funding was there for SARS-CoV-2. For bacteria, the problem is, it's the same problem as with bacteria, detecting typhoid bacterium in the blood, right? Even at the height of enteric fever, you only have 1 bacteria per ml of blood. So we had to devise methods. We had to find out ways, even in the wastewater, how to concentrate the wastewater effectively, and how to process it effectively, and finally how to detect it. Again, for viruses, for PCR, you can have 1 or 2 targets, and that's it. For Salmonella typhi, all the targets that we have, they cross-react with other Salmonella. I mean, typhi is weird. It's not even a species. It's like a serovar of a subspecies. Microbiologists will know what I'm talking about. So all the targets that we use will cross-react with other organisms in the wastewater. So we had to define what do you mean by a positive sample, and we needed to validate it by clinical surveillance, and also by doing detection of bacteriophages for Salmonella typhi. Currently in Vellore, there is a typhoid TCV cluster randomized trial going on, in which it is blinded, but we have divided the demographic health surveillance system in multiple clusters, and there's a separate team doing that. So we thought this would be a great opportunity to do parallel wastewater surveillance to demonstrate the effectiveness, and our results are very, very encouraging. In 2023, we had a huge outbreak of typhoid in the study area, and the wastewater surveillance kind of mimicked the clinical surveillance almost 1:1, right? And in June of 2023, we implemented the typhoid TCV vaccine, and immediately both the cases of clinical surveillance of the clinical cases and the wastewater surveillance came down. So 1 year since, we had very less cases of typhoid in the community, and also the detection was very, very less. After 1 year, I think the effects of the vaccine, the herd immunity is waning, and we are seeing a similar increase in cases and wastewater detection. So we know that there is we can detect it in the wastewater, and we know there's a correlation. Now, the outstanding question is, how do we use it? I would just like to complete by just saying this. Let's say people talked about SARS-CoV-2, wastewater surveillance of SARS-CoV-2. If you see a rise of case detection of SARS-CoV-2 in the wastewater, you can ideally predict that in the next 5 days you will have an increase of number of cases in that particular catchment population. That is not the case for typhoid, right? If you see an increase of typhoid, that means you probably had an outbreak of typhoid some 2 or 3 weeks back. So I would like to say, instead of, I think people think of wastewater surveillance as something it's in a one box, but it's not the case. You need to understand the disease, you need to understand the context and the sample. I mean, wastewater surveillance from wastewater is not the same as from river water that is contaminated with waste. I'll end there. Thank you.
Thanks, Dilip. So you brought an important point. It's not just wastewater, there's also other waters where waste can go into. And I know right in the beginning we took a quick poll, and now we have a slightly different room and more people on how many people folks are involved in water surveillance. I'm going to expand the scope a little bit from wastewater to water surveillance. Water may also have waste. If you could raise your hands, because one of the objectives of this was to share practical examples of water surveillance for pathogens. You have one. Could you share very quickly what your experience has been?
Oh, thanks. Yeah, we surveil lake waters. So we have a whole system of lakes that kind of, you fill up the lake at the very top of a hill, and all the lakes underneath.
Sorry, if you could introduce yourself.
Sure, sorry guys. I'm Varsha Sridhar from Molecular Solutions. And a lot of the work that we did about 2 years ago, starting from 2022 to about 2023, with the Catalyst group and a part of Swasti group, we looked at lake waters and saw if there was a corresponding decrease in antibiotic levels and pollutant levels. If the lake at the very top of a hill was very polluted, do you actually see reduction and sort of further purification as the water goes down through the gravitational gradient? Yeah. So.
Thank you. And the second objective is translating these successful experiences into actionable policies that support the broader adoption of WES as a core component. Now, we heard stories, really lovely, interesting stories, and how your programs have evolved. We've heard about the enablers that have kept you going. And we heard a little bit of future directions. But if you could speak about the challenges and perhaps the failures, because that's probably what is getting in the way of integrating WES. And we do have a proclaimed cynic in the room, and we may have a few more. So I'm going to open the space to you guys first to ask the questions, and I'm going to invite the panelists to take those answers. 1, 2, 3. Please introduce yourself first.
Hi, good morning. I'm Dr. O.P. Kansal. I'm in World Bank here in Delhi. And this topic is very pertinent to us also because for the last 6 months or so, we have been discussing into wastewater surveillance. Specifically, to the context which I think the next round of question can go to the panelists is the support that probably we may require is that in India under NCDC, there are 20 metropolitan surveillance units under establishment, and one of them is in Ahmedabad, if I remember. And so in that, one of the to-dos that has been given to these metropolitan surveillance units is to see that how can we integrate wastewater surveillance into their routine work, because ultimately they are the surveillance units, and so as we learning, the role is there. The second part is, I think, if some of the speakers can also let me know during their, when we talk to the policy makers, how do we convince them about the cost effectiveness of this? Everyone would like to see that, because as he rightly mentioned, Patipat, that no one talks about environment. So how do we convince in terms of the cost effectiveness as well? Because putting money into environmental surveillance is a big decision that a government will take. Over.
We'll take all the questions first.
Good morning, everyone. Myself, Dr. Nupur, and I'm working as Surveillance Medical Officer in the NPSP project of WHO. So whenever there is a case of Sabine-like virus which is isolated in the environmental sampling, so we get notified for initiating the public health interventions at the ground level. So my question is related to the point which was mentioned in the presentation, that the absence of virus in the environmental sampling does not necessarily signify the absence of transmission in the community. So I want to know what are the factors that can contribute to the non-detection of the virus in the environmental sampling. So thank you.
We'll take 2 more questions, and then maybe panelists can...
Hello everyone, I am Dr. Dheeraj Agarwal from KM Hospital Research Center, Pune. We are not into this environmental sampling, but we are thinking on this line to get entered into it. So I want to understand, as per my understanding, all these sampling sites are morely concentrated in urban areas or semi-urban areas. But do we have a rural sites also for such kind of sampling. Second thing, we have a health and demographic surveillance system where we follow specific population from last 20 years. What if we club this kind of surveillance along with the health and demographic surveillance system? Will it give us the new insights into this science? Thank you.
The last question before we go to the panelists.
Yeah, my name is Gautam Menon. I work at Ashoka University as an epidemiologist. So my question is that when you do surveillance in STPs, for example, sewer treatment plants as one indicator within a city, and there's work in Bangalore on it, you do need to understand the hydrology locally to figure out where the input to the STP is coming from. This information is usually very hard to get. It's usually, these are very old lines, they're broken in various places. But it's essential if you want to translate what you see in an environmental surveillance into any type of public policy that can be localized across the city. So this calls for a certain relationship with a completely different ministry in the city. I just wondered to what extent we need to think about these questions as well, larger questions of governance.
Great. And I'm going to hand over to the panelists. We also have Dr. Aruna and Dr. Varsha in the group. So if there is any of the questions that you would want to answer, just indicate to me and I'll hand back to you. You want to go first? Yeah.
Yeah, I'm happy to take the technical questions that were asked because we have been, yeah, yeah, I'll try. So we have been thinking about much of the same questions that you were asking, like, number one, what contributes to non-detection of a virus? See, we mainly detect, the main thing that we do is qPCR, right? So the main issue that can lead to non-detection is, number one, the yield of the bacteria is not enough in the wastewater. Suppose the example that we suppose a dog is swimming in a swimming pool. If we sample the water, we'll get dog DNA, right? You need to sample the place. So that's one basic common sense answer. The second one is inhibition. Inhibition of qPCR because of the sample matrix. It's not a clean sample. There are many things that will interfere with PCR. So that contributes to non-detection. So you need to design your sampling method that way. The next question is urban versus rural. Happy to see you, Dheeraj. We also have a DHSS, and we link the wastewater surveillance with the DHSS. And one of the most important thing that ties into the last question also, that the initiation part of the study was trying to exactly map the drainage of the wastewater channel to the households. So we had people walk along these drainage channels, trying to figure out which household drains into which, and so like that we're able to derive catchment populations for each drainage channel. So that's what we do. Yeah. And I think that's it.
Yeah, thank you. Madhavi, you wanted to answer a question.
So I'll maybe start answering your first questions. That is regarding one was cost effectiveness, and then how do you communicate or convince policymakers to do integration of this work. So we have faced many challenges. While I say the rosy picture that it is all good in Gujarat, but there were times where because of some media miscommunications, there was some chaos in the public during the time of pandemic, that in Sabarmati river COVID virus was floating as if, it was there in air, so duty bound to be in water, no big deal. So one thing is the cost effectiveness. Otherwise, when you are doing clinical surveillance, you are doing both the zones that are not susceptible versus the actual clinical cases. And that means you're talking about doing surveillance of an individuals, which is anyway combined at a community scale is going to be much higher than when you have only few strategic sampling points across cities where you are doing wastewater surveillance. So that is one part of the cost effectiveness. Second is, you heard Aruna also talking about that we are developing a lot of indigenous kits and methods and protocols, and they are validated in Indian settings, and they work well for not only our lab but the labs across our collaborators in the country. So if I may say so, that the costing is not very high, even if you are talking about a targeted surveillance of environment. One must know what you are looking at, because I think everybody thinks that all the answers are in wastewater, but it is not. Technically, any vector-borne pathogens, you cannot do surveillance with wastewater, specifically even avian influenza. we cannot get good results with simply by doing the wastewater surveillance. We need to have different environmental surveillance means in practice. Second thing is to policymakers. As far as I have interacted with different policymakers, and partly it will answer the question which was asked by the different departments getting engaged and who would take a lead. So technically, if you are talking about urban settings, these are the municipalities that are on forefront, right? And they are willing to take up these things. But they need a lot of hand-holding and, to translate from lab to actual regular surveillance, there is still a long way to go. And we need to walk this step by step so that, we are able to achieve it. So far, health departments are convinced that, these are good tools. That it can give us good results. But if you even look at the infrastructure, the way we are spread in states and districts or in major cities, there are multi-stakeholders that we need to, taken into account. And many at times the decision makers for the state are different and the decision makers at the local bodies are different. And you will have to take both of them hand in hand in order to achieve what we are trying to actually, get into. Yeah.
Thanks, Madhavi. Vincent, do you want to chime in?
Yeah. Thanks very much for the very useful and highly relevant questions that you have provided. Maybe just to share a few points to address those questions. One is actually, as I mentioned, the importance of multi-sectorial as well as multidisciplinary approach towards integrating wastewater surveillance into the national surveillance systems. And I must say that, through our Asia Pathogen Genomic Initiative effort to empower country partners to expand and sustain and institutionalize wastewater surveillance into their national surveillance systems, we learn the process and the challenges of integrating multidisciplinary approach. It sounds easy to do that, but it's actually quite challenging on the ground. First of all, is, as I mentioned earlier, the lack of awareness. Who should be involved? Who can contribute much effectively? And I think it's very important that we must recognize that on the ground, issues such as simple issues like the mapping of the sewage pipings or the mappings of the flow of the rivers with potential biomass contributed from neighborhoods, residential nearbys, and including some of the specific sites of where potential chemical discharges from pharmaceutical companies, chemical industries are also equally important to be mindful about, where are the sampling sites that needs to be avoided, because we know that some of the samples collected from some of these areas tend to have very poor integrity of the samples that will not allow you to detect a lot of the pathogens that you're interested to look at. So I think it's very mindful that we do, as part of our contributions to the country support, we always recommend them to invest some time, some resources to do all these mapping very thoroughly as much as possible, so that we can then translate some of the wastewater surveillance data that we ultimately discovered or monitored can be translated to how to improve the public health in those regions that are contributing to the biomass in the river waters especially. Because we are not talking about sewage piping anymore. It's all about open water sources. And I think it's also quite important to understand how is the rainfall season is like to interpret our wastewater surveillance data. Because dilution factor is something that is actually very real. It can happen naturally, and it's important to understand how much of how much of multiplication factors that we need to be included, to be considered as whether the sample is important for us to interpret or not, or should we just not sample with caution. So I think with that, I think it's important to have this multidisciplinary approach to do the mapping with authorities from the water as well as the treatment plants. Just to share, every time when we co-organize a workshop, we always have this practice of having site visits to the water treatment plants and also the potential sampling sites of where the open rivers or water body sources are, so that to really understand and appreciate the ground challenges. And I think based on our discussion so far, in terms of what would be the best way to convince stakeholders to be part of this discussion, this movement, this journey with every one of us, is that we have to use very simple, successful use case of polio and SARS-CoV-2 that we have, implemented so far. And I think based on our engagement with some of the countries, they are really using that as a case study to evaluate the cost effectiveness of how wastewater surveillance can actually augment immunization strategies. And they have shown that, based on a number of reports, including from WHO report, immunization is actually the best buy, with return of investment of at least US dollars, $54, for every dollar invested in immunization. And therefore, with the supplementation of wastewater surveillance to target potentially blind spots of at-risk populations or blind spots of geographical locations where healthcare facilities are actually not as robust, we can definitely and increase the return on investment to more than US dollars or $55, in addition to how immunization strategies has been implemented so far. So I think there's a good case and a good simple strategies of us using the vaccine preventable diseases, as a good start to convince stakeholders that with the targeted approach of immunizations using wastewater surveillance data, we can definitely reduce public health burden and the need to increase healthcare costs for treatment and mitigations. So hopefully that helps in some way.
Thanks, Vincent. Yeah. And that noise there was our alarm. So we're not going to take more questions, but understand that one of our objectives is to really see what policies might enable the mainstreaming of wastewater and environmental surveillance into mainstream surveillance. So from Patipat onwards to Madhavi, and then I'm going to open the floor. What is that one policy that might enable that in your setting?
Thank you very much. I think I'm from bottom-up approach people. So I think the policy would be allowing civic movement to participate in this health-related, especially like disease surveillance. Currently in Thailand, at least, it's controlled by the Ministry of Public Health, which is like disease surveillance. Anyone from Thailand? No, okay. Their priorities is not disease surveillance. I'm not supposed to talk bad about my country's government, but their priority is like last government was like decriminalize marijuana, which is like, oh wow. So I think from the other civic movement, let's say from like democratic civic movement, if the government allows this civic movement in disease surveillance, so like they allow the local government to start this by their own without the centralized government approval, I think that would help a lot on democratize how can we stop the next pandemic.
Yeah, Indians have no problem talking bad about their country. But seriously, I think if you are serious about convincing public health authorities to take this up, what you need to have an answer from a microbiologist perspective is like, what do you do in the what do you do in the case of a positive signal? Like even for polio, we know what you do. The GPI has clear guidelines. What do you do in case of SARS-CoV-2? Do you overreact? Do you shut everything down? And what do you do in the case of typhoid? Right? I think that's the most important. Is okay. Is wastewater surveillance a replacement, a supplement, or a complement to clinical surveillance? I think that is the right way to think about this.
Sure. Maybe I just add something new in the sense that in terms of the change in policy, I think the biggest wish that we wanted to advocate for is also the change in the way how we can do innovations. with some of these wastewater surveillance data that we potentially may generate. I think it's very important to innovate in the sense of how we can translate this wastewater surveillance data into policies. And one activities that we are currently working on now is actually looking at how to make use of the concept of artificial intelligence to learn, from the data we have collected, to do some form of forecasting, and to allow us to understand what would be the best estimate of the characteristic of a novel pathogens that we are able to determine, potentially based on pathogen genomics data that we can potentially collect from wastewater to understand what will be the potential risk of these novel pathogens, especially coming out from potential zoonotic spillover at animal and human interface. I think that's something that is quite of our foresight in terms of understanding the need for technology, the need to embrace technology to enhance how we can make use of wastewater surveillance data to influence policy. Thanks.
In the interest of time, I would just say one thing, that is establishing stronger use cases. So far, we have got polio as a use case, SARS-CoV-2 as a use case, as many use cases as we establish, that will automatically convince, the policymakers to take these activities into mainstream and make them going it regularly.
Thanks, Madam. May I invite Dr. Aruna to also share what might be that one policy action that you wish for?
One policy action. So we've been really reaching out, like I mentioned in my talk, to various key stakeholders, and we would really wish the NCDC, which is the main surveillance unit in India, to work together and move forward that guideline documents, which would basically integrate their current surveillance technologies with ours. And I think that would be the one policy we were looking forward to. And just a very quick thing about that cost effectiveness. We've been working with the Indian School of Business in Hyderabad, and we've come up with a model which really shows that for a fraction of the overall healthcare budget of India, less than 1%, we can successfully implement these wastewater surveillance program, which would really be very effective in reducing disease burden. Thank you.
Introducing Dr. Varsha Sridhar, who's also a co-lead of Precision Platform, to summarize 3 key learnings what you got out of this discussion.
Sure, thank you so much. And I really enjoyed the insights given by all of you. I'll quickly summarize it just so that all of us are on the same page. Karen, from your talk, I loved the things about standardization of protocols. Aruna on indigenous kits and protocols and context-specific, local developed protocols. 3 C's from Vincent. 3 C's in action from Madhavi, and the establishment of use cases which actually denote those 3 C's. I loved your thing about citizen science and the point that you brought about the medical guilds that kind of control disease surveillance. And I do agree with you that I think we need to move past just health professionals being part of these guilds which are controlling disease and health. And I do think it has to be opened up. And that is, I think, my point number 1 that I learned. Dr. Dilip, from you about typhoid and how that actually relates to vaccination, and that I think that's another beautiful use case. Actually, my second point actually had to respond to you about financing and return of interest in environmental, not surveillance. I think what I heard from Patipat was looking at how do we actually improve environment and how do we make this truly something that we can all enjoy and value. And one of the things that we had learned about, and this came from the director of environment in Uttar Pradesh when we were working in the Namami Gange. One thing I want to point out over here is that while we talk about open drains in India and other LMICs as sort of separate from rivers and lakes, honestly, most of our rivers are open drains. So when you go around testing for the open drains, we have to remember that they automatically flow into lakes, they automatically go into our food as well through agricultural systems. So there is really no difference. So in the Namami Gange project, when we were talking about how we could perhaps use environmental surveillance as a way to improve, typhoid and gastrointestinal diseases, what he said was, what we really need to do more than anything else is to actually nudge the industry from sunset industries such as leather and polluting industries to more sunrise industries, which are actually towards perhaps tourism. How do you actually encourage people to help your river dolphins thrive better? And finally, I think I want to add the last part, which is about the interdisciplinary point that Dr. Menon brought about. It's not just about health, it's about hydrology, it's about engineering. A lot of the cholera outbreaks that happen in places like, in a lot of places in South India, actually have to happen because of poor engineering of water pipes. So when you have intermittent water being thrown, there are cracks in the pipes, you have the sewage pipes on top of the drinking water pipes, and that's basically why you're this thing. So I completely agree with you that you cannot separate health from infrastructure and urban development and urban planning. So these are the 3 points.
Thank you. We have Eloise Todd in the room, our second intervener. She's the Executive Director of Pandemic Action Network. And PAN has been very instrumental in keeping pandemic action and preparedness on the global agendas. So over to you on what you feel would further the work of preventing pandemic and what you heard here today.
Thank you so much, and it's a real honor to be here. I think my overall reaction is what an amazing story. What an amazing set of data. 1, 2. Hello. Hear me now? Yeah. And for me, this is a really great way in for pandemic PPR in general, because sometimes with this very broad issue of pandemic prevention, preparedness and response, which is even difficult to say, it's hard to bring it to life. And as we heard at the beginning, everybody poops. Had to get it out there. And this is such a leveler and so intuitive. I loved those graphs, the graphs showing these spikes and how unbelievable data we have to take to policymakers. What a great kind of thing to put the evidence in front of them and show them. When we were hearing about the 3 Cs from Patipat about the collaborators, let's make sure there are advocates in the room. I feel really passionately that, even those of us that aren't scientists or engineers, but really want to connect the dots, let's sort of empower those people with as much access to expertise and experts as possible to do that. And then I think, hearing from Karen about the real-time nature of this and the complementarity, those things really stuck out for me as well. Because in this era of diminishing resources all round for health in general, things are really in turmoil in many ways. So that idea that we can be systemic in our approach and do this in a way that really complements what is already going on is an absolute game changer in terms of being able to sell this in to ministries and ministers and politicians. And that part about the minister saying, what does the wastewater say? I thought that is one of the biggest advocacy wins I've ever heard. When you get to the point where the minister is saying, what does the wastewater say? That's when you've got this. So in my mind, how can we get ministers of health, but also ministers of finance everywhere asking that question and understanding what their costs of inaction might be for not doing this? It seems like an absolute no-brainer. And I'm quite excited to take all of that information that you've provided and think about how we can integrate that to tell the story of wastewater surveillance and pandemic prevention more generally. So huge thank you to everybody for all of the work that you do. Just trying to look at my notes to see what else I might have missed. Yeah, I think the other things that really stuck out, that 12 hours to detection piece, and then 7 to 14-day lead times, but also the sort of caution that you have to be very careful about which disease, which sample, which approach, so that nuance being important as well, and that education point. And yeah, education and communication, until we have solutions and treatments and vaccines for every disease, communication is our best tool in trying to make change happen. So I think hopefully that's where we can all work together and really sell in wastewater surveillance. I'm so proud to have been part of this brilliant panel. Thank you all for your brilliant work. Thank you.
Thanks, Eloise. I'd like to thank the panelists for sharing their stories and challenges. And I really hope that the audience got some practical case stories from successful examples, some challenges, and I'm hoping that you're all advocates of looking at a cost-efficient, that's been repeating here, cost-efficient, cost-effective signaling technique that can add and complement the current surveillance activities. And thank you for staying and for your engagement. Thank you. Can I call the interveners as well for a group picture? Thanks. And Dr. Aruna, please come.
Check. We are the managing team. Hello, hello. Check, check. Check. Check, 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 check. check, check, check.
So Cal introduced it, so not a big deal. Joy is also in this session. So but Joy Manan is also in this session. तो जो पाथ में जो लिस्ट बनाई उसमें नहीं था thankfully उन्हें खुद ही मुझे याद लगा he is a cool guy told him कि वोट नहीं बढ़ा लेगा Roy is again very relaxed. Sensitive people. So Karthik is very unlike typical IAS. I'm just trying to find out. Exactly this in the context of your previous experiment using AI for breast cancer survival. And I can really see, and maybe with your other work in other areas, because trust is a critical issue with HIV. So cancer is not that kind of a diagnosis, but problems could come. So here I could refer to your previous experience with HIV, where trust is a massive problem. So what do you think about it?
And also, I'm also a cancer patient. So I'm going to add a little bit of personal touch to that if that is fine with you.
We have plenty of time in this session.
आप आइए फिर
It's already on. Hello. So I think we have reached that critical mass when the number of audience is greater than the number of panelists. So with that done, I'll simply invite, without individual introductions right now, invite all the panelists. You all know who you are. And Joy, you are here. So we are missing one small marker. But please, Karthik, Joy, Dr. Chaturvedi, and I am looking for people whom I know are here but maybe are having coffee. That's always a possibility. Dr. Manju. Okay, there are always two check marks. Audience is greater than the number of panelists and all the panelists are in the room. So perhaps they are waiting for, but let me start by introducing the people who have already taken their seats. And that I think will be a very simple, short introduction. Many of them are very, very well-known names. I will start in the order that I see them. And Dr. Joy Mammon, CMC Vellore, one of the most data science, digital, oncology, scale-oriented people from a center that has been electronic since the 90s. And with an amazing story that a plastic surgeon built the electronic health record many years ago, showing that surgeons do more than just operate. Then of course, Manju is here. Many of you might have heard of the National Cancer Grid already and the Quetta Center for Digital Oncology. And at Tata Memorial, those efforts are largely led by Manju's team. And this again is an effort to create a large platform with large amounts of digital data so that we can move to the next generation with AI and digital tools being used to improve oncology. So it's an absolute pleasure to have you here. Everybody in Delhi, well, hopefully not for personal or family reasons, already knows Dr. Harit Chaturvedi. He is one of the senior most people who pretty much established Max's reputation in cancer care and has been using cutting edge technology of every possible type, including new treatments, everything that comes in the city. I think Dr. Chaudhary is one of the first users in terms of deploying it. And to balance this, we also have Dr. Asha Hegde, who comes from a background that starts with HIV, extends all the way to cancer, because ultimately it's not just a tertiary level problem, it's a primary level problem as well. So it's absolutely wonderful to have you here, and we look forward to hearing more about your experiences in screening for breast cancer, cervical cancer, for public health settings, and you are from PATH, which is known for its great work in public health. Dr. Prashant Mathur will find his way from this maze soon enough. He is the director of NCDR, which is an ICMR institute that maintains the cancer registry for India. And that's a really important topic, as you can imagine. And of course, he is involved in all things to do with disease and informatics. And that is ultimately the purpose of much of what we do. The last person, definitely not the least, Dr. Karthik Adapa, has so many hats, I always wonder which one to introduce them by. For the purpose of today, we will go back to a time when he ran one of the largest cancer screening programs in Punjab. From his point of view as an IAS officer, maintaining the health of the state and trying to figure out how government and innovation can work together and scale. I will just mention his other hat simply for the reason of being complete. He is currently heading digital health for the WHO's Zero region. And of course, he is also, by the way, the third hat, I'll mention it again because it's relevant. He can also be seen in an avatar as a faculty doing health AI at top US universities, where he formally trained in AI. So he can wear a technical hat, a bureaucrat hat, and a global hat at any point in time. Today we will ask him to talk about the region. So with that done, let me just briefly set up the basic ideas of what we'll be talking about before I give almost all the rest of the time to the panel. The key point is, yesterday we had a wonderful talk by Mr. Rizwan Koiter, the Koida Foundation, and also the chairperson of NABH, on how the imagination is, if you can imagine what you want to see in healthcare, you can imagine a digital mirror of the same by which you can see what is happening, and then you can build a recording system that allows you to access the data in the records, to build the digital image, to look at reality, that allows you to simultaneously work on assurance of quality, work on accreditation, but also allows you to research and also allows you to improve care for people. And this is not something that is just generic. It can be thought of in any vertical that stands alone, requires a lot of data, generates a lot of complexity, and what better area than cancer? Not for good reasons. One of the reasons cancer is a particularly good area to do this is because outcomes tend to be on a shorter time scale than many other diseases. We would like to see those outcomes become longer and longer, but the reality is good cancer care versus bad cancer care, effectiveness versus lack of effectiveness, correct diagnosis versus wrong diagnosis tends to occur on a more accelerated time scale in the world of cancer than many other places, which automatically means that people who start leveraging the power of digital will eventually translate this to better outcomes, better efficiencies, and overall better health for the population at a time when cancer is becoming one of the dominant problems of the world. With that said, I'm going to start moving to the panel, and we will start with simply with Dr. Joy Mamin, because he has done this for a long time in a center that was digital from the time he would have started his medical training. And I want him to speak about a few minutes to us about what difference he has seen in how the digital oncology world has been changing and how his experience of digital has helped him across in his cancer care.
Thank you, Dr. Agarwal, for this opportunity and for the organizers for me to be here today. I think coming from an organization which has a long legacy also has its challenges. Challenges which legacy institutions, people from legacy institutions here will also understand. We have been digital for many years, and a lot of that digital transformation has happened sheerly out of necessity. It was trying to take patients at one end and spit them out at the other end with minimum trouble for both parties involved. And of course, we worked from the clinical side first, starting with the usual billing and appointment systems and all the laboratories which came on board. And I think one of the watershed events was the introduction of digital radiology and PAC system in 1998, 1999, which suddenly then brought a desktop computer to practically every workstation. So I see that as a significant process, because prior to that, although we were digital, a lot of the end user experience was still on paper. There was back-end automation and process automation. So bringing in digital radiology, and that was a change where people used to earlier look at X-rays and CT scans at the bedside, to working with digital images, which was a big change for us to adopt and adapt. There was a lot of resistance initially, but however we went through with that process. Subsequently, having a computer at every desktop then became a reality, and more demands were made on the system. So from the year 2000 onwards, we have developed what we call very unimaginatively a clinical workstation, which then enables the physician at the center of care to do many things which are required for that. And it has gradually evolved so that now a lot of the workflow which is connected to the patient happens digitally and electronically. However, there is also a realization over the last few years that this has also ended up with a lot of task shifting to the clinician, to the doctor who's at the end of the process, sitting with a computer, clicking a button to call a patient, doing the clinical work, and then transferring that data into that digital format. And most of us are still seek and ye shall find three-finger typists. So that itself is a challenge. Those interfaces have not changed for us. So that's a big challenge in digitization. And of course, patients are unhappy when the doctor keeps looking at the screen intermittently. And then there is lab ordering, and there is diagnostic processes, e-pharmacy, and all these things are electronic, but finally it's the doctor who's doing this work at the end of it. Earlier it was scroll on a paper, and then somebody else would take care of the downstream operations. So some of it has meant task shifting, which has occupied clinician time and has reduced efficiencies in terms of the time that the clinician actually spends and pays attention to the patient. So we need to rethink some of those very nitty-gritty things and make life easier for our clinicians. The good thing is that there's a lot of clinical data, including narrative outpatient data, which is electronic. A lot of the reports, practically all the reports are electronic, although still natural language. And with the advent of newer technologies, there is hope for us to convert all our natural language into usable data, which can then be used for research in the future. We have extensive imaging, both in terms of radiology and all the ancillary cancer imaging. And we've also introduced whole slide imaging over the last 2 years. So digital pathology is slowly taking off, although there's no economic model around it. We are still struggling with that part of it, but there are opportunities for research and development from there onwards. So we are really excited about these transformational things happening over the last 2 years. I myself head a biomedical informatics unit, which is a virtual unit. I have only one FTE, but we are hopeful that more people will be excited about these changes which are happening, and that we will be places where change can actually come to the ground. That's where transformation happens, I think. And there are many opportunities for that. We seek to position ourselves as testing and implementation centers rather than actually doing development work, which requires different capabilities and different specialties. So I'll stop over there. And I think overcoming silos for us is one of the biggest challenges we've seen between public and private, and then within our own organizations, bringing people together, because cancer care has developed, grown from subspecialties. And so now bringing those subspecialties together, having common data sets, having common interests, having meetings together itself is a big challenge. But we have set out on it, and recently we had a team from NCG from Bombay visiting us, and so we hope that more collaboration and cooperation will go forward. But we completely realize that we cannot be siloed, we cannot be isolated. It is in bringing large groups together to work together is where the benefits are going to come from. Thank you.
I think you spoke the magic words towards the end: common data sets and collaboration. So from an institute that was digital, and other people were still analog, we're going to move to one of the biggest efforts of India in terms of creating the National Cancer Grid.
So Manju, if perhaps we can continue on the theme regarding what are the key transformational aspects from your point of view of the way the NCG is designed. I fully understand that that will not do anything to take away the extra burden being created. In fact, I would probably imagine 100% of the work you do for NCG is an extra burden on your usual clinical care. So that solution is not coming for you anytime soon. But I assume NCG is being done to make sure that the last problems that were being discussed about, the common data sets, easier collaboration, standardization, are taken care of at nation scalable ways. And please tell us your experience and how do you think this will transform oncology in the country?
So just a brief for people who don't know about National Cancer Grid. It's a network of cancer centers, research organizations, and patient groups who are working towards, the cause of cancer in their own capabilities. This concept started in 2012, realizing that there is a lot of fragmentation of care within country as far as cancer is concerned, and we wanted to do something to ensure that there is uniformity, standardization of the cancer care, and therefore, the outcomes are very similar and the access is similar to anyone irrespective of where they are within the country, what their socioeconomic status is. So with that, with 14 centers in 2012, we have grown to now more than 370 member centers. Three main pillars on which we've been working is bringing the uniformity in the care, training people so that we have that gap which is there in terms of manpower is bridged, and the research, multicentric collaborative research. So when we started doing this, we realized one of the biggest challenge in the treatment or in the management of patients with cancer is that they move from center to center. They take part treatment, their diagnosis is done in one part, they move for surgery to other, the chemotherapy, radiation, and finally the palliative care or survivorship, which goes on at different places. And at every point of time, the onus lies on the patient to produce whatever has happened in the previous center, ensure that they have enough information, records available, sometimes even the biopsy blocks available so that the treatment is continued without any interruption. And we realize that there is a lot of missing information which goes in here, which can actually compromise the treatment, can get errors in terms of treatment, and of course that's going to have impact in terms of outcome of the cancer which they have. So we started with a proof of concept to ensure giving ownership of data to patients with a group of people, which is based on consent, so they can go from one center to other center and the data can be shared. We realize in this that most of the records are paper records when they are moving from one center to other center, and how do you do this for paper records? So that's when we started thinking that we need to have electronic medical records. At TMC, we do have electronic medical records, and patients can view their data anywhere from wherever they are in the world. But that's not true for the majority of centers, and that's where we collaborated with Koita Foundation, and that was the genesis of Koita Center for Digital Oncology, trying to look at how we can bring in the digital initiatives to enhance the oncology care. We did a survey of all the centers to figure out how many of them have electronic medical records, and it was less than 15% who had some form of electronic medical records. And therefore, the first initiative which was on priority by most centers was electronic medical records. Now, as Dr. Maman mentioned, our problem is that the tech people built in something and then it's thrust upon the clinicians like us to use it, and that's where there is a constant tussle which comes in, and you don't use these systems. So we decided that we need to have clinical people who are involved in creating and designing the fields as well as how the workflows would be, so that it's an exact replica of what you do in the clinic, with minimum disruption of how you think about your patient. Instead of putting data into fields, it still remains a story which you want to hear or which someone wants to see it when you finish the clinical encounter. Keeping those things in mind, we began with this electronic medical record initiative, had committees looking after the individual clinical aspects, looking at interoperability, because that's one of the bigger things which we want to solve over a period of time. Given that we have between these 370 member centers more than 800,000 new cancer patients being treated annually. So we realize that this data has to be harnessed, and we can harness the data only once it's there in a uniform format. And therefore, we needed these electronic medical record solutions to capture similar kind of data, capture the patient journey longitudinally from screening, diagnosis, till palliative care or survivorship, so that all this is reflected appropriately. What we hope to do is that once we have this interoperable data set, people are willing to share minimum data with the patient consent, we should be able to have real challenge, exposed to us in terms of what is our real burden of cancer, and make policies accordingly, or make treatments, or give out information with respect to what treatment is needed where, what interventions are needed in which areas. So this is something which we have been trying to do from National Cancer Grid with regards to the common data set. There are, of course, other offshoots of this. One of them is ensuring that they have quality care accessible closer to their home. So we are looking at several innovative ways of doing the teleconsultation and making sure that the patients do not need to travel for a long distance, which we typically see as of now. And as we know, once you have this huge data, you can use that data to get any information, whether we talk about all the AI, ML, everything can be run on this. The other challenge is lack of uniformity in terms of reporting the pathology and the radiology, which is, you read a pathology report, you find 5 components missing when it comes from some other center, and now you review it, and it's the same thing which takes 10 days for a patient to, then get the review done, get the complete report. So initiating what we call as synoptic reporting for pathology and radiology, which again will help giving this very crucial data piece for doing subsequent work. So these are some of the initiatives which we are looking at currently.
Well, that's really interesting, because one of the things that came about in yesterday's panel was that if you want to bring data together, that problem you started with, you have to first find a compelling reason why it has to be together, and then sufficient reason that motivates people to work on it. It was very interesting to me that for you, it didn't start with research. It started with ease for patients. And because your purpose was ease of patients, you probably found sufficient motivation and support to do this. And while delivering it, now we are in a process that research will also get easier and better. Dr. Hari Chaturvedi, you have been at Max since the time Max went digital. I know that when Manju was speaking, that particular EHR system wasn't necessarily designed for many of the purposes that we discussed towards the end, but yet it was an early experience. So I want to hear from you in 2 directions. A, did it make any difference in terms of your ease of treating patients better? Of course, from patient's point of view as well as your point of view. And number 2, you've been one of the early adopters of technology. I remember when you came to me when I was heading the Genomics Institute, and we were talking about bringing genomics when nobody else was really talking about it, making it routine. So even if not what is already happening at Max, with your wide experience of what is happening worldwide, please feel free to generalize your answer.
Sure. Thank you very much. Thanks for this opportunity. So first and foremost, I think oncology is the best test case for digital space. And one of the major reasons, while you mentioned about the short-term outcomes will give us the reflection of what is happening, the bigger challenge is that it is no other medical specialty has so many subspecialties, so much of interface with pathology, radiology, molecular oncology, genetics, medical oncology, radiation oncology, surgeons. So we are almost 15, 20 pillars who have to work together to deliver best care. No other space, whether it is nephrology, cardiology, nothing else is like this, parallel to this. So I always mention this, that oncology is the challenge of any specialty many times over. And to deliver that, there's no other platform than digital. To create a language which everybody can understand and analyze. So if I look at what I as a surgeon see is what is happening in the surgical space. Now, most of you might have heard whenever somebody goes through a cancer treatment that whether the MDT happened, whether the tumor board happened, whether this conversation happened within different specialties, and what was the decision. So unless the data is rich, that conversation is never rich. The data lays the foundation for that conversation to make it happen. So I think the first point is that oncology is really the best test case, and I will request all of you to pitch and work towards making this happen for the oncology space. And as Dr. Manju mentioned, from prevention to the palliation, every touch point will be impacted by oncology. If I see how digital and AI will change oncology world, it will happen at every step. Every GP will have in his pocket on the desktop the algorithm that when this fever needs to be tested more, when this lump should be tested or not tested, all this is what we are foreseeing will happen. And we all know that clinicians today spend a lot of time on the keyboard, but that is also going to change with the kind of new technology happening, the voice and text messaging, all this is changing very fast. Now, coming to your precise question about Max. So, on one side, we heard that only 15% of hospitals had any kind of EMR. Now, the key word is any kind of EMR, because EMR per se does not deliver. We all know that. And even at Max, while today I may say with some humility that I think it was the finest digital platform, and what Dr. Manju mentioned that we tested 4 centers. One was Max and Tata and obviously Adyar, and 4 centers tested the transportation of data, how patients can use their data, leverage data power and get best care in any center across India. So it was tested there. Even at Max, only about 60% data is captured properly. 40% is lost, and therefore what happens when you come to analyzing data for research for this, only 30-35% gets meaningful. Even it gets further lost, because in the chain, in this 40%, something is lost here, something there, and therefore it becomes not so good. But where we are today, I think we are in a critical point where we will have to go paperless in a real, genuine way, and everything else will have to be off the table. Only then the transformation will begin. And as we will solve for ourselves, I think we are in a position to solve for the world. Why I say that? Because there are 2 kinds of world, the developed and the underdeveloped. We are right in the middle, and as we solve for us, the US healthcare, the UK healthcare, all that European healthcare is either too expensive or too late and too limited. So digital is the only way I think we can solve all these things. The cost will go down, the speed will come up, and the pickup will improve, and we'll solve the underworld also, because less privileged societies also, because there also this will bring down the cost. So I think we have no other way but to really bank on this. And our experience at Max has been fantastic. And as you know, that we are working with Ashoka on 3 projects, and each one of them we see how this, for example, a triple negative, how this data is helping us sub-analyze and look at these subset of patients. So I think for anybody in healthcare today, oncology is a good test case, but every space, whether it is diabetes or neurology or whatever you talk about, will be impacted hugely. And whether you are a researcher or a clinician, you have to work together. Whether you are a researcher, clinician, or from a diagnostic space, you have to really work together. And the only way to build that language is by digital platforms, creating models which people can understand and apply the best practice. So the future of healthcare and future of oncology specifically is based on 2 pillars, I believe. One is deep diving, that is focusing more and more. And that is rather going into the silo very deep. At the same time, the other side is really connecting with the world and knowing what is happening. So I always say there seems to be a sense of contradiction, but actually it's not a contradiction. You reach a point where you can capture both these things and actually deliver on ground. And that is where we are moving towards in a fast pace. So I think it's a very exciting time for anybody in healthcare, and whether it's private or public, we have some same mission as Manju mentioned, 300 plus institutions. We are really blessed, the kind of thinking which is evolved at NCG and has us shaped in a big way. So.
Thank you very much. And it was a lovely point that you made about being the most complex specialty in the sense that you really cut across every discipline in trying to provide the best cancer care. One part that didn't come up automatically, because so far all the people speaking have been more hospital people, is cancer in the public health space, primarily at the level of screening, etc. And Ashad, your work in this particular space has been about using AI and digital to accelerate the screening of cervical and breast cancer. What has been your experience of the potential as well as the gaps and things you would like to say that might become part of a digital oncology momentum gathered right from the ground, going all the way to the roof.
Thank you, Dr. Agarwal, for your question. And before I respond to your question, I just wanted to make a few comments on the National Cancer Grid. I stay in Mumbai, so we have a lot of connection with Tata Memorial. We take our patients, not only just refer them, but escort them to Tata Memorial and have good experience of using NCG for a second opinion. I think you call it Navya, the program. Good experience on that. But one suggestion, Dr. Manju, is during the first registration, right, we know that we can upload the records. But the problem is that the first registration and to prepare a clinical summary of that, it's a very time-taking process. So can we use an AI-powered tool over there for generating? I'm sorry, I put it as a question.
No.
Absolutely fine. I think more discussion is better. So please feel free to question each other without my even having to pick up the mic.
I can respond, right?
Yeah, please.
Yeah. So when we started doing this, the teleconsult bit, which is directly patient to the doctor, we are looking at how we can create the summary, the case summary, without too much of manual effort, because that's a time-taking, aspect. If I have to sit down on a teleconsult and if I have to go through like 300 records, sometimes 99% of them are just the blood reports, to figure out that, which one is relevant, it becomes difficult. So we are looking at methods that how we can get this summary out of those clinical records, which is automated, and no one needs to put that effort and write it down. So that's a work in progress. Yeah.
Thank you so much. And to responding your question, yes, I mean health technology is very useful in the entire cascade of care, right? And I heard someone saying yesterday that it should not be deep tech, it should not be high tech, but it should be right tech. So right tech for cancer continuum of care. And I think for that, it should start from awareness. I think it's just awareness. So do we have the right technology? And when we speak about rural setup, okay, and we know there is mobile penetration in rural setup also. And if we are using mobile technology, then instead of maybe internet connection, I know that there has been a lot of success in maternal health program where they've used the SMS text for awareness. So can we use that? Can you use social media, a web-based platform? And when we speak about web-based platform, like if we are planning to use a risk assessment profile in the web-based platform, then also a challenge is how we can create the best platform, but how do we push people to use that platform? That becomes a challenge. So then can we think about incentives over there? Incentives maybe not for all, maybe using, a lottery system where we can do a cost-effective incentive most. And then when we have this risk assessment profile, that also helps us we know that while doing a predictive analysis, data is a challenge for us. So such kind of huge data set, if we have during this risk assessment, it can help us in using AI algorithms. And also, when we talk, what is the right messaging, especially for awareness? And here is where I want to put my personal experience. I mean, when we talk about awareness about cancer, we always talk about loss of appetite, loss of weight loss, blood stain discharge. But I want to talk about my experience. It was just episodes of sweating, episodes of abnormal sweating, episodes of exhaustion, and just watery discharge, not foul smelling, just clear watery discharge. And this happened for 6 months. And I, being a medico, did not even pay attention to that. I had a very active lifestyle. I was happy in my lifestyle, ignoring all these 3 symptoms. So if a medico takes about 6 months to diagnose oneself, then I think we need to look at what kind of awareness messages that we need to give for the non-medico population that we're talking about. And this has really made me think, because I think my personal experience over here. So that was about awareness. And then when we talk about point of care diagnostic tools, that is where we have our experience, and we have used for cervical cancer, periscope, periwinkle, and for breast cancer, we have used Nirmay, and we have used it in Satara. The challenge is that that we need to work with the government over here. For any point of care AI-powered tool that we're using for screening, it has to be with the government, right? So we have used it with the government. We have screened about 12,000 cases for breast cancer and about 500 cases for cervical cancer. And then there is a proper protocol, which is very important, the referral protocol for the confirmation part. And this is what we have worked on. So when we talk about the continuum of care, then once that the diagnosis is done, we're worried about the processing of this information by the patient. How painful is it? And how can we make it better? So can we have some kind of a digital diary, okay, where the stories are told? And the stories are told by the survivors, and when the new patients who are detected, when they read these stories and they understand what are the challenges, especially the challenges related to chemotherapy, which we may just mention it, but it's only a person, a peer-to-peer access, that is important. Only they can understand the pain that has gone through. I think that is where we can use technology. We talk about telemedicine, remote monitoring, but here it is not just, it's a remote continuous monitoring, because this is a longitudinal cohort. So can we have this kind of a AI-based remote monitoring where we can pick up early warning signals for any relapse cases that can happen? And finally, when we talk about AI algorithms for images, we have worked, PATH has worked in for digital chest X-ray. And it was so difficult to bring the radiologist on board for acceptance of them, for usage of this. I think that will be the similar case for CT and MRI also over here. Okay? And we talk about predictive analysis. Yes, it is very important, but where is the data set? With the Data Protection Act being there, we do not have the data set to work on a predictive analysis. And from my side, I have one humble request to this August gathering is, we have predictive analysis, yes, but in a setup where there is a strong family history and the genetic test is negative, is there a kind of a prediction that can be done where the mothers can feel safe that their daughters or their niece or their close family is not affected? Is there something that is coming up? And that's my question. I end it over here.
Thank you very much. Very, very important points. Prashant, I'm going to go past you because two magic words got said. One was Niramai, another was government, which takes me automatically to Karthik, who basically did this at scale. And so Karthik, maybe you can talk about your experience and answer the question that was raised at the same time. How can the government help in scaling new technologies that otherwise have not been deployed before at scale? And please feel free to continue from that onto the larger question of how you think, in general, digital health screening can be expanded at scale.
Thank you, Anurag. Thank you so much for having me. Very often, folks typically invite me only for digital. Oncology is a passion. And I want to just narrate the story of how I landed up in oncology. About 17, 18 years back, I was a subdivisional magistrate in a district called Bathinda. And there used to be a train that everybody would take in the evenings in this town of Bathinda. It's called the cancer train, where people would travel from Bathinda to Bikaner. And I would always worry that the moment it is evening, most of my staff in the government offices would typically say, I'll have to drop someone to the railway station. So, and coming from the southern part of India, I would think, okay, maybe they're going for a trip. And only to see that one day I realized there's a huge train that actually travels and only transports cancer patients. And this then led on to me getting into the health department. And we realized as a state that we did not have the resources to first even treat people. And that's the reason why people were moving from Punjab to Rajasthan. So one of the first things that we've done is we went to the Prime Minister then, Dr. Manmohan Singh, and requested that the Tata Memorial Cancer Center, which was essentially in Mumbai, and Dr. Badwe, who was then the director, was very hesitant to actually move out of Mumbai because TMC was a very Mumbai and Mumbai-centric institution. So we then signed up an MOU with TMC to actually do the entire upgradation of our medical colleges. The first thing that we had to do was GMC Patiala, Amritsar, and Faridkot did not even have advanced cancer facilities. So if you have your tertiary cancer facilities not really taking care of cancer patients and what would happen. So first was that. Second, we realized that we did not even have this is about a decade and a half back. The second thing that we realized is, one, to set up these advanced cancer centers, we don't have the technical skill to even write an RFP to procure a linear accelerator. So what we then did was we asked TMC to say, if you're procuring 3, why didn't you get 3 others for the state of Punjab? Then we also realized we did not have an ability to do a rate contract of drugs. So we again latched on to TMC. And then finally we said, okay, TMC, if you can actually do this much, why didn't you set up a satellite center? And then TMC was pushed to set up a satellite center in Sangrur. And then we said, why just a satellite center? Why don't you set up a tertiary cancer center? And that's where you have a Tata Memorial Homi Bhabha Cancer Center in Mullapur. And now today, TMC is essentially there in large parts of the country, and this journey started in 2014. Now, participating essentially in setting up these advanced cancer centers in Punjab has been a very fulfilling experience. And this, in a way, when I went to the US, picking on what Dr. Chaturvedi talked about oncology, let me talk more about my passion for radiation oncology. Unlike within oncology at least, radiation oncology is even more sophisticated from an informatics point of view, even in the US, because there are 20 different information systems just in that field. Unlike, for example, in the US, where EPIC got introduced somewhere in the early 2000s, the EHR system in radiation oncology is called Mosaic, which got implemented in the 1970s and 80s. So in many ways, Mosaic predates even something like EPIC or Cerner, even the US. So today, a classic radiation oncologist or a medical physicist and a dosimetrist who works in the radiation oncology workflow, they typically at every point would use at least 5 to 6 different information systems, and the entire care path has close to 20 different information systems in the US. Now, that essentially was the reason where I got into AI because of that. Now, coming back to the Punjab story, after 10 years when I came back to India, here was an opportunity now where we realized that we kind of set up these advanced cancer centers. We also kind of created a scheme in the government called the CM Cancer Relief Fund, because one of the first things that we realized 10, 15 years back is when patients go to hospitals and they get diagnosed with cancer, the first thing that they would say is, I really don't have the money to pay for the diagnosis and treatment. So Punjab was one of the first states where we started giving cashless hospitalization in 16 centers, both in the private and the public. So we empaneled both the private hospitals in the region so that we can cover for at least a distance of 20 kilometers in the state of Punjab. And this is again in 2014. Now, the reason why I'm telling you this very long story is by the time you start if you really want to implement any AI machine learning tool at scale, especially for screening, what you really need to think about is not the screening tool itself. It is the ecosystem in which you need to really screen. And so very often what would happen is you screen people and then you leave them in the lurch. So one of the first things that we've done is when we put in this project, we essentially asked the innovator, asking them saying, what we're going to use the project funding is not just for the tool itself, but actually to create an ecosystem to ensure that the tool and after the screening is done, people can actually be taken for diagnosis and treatment. And more importantly, we realized the need for a project manager and a knowledge partner, primarily because very often people, once they get screened, they really did not know what to do with the report. And most often people would say, as I was hearing in another panel, people are disappointed that they have nothing in the report, as if they really want something to come out of the report, right? Very often you go for a screening test, you put in money, and then you get nothing positive, and you're like, what is the end result of the screening? So and therefore that was one key learning. And the second thing that we really realized was most innovators would talk about how useful and usable their tools are. And now for us, in the public health system, the proof of the pudding was in, do our end users really feel that it is truly usable? So what we really did for us was, when we started screening, we essentially told the innovator that we will mobilize women only for the first 3 months, and if the tool is truly useful, people will continue to use the tool for the next 17 months or so. And what we've essentially seen is the usability of the tool. Once we mobilized, we did see a peak, but because of the word of mouth spread between women, we could see the tool being used for almost 98% of the time that it was made available. Now, anecdotally, I can just share with you this, that in the secretariat, after almost 10 months, all the senior women officers came in and said, this tool, we hear about it in rural hinterland of Punjab. Why is it not being used for women employees in the secretariat? So we had to pull the tool, make it available, do camps in the secretariat, and then in the office spaces so that women officers also could get used to it. So what I really believe is, for truly scalable usage of AI, especially in our public health systems, which are extremely fragmented, is can we re-engineer our public health systems to ensure that the workflows don't get completely distorted, and you really integrate the AI machine learning as a part of the regular workflow. And second is, when we implement them at scale, you want to augment the entire ecosystem to support the implementation of the scalable tool. I think those are the two broad learnings that we have from having implemented this at scale in Punjab. Thank you.
That was fantastic. Now, back to the biggest difficulty. If you have multiple data sources in the country, some more reliable than others, some digital, some not digital, and the country asks you questions regarding how much cancer is there, what type of cancer is there, there is no other way than to go to an institution that was built to answer these questions. So Prashant, as the director of that institution, also with your personal interest in registries in general, how do you see this entire area as making your life easier or harder? How do you see this going? Because you already have a system that works for you, but there seems to be a very attractive cross-operational system being built, the National Cancer Grid. Your thoughts on the potential and what pitfalls do you see?
Yeah, thanks Anurag, and thank you all for being here in large numbers. Cancer, the other context why I'm here sitting is because from the ICMR National Center for Disease Informatics and Research in Bangalore, we run the National Cancer Registry Program for India. Now, this is a 44-year-old program, the only disease registry in the country outside national health programs. And it has been collecting data systematically over the last 44 years. We were paper-based, then in 90s we became electronic, and we are still electronic. And we were used as an example when the National Digital Health Blueprint was being developed, how registries should be constructed. And with that came the biggest pain of realizing that data gaps are too much. We started with small number of hospitals, but then we enlarged. The NCRP, or the National Cancer Registry Program, primarily has two functions. The first one is to inform public health, which means government and actions around cancer burden, cancer epidemiology, incidence rates, mortality, trends by the sites of cancer, giving variations, geographic distributions of cancer, giving trends, projections. That is a primary function as a public health function. While this is being done, we were also collecting data on clinical parameters. But they were not being reported very aggressively. We, being a cancer intelligence system, are heavily dependent on the inputs which come for intelligence. And the quality of inputs which come are besieged by problems related to missing data. Because the registry captures data from the health records, from the patient records. It doesn't interview the patients. So what is written will be captured by the registrar or the social worker who abstracts data. Now, since there is a lot of missing data, there is a lot of inconsistent data, a lot of our time goes wasting in cleaning this data and trying to make sense of this data. And that is why most of our outputs are delayed by 2 to 3 years, which is also a little global standard also. And we are working in an environment where cancer is not a notified disease. Unlike the West, where cancer is a notified disease, it works under a Public Health Act, Here we don't have that provision. Now there are 17 states who have made cancer as a notifiable disease over the years. Now, registry is an aggregator of data. It is not a generator of data. So where do we get? Our most trusted sources are hospitals of all ranges, from the nursing home to the super specialty, only cancer treating hospitals. From public to private, from NGOs to foundation run hospitals, everybody. Anybody and everybody who deals with cancer, any aspect of cancer, including diagnostics, should be submitting data to the registry. Registry aggregates the data and then produces the results. And the results are mainly epidemiological results. It informs how, where, what, why is happening at a cross-sectional level and as a trend, or you can look at past and project for the future. There are multiple, and one thing we don't talk enough is we talk only of new cases or number of cases of cancer occurring. We don't talk about deaths in cancer. And this is where we fail because our mortality system is extremely poor. 99% of death certificates are cardiorespiratory arrest. So how can you derive who died of cancer? So everybody dies of a cardiology or a respiratory related disease. So when you look at statistics, all our DALYs, QALYs, etc., everything is twisted because mortality figures are all twisted. We don't have that data. Now, mortality in India is dealt by another very robust system, which is opaque, which doesn't open up. And the problem is doctors write the death certificates. We doctors write cardiorespiratory failure, sepsis. So the correction has to happen there, and that should also be part of digital and improving cause of death. Because we see numbers are increasing, but people are not dying. So our policy makers are very happy. Because you don't die of cancer, okay? You die of something else. So some other specialties are reaping that everybody, so the investments are going wrongly. And this is our intelligence system in cancer. Then there is a lot of reluctance by data creators to share data. Why should I share? What is my gain? What do I benefit? Whether it is individuals, whether it is systems, whether it is platforms. If we have a mandated platform which is ready to share data, again, all the challenges of standardized data, what field should be there, what frequency should be there, what depth. So there is a difference between what kind of data sets you require for treating patients or managing patients versus a data set that you require for cancer information, intelligence, epidemiology. We need more aggregated, little higher level data so that we can give at least good estimates. So as a public health functionary, we are able to give very robust information on cancer survival, 5-year survival at population level, hospital level. NCRP is an underutilized system because we don't ask the right questions to NCRP. We only ask questions related to, burden, trends. That is, clinicians don't approach NCRP to ask questions. So if that is not there, then it doesn't get enriched. So, for example, currently we are working on estimating what is our radiotherapy requirement in the country. Is it true that we need 1 per million radiotherapy machines, or we need something different? And government is chasing that one figure. So we may be, incorrect if you look at the cancer burden, because those are Western derived figures. Clinical care, another, this is one. Then national programs. So, for example, we have the national, let's say, viral hepatitis program. it deals with viral hepatitis, hepatocellular carcinomas. We are not connected. The National AIDS Control Program, we are not connected. Then the TB program should be connected with for lung cancer. So even at policy level, these connections are not there. I am not delving into areas of insurance, pharmacy, genomics, they are still little high end. If these basics get connected, the registry gets tremendously, strengthened. And by having a digital approach, it will save us a lot of time and energy. But that will be dependent on the standardization which has been done in the EMR systems. If today we get a lot of garbage data, we spend months clearing of that data and to arrive at a correct numbers. But if the input is coming in a good quality at a regular interval, that will really make registries more robust, more real time, not real time in the sense, but little more closer to reality. And cancer is not like an infectious disease that, there is an outbreak of breast cancer. So you can wait for some years to see changing trends and all. So my only submission for this digital oncology in cancer care is have multiple solutions, but they should be standardized. They should talk to each other and
Thank you so much,
have a
Anurag.
commonality
You
in
made
the
very
sense of
points
what
out
is the
of-
minimum
and I
basic
think the most
which
biggest
can be
takeaway for me has been
provided
what you said
and
that
be
National
utilized
IPC
by
guidelines
the
were prepared
registry.
for coronavirus during COVID, and I
Thank you very much.
Thank you very much. In fact, your answer was so interesting, we got other people from other rooms hearing in. So, but I want to come back to now a very quick round, 2 to 3 minutes each, to build on one critical theme that came. You ended your point very validly by the fact that data is often wrong. Nobody apparently dies with a beating heart. Once in a while, people are brain dead, but that's hard. So the doctor on call who comes and declares them dead notices only the first thing on the front of the sheet. Now, you also talked about, very mildly, the lack of aggressiveness in populating the data, which leads to perhaps the first problem anyway. And you talked about how this would save a lot of effort when the nation wants to know, right? So when the nation wants to know, a lot of effort would be saved this way. But when Joy started, he pointed out when the doctor's work burden actually goes up. So it's a question of what's in it for me at various levels. And so let's start from the point of view of the person who is taking care of patients and is generating data at that point. That is the fundamental lowest unit, I believe, of all this. So Joy, in 2 to 3 minutes, what kind of digitals do you think you would like to see that will make the job of a doctor easier in helping other people further down the chain?
Thank you, Anurag. My neck has grown tired of nodding. Like I never thought I would agree so much with everybody on the panel today. But it's truly encouraging to see that we are all kind of coalescing around critical things. So I'll start with the first point that changing from paper to paperless should not just be in that sense of changing from paper to paperless. And I think understanding digital processes and the benefits that digital processes brings to us and how it can make us more efficient as clinicians should be an underlying part of it. And bringing clinicians to design screens and making software is very critical. Often we do not speak the same language, so we are always at loggerheads with the technology people, and somebody brings up something, sometimes it's 6 months later and we've forgotten about it, and then we are all fighting with each other. This is not what I wanted, the button is in the wrong place. The focus on UI and UX to make this more efficient is key to this whole story. And linked to that is, what is the incentive for the clinician? How do I make that incentive tangible to the person, whether it's a research paper or whether it's making that workflow easier or some statistics or some feedback to the clinician to make life easier. There are many different incentives at different levels, and we need to think that through. And the last thing is moving out of this culture of data entry operator. So you have a paper and then a register, and then there is no data entry operator, so things did not happen. In our institution now, I think to get somebody called a data entry operator is very challenging. If we have to normally face 3 committees, a data entry operator position has to chase 6 committees, I think now. So we made it progressively harder to get those kind of people in, but that means that we should change our attitude to work and how we collect data. So real data, real-time data and live data from the person who knows it best. The second is the need for standardization, and I think there is no getting away from it. Part of our challenge as early adopters is that we built our own standards, and the question always was, only we need the data, so why should I build to SNOMED or LOINC or any of those standard vocabularies? And I think we need to change, and I think some of those reporting requirements, if they change and say you have to report with this particular code attached to it, either for reimbursement, that's a big incentive, or for registry purposes, then I think we are going to see change coming through. Also, authenticating individual patients. Now there's an opportunity. Earlier there wasn't, so we have this duplication of identities, which is a big problem. And the last is cost recovery. You know, all this technology brings in cost, and we have to be conscious and aware of it. There are improvements and benefits from it, but to tie in these benefits to what has happened with cost, you know, computer, hardware, obsolescence, and now licensing. Everything has become a licensed product now. There is nothing you can buy in perpetuity. So all these things are adding cost and then bringing back value through evidence generation or improving quality of life for the patient or for the clinician. I think somehow we have to tie those threads together and show that digitization actually brings in value is critical to it. I'll stop over.
Manju, we'll go to a problem that I think you guys have partially solved already. Creating a suite of EHR products that are built to be interoperable by following a set of national standards like those by NABH. What's been your experience in getting EHR vendors to come together? Because until the EHR product is interoperable, you know, spending more time on extracting data into common data models is simply not going to happen. So given the work that the foundation has done in this area, your thoughts?
So I think what we started with, and that's the biggest challenge in terms of that, you know, when we started this entire thought process of that we want to have an EMR which is oncology specific, has these data, you know, has these features, we were very naive and we said National Cancer Grid is going to build these EMR systems and we'll maintain. And I think that was the right moment when we got in touch with Rizwan and he suggested that, you know, this is something which is not going to be you know, sustainable for you people and we need to think differently. And what we realized that we don't have certain capabilities and the EMR vendors don't have the complementary capabilities what we have. So if we put together a project where we say that we will guide you, we will be, you know, your partners in the development and we'll make sure that once the product comes in, it's in the right shape and it's adoptable by majority. And we will not just, you know, build a product, but we will help even with the deployment of the product, whether that requires assessing a center, helping a center what they need to deploy the EMR, and even to a certain extent financial support. So both the technical support and the financial support which will come in. And of course, a bigger thing was that we are looking at close to 300 odd centers. And if you build this product which is usable and which is, you know, adopted by these centers, you have a huge market. So that was something which was there for the vendors in terms of the market. And of course, at each step, we were constantly working with them, giving them, instead of them going and finding a clinician or an oncologist or, you know, somebody who's remotely associated with health and then building up something and coming back to us saying that, hey, we've built this product, now start using it. So that wasn't the case. And I think that was our USP because we had teams who were working with EMR vendors, giving them constant feedback. So they knew what they're developing is going to be used and will have more adoptability as compared to, you know, what they have been doing all this while. So I think that was, you know, that's something which has worked in our favor. We are going slow. We are, you know, looking at what are the challenges which are coming on ground when we are implementing. And I think one thing which we were very conscious about when we are developing this, that, you know, typically in a clinical workflow, when a person is seen in the OPD, a doctor writes a whole set of notes. Then the same person comes to an inpatient, another set of doctors write another whole set of notes, and then the sisters write another set of notes, and then there are investigations which are ordered by somebody else. So there's a lot of duplication of work which happens at several levels, which can be clearly avoided, and that's the reason why in my EMR, which we were using, as we are very reluctant to use the EMR, because you need to start doing everything when the person comes to you. A lot of it can be auto-populated from the previous encounter, which can be editable. And we kept this in mind so that the amount of effort needed by the nurses, by the doctors, or even, let's say, a billing clerk who's going to be involved there is no duplication which is there. So that's where, when we had all these subcommittees, at the end of it, everyone sat together and say, hey, my template looks like this, your template looks like this. Can we see what can be, common, and which can, be brought in from your template into my template directly without anyone, entering that data. So I think that has helped, and that has led to some bit of standardization. I may enter a diagnosis in X manner, somebody else may enter diagnosis in some other manner, but we want this to be, all built in. The other challenge which we were just talking about, we don't like looking at ICD codes as doctors. I just don't understand, what I mean by I in the sense that we just don't understand, because it's not typically how I would see a diagnosis otherwise. That's not how I've been taught to look at a diagnosis. So whether we can have things at back end which can be done automatically rather than doctor trying to select that code, or for that matter a resident trying to select that code and put in, that's where the errors will come in, that's where the missing data will be there, and you would never get the information at the end of the day what you want. So I think we do need to keep the user in mind. Again, the pain point of making the data entry. In a busy OPD, when you have practically 2 minutes to spend with a patient, and all my resident is doing is just looking at the computer screen and the patient sitting that side, it's not a good feeling which a patient gets. And even as a doctor, you don't feel satisfied at the end of it. So we are looking at solutions which are capturing the ambient discussion which is happening and putting it in a template in which you want to see at the end of it your clinical notes. So I think we just need to bring in everyone who's involved. Everyone can give their strength and bring in. And again, linking all possible sources of data together at backend is going to be something which is needed from everyone if we really want this to succeed.
Thank you. Sounds like wonderful topics for AI developers to work on, right? You can almost see Karthik nodding on the other side. Dr. Chaturvedi, I'm going to ask you probably the most difficult question because we talked about there will be financial costs. There would be other difficulty. There is long-term benefit. You are extremely acquainted with the corporate setup, and in corporate setup there must be incentives for things to happen. There is also on the corporate setup another side that if the patient is more satisfied, then many things can be justified. In your experience, and I'm sure you have faced this across your journey, how do you bring this in corporate hospitals to prove this? Because they can work faster than many other places in some of these areas. So you know exactly what I'm asking.
Yeah. So what you're saying actually is music to my ears, because this is something which has been my core thoughts since 2009 or something, what I used to call the IT highway. We need to build the IT highway, and that is not just a digital journey, it's also the experience journey, and as you said in the corporate side, you see the cost and all three journeys have to be captured. And it's very important what Dr. Manju also mentioned and others came across, that data entry operators or how the patient experiencing who's doing. So in our setup, what we have realized that people who are spending too much time on data, their patient satisfaction actually goes down, and they're not able to see the desired number of patients, not desired by virtue of some pressure, but desired because they have a waiting list. They're good doctors, they have a waiting list. And whether it is Tata Memorial or Max, unfortunately, we have a huge load. Even at Max, every day at one center, we see about 300 to 400 new total patients in an OPD. So it's a huge load. And I also have not 2 minutes, but 5 minutes. That's it. And that's what. So you need data entry operators, or you need somebody to support it. And what we have found a way is that coordinators and somebody will fill in some data, and some junior doctor will fill in some data, so that when the patient comes to my table, at least It is something there on the table, because still somebody or like me is not able to spend or fill on this properly. So as far as the incentive goes, the doctors are professionals who also want to be respected in professional space. They want to show their data, they want to show their work, and they have realized that unless we do our own work, we'll not get the respect. At max, if one of the concerns is that how do I get a podium presentation call from XY hospital or XY conference, and that will happen only on your data. It will not happen because you know the subject. Doing is not enough. You have to create something to create magic. And this realization is there in the whole professional world. So one is that inherent incentive is already there. As a management, we also realize, or management realizes, that unless you support this, you cannot grow. So in my mind, I've created 5 levels of institutions. So I will not go into and waste your time on that. I'll just say that everybody knows what's the next step. So we know what's the next step for us. For us, the next step is not just doing what you're doing, but collect data, publish data, command. That is why we partner with institutions like yours and so many other institutions. We realize that this is a critical piece for us to fill in, because standard of care today through guidelines, and because you have so many specialists working together, by and large you know that 85-90% will be consistent good care, because they are all trained people and they are doing. So that is not, this is the worry, and this is a good enough incentive. Now the financial aspect, because the cost of manpower goes up and all that, I think it's balanced by good data. That itself serves the purpose. And today we get partnerships and grants also because we have data and meaningful data. So that is happening. But still, in that whole digital journey, my scoring, I would say we are still hovering around 4 or 5. We have to go cover a long way. But there are enough inbuilt incentive for professionals, for business, for everybody to really leverage that. And it is, we are on that tipping point, if I can say.
Thank you so much. Ashaji, you have dealt with trust. When you start collecting large amounts of data, one issue that will always come up, that's where the Digital Privacy Act comes in, many other things, is trust. And you have formerly worked with areas like HIV that were particularly sensitive for a variety of reasons. Do you see trust issues in the area of cancer? And if so, what are your thoughts at the ground level if you want to build these digital ecosystems, how to improve trust?
Thank you, Dr. Agarwal, for your question. And before responding to that, again, 2 points. One is what Dr. Prashant raised about integration of the programs, especially HIV program and cancer registry. So I just want to highlight Dr. Sheila Godbole is here. We have published paper, Sheila Godbole is the first author. We took HIV data from Maharashtra and matched it with the Pune Cancer Registry. And this was long back in 2012. Okay? So I just want to say that the point that you raised has been done. And ma'am, regarding you spoke about duplication and the time that is given to the patient. But in spite of all that, ma'am, still there is a lot of compassionate care that is being delivered by Tata Hospital. I really appreciate that. And that being led by Dr. Badwe, sir, right? The compassionate care that, people come all the way from far away is for that, I think, that compassionate care that is given. Thank you for that. And now coming to the question, sir. Yes, trust is very important. And just to say from our HIV point, we tried to use biometric way back, okay, for our program. But no, there was a lot of issues. Privacy, confidentiality. We wanted to have a unique record because it's a longitudinal follow-up, unique record. But we could not use it. So the problem is trust, and the trust is from every side. It could be the patient, the provider, and when you talk about digital technology, from the developers and the systems. So when you speak about the patient perspective, I said building the trust of the patient is so important. And also, does the patient understand what is this digital technology going to do? Is it how effective it is, how it is going to help? So I think that conversation with the patient, that is very important, bringing the patient on board. And also, someone mentioned technology has to be user-friendly. And it has to be the bottoms-up approach. It has to be from there that we should start using technology. And for the providers, I already spoke about our experience in digital X-ray. So basically it was, is this technology going to compete with me? The understanding that it is complementing the provider, and it is a tool which is going to augment the services that is being provided. I think that trust, and that trust can happen only with continuous advocacy, continuous conversation with the provider. Okay, but the only challenge is, will technology replace human interaction? That's another challenge that we need to think about. And when we talk about developers first need to first look at what is the need. What is the need from the patient side and from the provider side also. So has it been done? And then if that is not done, only the technology is not going to be useful. And in India, there is so much of regulatory hurdles. And we talk about data how is it going to operate between two systems? And how are we going to use this into the workflow? One of the major challenges that we had in digital X-ray was integrating that into the existing workflow of that clinic over there. I think that will become a very big challenge. So how do we then navigate across this complex regulatory process? I finally want to say that it is just data privacy, security measures, and robust data security, if that assurance is given to the provider. Now that we are using a lot of Aadhaar card, okay, but I just want to give an example of that also. Recent visit to Delhi, when I'm coming from Mumbai to Delhi, one of my colleagues refused to use Digi Yatra. Why? Because of the scare of the data breach over there. So this is also one of the challenge. Finally, I just want to say it is just a multi-stakeholder collaboration between the government, between the private sector, between the developers and NGOs, which will implement this tool to the last mile and provide good output for the program. Thank you.
Thank you. Prashant, a tricky question for you. Data being digital does not make it equally valid or likely to be valid, right? And I know you're part of the global burden of disease, in which very often you make your own assessments of data quality and you make adjustments. Now, as a government organization often working with state data, often working with a variety of data sources, do you think it's a good idea or a bad idea? Because quality does tend to be variable. While building models and things like this, which again you would be expected to do, to make adjustments for this or to take things at face value. Because digital alone will not solve the problem. We'll have to make quality judgments as well. And it's tricky.
Yeah, correct. So currently, as I said, we are grappling with data quality. And the quality is a reflection of an attitude, which the clinicians who record, whether on paper or digital, that why should I have this? I mean, the issue is that recently we had a review meeting of our registries.
I have two questions. How you see that in terms
Why
of
is it happening with my session?
You have the most interesting
yeah,
things
it
to
is
say.
more
Prashant.
interesting.
We still see that there is skin cancer which is being exacerbated in some other skins and neglected tropical disease that are.
So in our recent registry review meeting, the oncologists, we were repeatedly asking them to improve data on staging of cancer. It is incomplete. Many places it is not available also. I mean, my question is, how can you treat without staging information? And they said, it's very difficult. We have it here. It is difficult to write it down. As a treating physician, I know. I will do my job. I will treat the patient. But if you ask me to document it clearly, is a problem. Now we are asked questions, how much of cancer is tobacco related? We give estimates, because how do? We give that IARC has given tobacco related sites, any cancer. So now even cervical cancer is tobacco related. Now if I give burden of tobacco related, cervical cancer will stand on the top. It will upset the whole public health approach. Now this people don't realize. So say no. History of tobacco consumption, say no. Don't leave it blank or NA. It doesn't mean anything. No is an answer. Okay? People don't write in clinical notes exposures. How can you do cancer epidemiology without knowing exposures?
One comment on that tobacco thing. So today, insurance companies are not paying patients if they have a history of tobacco consumption. So what is happening in the OPD real time, that the patients who are using tobacco, they will say, if you're going to write, then please, I'm not taking tobacco. So, but because you're my doctor, so please, you should know that I am taking tobacco. So this is the reality, one part of the story. So that is just on tobacco. But I think overall now, I just want to make one more comment that we need to really take ownership of this whole game. I think whether it's ICMR or Max or Tata, for example, NCG has built a good ownership game where people have joined hands and we are building a lot of things together. So I think that will transform all this, because all of this is in our head. For example, as you mentioned of staging. So this discussion keeps coming up in all clinics and everywhere. So people have documents. So we have our tumor boards where every staging is mentioned. It's not mentioned. So it is captured somewhere, but probably what is reaching you is not there. So I think accordingly for mortality, there's that. So I think we need to really take ownership, and somewhere such panels help, but I think culmination has to happen.
But I think his problem
for interrupting.
No. But I think his problem stands of variable levels of quality in the data from the point of view of the integrator.
No. So this is an example of within hospital integration. Okay, so you have the data in that building. It is in this silo, this silo, this silo. But somehow it is not getting into the submission stage. Okay. So currently we take data at face value, but we would really, and we do conduct a lot of training sessions on how to improve data. So this is one big challenge we should take on as a professional body, that how can we improve, because it is clinicians and nurses maybe who write. So what you either write or you enter digitally, whatever it is, you write complete and accurate things. And as this goes on, it will solve our burden of, cleaning data. Because for one single patient, I can get data from 5 sources. It is my headache, how do I synthesize this and bring it? Otherwise, we will be counting cancer 400, 500 times. If from the same hospital also, the surgical unit will give a data set, the radiation will give a data set, pathology will give a data set. So how do we, that is our full-time job, to converge and, make sense of it. But if this happens through a digital technology, it will ease our burden. And then correctly, as a user of data, the clinician today, why is not able to use the data? Because then he has to use super intelligence to analyze it. And everybody doesn't have the capacity, and every institution doesn't have systems in place. But if it is so a lot of digital technology should also bring in some amount of basic statistics or summary statistics to be generated, which that is the incentive, biggest incentive you can give to a professional.
Agreed completely. Now, one way we could go is, of course, to use the remaining time and tell every question can be asked to Karthik. He can answer using one of his various hats. But the other thing I will do is, Karthik, ask you again a very sharp question. Many of the things that we heard will come under solutions that may be cross-operability, the way you have done it, or auto-extraction to reduce burden of work. But one Brahmastra is always mandates. Of course, mandates should be given when solutions exist. But where do you see this path going?
I think that's a great question, Anurag. I'm actually tempted to answer some part of what Dr. Manju was talking about, because that's a very interesting space now on what India could do differently, right? Now, over the past 2 decades, we've essentially implemented EHRs around the world, right? And what have we learned from EHR implementation around the world? We've seen 3 broad patterns. One are countries like the US, which have duopolies, which have the Epics and the Cerners of the world, which are extremely expensive EHR implementations. Then we have countries like, say, a Sri Lanka or a Bhutan, which said, no, let's do a homegrown EHR systems, which we also have in India, very suboptimally built. We have e-hospital, we have e-Shushruth from CDAC and NIC. And then we have another parallel movement, which is the open source standards-based EHR solutions, which are the OpenMRS, which is the Balmni's of the world, which are Open EHR, Open EMR, which have essentially come from academic institutions. Now, after having implemented for 2 decades, what we've essentially realized is the story that Dr. Manju said, which is our health people don't understand how these systems have been built and for whom they have been built. And the IT people think they've built one of the finest tools possible, right? So they really don't talk with each other. So now after having, and then where you've spent in close to 21 billion US dollars for EHR adoption in the US, there what you hear now is EHRs have essentially resulted in burnout in physicians. There is now a new thing called a pajama time. So what US physicians typically do is throughout the day, the 10-20 patients that they have to see, unlike our physicians who probably see 200 patients, they see 10-20, even the 10-20, they write their own typical cheat notes. They go back home at the end of their day. They'll basically get the kids to bed or maybe give some assignment to the kid, wear a pajama themselves and then start doing typing. So what Dr. Joy was talking about, how difficult it is to get a data entry operator, typically physicians in the US are essentially become the data entry operators. Now with all this journey, very interestingly, in the US, where millions of dollars have been spent on well-researched AI machine learning solutions and very little of them get implemented. On the other hand, the US healthcare systems about 3-4 years back realized if we have to solve this EHR problem, let's use what are called ambient AI powered scripts into the EHR system so that essentially you capture this conversation from the physician and you have a note that gets generated. So it is essentially a conversational tool, a natural language processing tool, which transcribes a conversation and then uses an LLM to put it in a EHR summary note. And then you have the physician to validate that note. Now, this is a fairly simple one from a technology point of view, right? Now, in the US, whether it is Stanford, Colorado, whether it is Hopkins, UNC, Harvard, all of them have implemented some form of these NLP transcription plus LLM powered. So you have a huge number of such tools in the market. And then we were actually doing an entire assessment of how these tools have come about. Now, one of the key lessons that we're learning from there, and why I'm sharing this entire story is, there is a very important lesson for us to learn. The lesson that we have is, we don't need to build the same old second generation EHR systems again in India and spend a large amount of entire resource to realize, oh, the UX UI is bad, the workflows are not really great. Rather, why don't we move to the next generation of EHRs, right? We know, and now these ambient AI powered tools, which are into your EHRs, are not really the most, what we're learning in the US is, to do a complex case history in a complex field like say oncology or in neurology, the ambient AI tools are not doing well, but in less complex fields, the ambient AI tools are doing well. There's enough evidence that is emerging now that the amount of time that physicians would take to record their notes is certainly reduced. The usability of this note is certainly much better, but the usability gets much less useful as the complexity of the field gets higher. Now, there are these 4 or 5 broad learnings that we're learning from there. Now, in our society, it gets even more complex because we speak multiple languages, multiple dialects. The same language is spoken differently. Now, but what about essentially trying to capture for at least the last part, where someone like Dr. Prashant and Dr. Manju are going to be happy that I don't have to do the ICD, but at least if the AI tool can at least automate based on basic intelligence, that if I say a CA prostate, it understands it as carcinoma prostate and does pick up the right ICD code. Right? And that's when Dr. Prashant is also going to be happy and the residents of Dr. Manju are going to be happy, right? So what I'm trying to essentially say is there are a lot of lessons that we have in terms of the technology implementation in other countries, which we really need to learn and pick up as we build tools in our setup. I know we just have 5 more minutes, so I'll stop here, but as you said, I'm happy. These are wonderful questions, so happy to answer all of them later. Thank you.
And I'll take that answer to mean first we need to build solutions, then we'll do mandates. So let's open it up to the room and please go ahead.
Thank you, sir.
I'm IT professional, recently moved to healthcare. I'm working with Park Group of Hospitals. I'm assistant vice president there. So I always see there is a gap. In the hospital sector, I see lack of IT professionals. Whenever we see IT professionals, they say they require for the maintaining of servers, they use for setting up the systems. But there is always a gap between whenever a product is being built. So the developer would have an idea or the data analyst would have an idea. So they lack the functional knowledge because we all know the doctor field is very critical and we rarely understand the terminologies and everything, the symptoms and everything, coming to the technology prospect. Coming to the doctor prospect, from the doctor's side, the knowledge like what they're having from the, regarding the IT prospect, it is very, yeah, from it like, so the importance of IT professionals in the medical field is neglected, which I feel from my side, yeah.
That's a comment, not a question. So we agree.
Yeah.
So I think there should be a common vision.
Yeah.
And vision has to be by the leader of the organization.
Exactly.
They're the essential. It's not the number of IT people, number of doctors. I think it's the vision and what you're trying to deliver together.
So because whenever the data is getting collected, it is not properly validated. Because
no, so it is a continuous engagement.
Yeah.
Okay. Good afternoon, everyone. And it was a wonderful and very interesting conversation. My specific question, first of all, I'm Dr. Varsha, teaching at IHMR University and involved with couple of interventional research in tribal area, deep down the community. So community is my first kind of basic thing, which you said that data has to be connected with the basic thing. So quite impressed with all of you, but specifically with Asha ma'am and Dr. Karthik, that actually community, because I belong to that, you saw that starting end at Bhatinda, and I was placed at Bikaner for 2 years, and I saw the end point of that cancer train. And
Varsha, seriously, we need to move to the question.
Yes, yes. So question is related to that. And then planning and intervention, another intervention research from that particular area near Pakistan border, that how to, as you said that, it takes time to diagnose to the community, and every house has a cancer patient. It is that prevalent, ma'am. How to start identifying at community level, and how to, what should be the start point for that intervention research, ma'am? Because later comes the role of diagnosis and clinicians and the clinical or the hospital treatment and all. But basic identification and the basic step, what should be
so while I ask my panelists to think about that very complicated question, let's take a simpler question perhaps.
Yeah. Excellent panel. I had a quick question for Dr. Adappa. So these ambient scribes like Bridge and Suki in the US, I was just wondering, pointed question, they record the audio conversation and then transcribe it. So how do you tackle with potential liability and medical legal things about that?
Yeah, absolutely. So you have a human in the loop. You always have a human in the loop. There are essentially three components. One is your transcribing, but you also have an LLM typically which powers it to enable it that it's placed in a right format, because it's not just transcribing, right? What a physician essentially wants is what part of the conversation needs to go into the chief complaint, what should really get into the investigation, when I was examining, what really gets into the examination part, what gets into the previous history, but most importantly, you need to have the clinician to validate the whole clinical summary note. So it's not that you don't have the human in the loop in that process.
May I? Thank you. I'm Dr. Mubashir Angolkar from KLE. Sir, you came online for my conference, so nice to see you here. We have a HDSS, Health and Demographic Surveillance Center, where very recently started, and we are trying to develop a cancer registry. We are using ODK WHO Collect 2022. So when all of you were discussing all this, I was thinking we have something which WHO has put up, and why are we still discussing making more and more digital platforms? So am I on the right track, or am I supposed to first wait? Is something
You're on a
coming up?
track with a difficult answer, which I'll again, well, we'll not ask Karthik to do this one for a variety of reasons. Let me take this one, okay? Because I have no stake here at all. So WHO has many products. Not all of them are perfect. And we need better products if we want people to want to use them, as opposed to have to mandate people to use them. So many of those products are mandate oriented. We want to move to the point where people want to use them. So while this, I mean, since now, if anybody, Asha, if you want to take that original question.
So thank you, Varsha, for the question. I think I've already answered it. It's just awareness, awareness, and awareness. Awareness first, and then risk profiling and screening the right population. Instead of screening all, screening the right population, and a proper SOP for a referral pathway for confirmation.
We'll take a last question from at the back, and then everything can continue as people walk out.
Hi, my name is Parth. I'm a public health researcher. I have a question on access to data. And we have 3 people with large data sets here, NCG, CMC with the Mission Network, and NCRP. My question is, if NFHS, HMIS can be anonymized publicly available, why is NCRP data and possibly other data sets not publicly available for independent researchers? Yeah.
This one, Karthik, you can take. Or you. Best, Prashant. This is the perfect question for you.
So we do have summary data online. You can access that. This is line listed data is privacy data. So that cannot be made online publicly. Also, there is a lot of incompleteness in the data. So, we are working on how to make it accessible, because if we give you a data set for which you cannot reproduce the results, it will be more frustrating for you. Because when we do it internally, we know what we are handling. So this is still work in progress for us, and I do hope that by the end of this year or early, we should be able to provide a better platform by which people can use that data.
Okay, absolutely.
Yeah,
The last
Prashant,
question.
You mentioned that it is difficult, like ILBS has data on hepatitis B and also hepatocellular carcinoma.
Speak into the
and,
mic,
sorry. And NACO also has data, a lot of data. What is being done to integrate so that you have the complete picture? Like I heard there is a Pune registry separately. Why is it like that? So is something being done by the institute to integrate all this data?
See, the first thing is people should be aware that there is a cancer registry. That itself is, even within the Ministry of Health, people don't know that there is a cancer registry. I am part of the cervical cancer HPV immunization program and all. The immunization division doesn't know that there is a cancer registry. And when I tell them that you link the HPV vaccination to the registry, they are blank. So, we are 2 years, we are discussing with the National Viral Hepatitis Program to converge. So, no interest. HIV AIDS. So, one paper, one study are fine. What I am talking is a large integration. There is a lot of association between TB and lung cancer. As we are eliminating TB, we will see a lot of things happening around lung cancer. And why are we saying stage 3 and 4 of lung cancer? Half of them are treated for TB. So the programs are not talking. So, this verticalization, not interested in cancer outcomes. So, I say that there is sympathy for cancer, but there is no empathy. As you said, the nation wants to, if the nation wants to know, then do everything to know about it. Otherwise, this is conference talks.
But you are in a leadership
Very, very well said. And I think the perfect point to end this conversation from here. And further conversations, of course, are welcome as people exit, bring on their availability. Thank you so much to all these wonderful panelists. And thank you to the audience for patiently listening to all of us.
Hello, hello, hello.
Hello, hello.
Mics, please. Okay. Good afternoon. Welcome to the session. The room is full. Anurag just said the basic rule of our criteria of a panel is met. There are more people in the audience than in the going to be in the panel. So thank you for making that happen. I hope you had a good lunch. Topic that we will be taking up is health technology assessment, HTA for short, because I know once we get started, everybody will be using that acronym. So I just made it very clear. And I am here. My name is Sindhura Ganpati. I work in the Office of the Principal Scientific Advisor to Government of India. I am doing the moderating because Anurag arm twisted me. I still... let's get started. I won't spend much time describing it because my hope is the purpose of this session is you will walk away with an understanding of what it is, why is it needed, what is happening in India, and why is it important, because this area is actually kind of ignored. Most people don't know what it is, why is it needed, and should we even be doing it. And it happens to be one of the most important areas that we should be doing. So without much further ado, I would like to get the session started with the remark by our chair, Anu Nagarji. So just a quick introduction for those of you who don't know her. Most people probably know her in this context. She is the Joint Secretary in Department of Health Research. I've had the pleasure of working with her when we were setting up National One Health Mission. And it was an absolute pleasure and learned a lot with the government's ways of doing a cabinet approval process. And she is a IFS officer of 95 batch and had extensive career in the Forest Service as Chief Conservator in Himachal Pradesh, had a career in the academy and have some common connections from there. In her role in DHR, she manages, of course, this HTAIN, so which is why she is relevant to be talking about this, giving the opening. But also other very important initiatives such as VRDL, the Virus Research Diagnostics Laboratory Network, one of the most important surveillance efforts by ICMR, among many others. So, Madam, please come open the session and help get this started. Floor is yours. As a chair's remark from there, then we will get started.
Thank you, Dr. Sindhura, and a very good afternoon to all of you. I come from I represent Department of Health Research, And as you're all aware that it's our commitment, the government's commitment and the Prime Minister's to provide affordable and quality healthcare to all our people. So we are here not just for our country but for the entire globe. And for that, Department of Health Research has a big role. I realized the potential of innovation, indigenous innovation, during the COVID pandemic, and I had the privilege of working in this department at that difficult time. And I remember how we were all, deprived of kits, and we were kind of in a very disadvantaged position, and we were approaching many countries for all these diagnostic kits. And there came our industry, our manufacturers, our people who really, worked very hard, the scientists at ICMR who held them, and we came up with diagnostic kits which were sufficient for all of us, but we were also exporting them. And I'm sure you all know that we provided the cheapest diagnostic kits in the world. Then we could do our own sero surveys. We had our ELISA kits. We also had, we were also one of the few countries who came up with Covaxin. So this was my first real-time exposure to innovation, and I realized how things, if produced indigenously, could really change the scenario of this country. Health research, actually, the Department of Health Research builds the capacity, helps in building the capacity of research. We have number of schemes for that, like Dr. Sindhura just mentioned. We have a viral research and diagnostic lab, which really helped us in the COVID times. We have MRUs, the multidisciplinary research units at the medical college level. We have various other schemes, and then we have ICMR, which actually helps us in all the evidence generation. And we have two verticals in the department who are actually working on the evidence synthesis. So whatever research we do extramurally or intramurally at ICMR, the mechanism to actually integrate it and make it available for use is through these two verticals. The first vertical is Center for Guidelines, wherein we are trying to make world-class guidelines, and we are already working on a number of them. And the second is Health Technology Assessment, which is the topic today. Health Technology Assessment is now an attached office in Department of Health Research. We have a very big network of about 26 resource centers all over the country who help us do the health technology assessment. And the potential of health technology assessment for those who are new to this subject would be that when the government decided to screen 7 crore individuals for sickle cell anemia, we did not have any indigenously produced kits, right? And there were kits available for rupees 350. And we thought 350 into 7 crores is a big number. At that time, government decided that we must do an HTA to assess the cost effectiveness or cost threshold of these kits. We had a whole study done, and we found that they were cost effective at a threshold of rupees 100. This was the price communicated to the NHM. NHM wrote to all its state missions, wherein they said that this should be the tender price. We had the first tender at rupees 82, and I'm very happy to tell you all that we have more than 10 manufacturers today, and the price in the GEM portal is rupees 25. So if you compare the kind of savings that we've done, so it's been tremendous. So similarly, there are various other examples, and I'm sure today we'll have lots of discussions on this, that how do we integrate HTAs. We've really tried to integrate the state governments. We are in constant dialogue with them. We are trying to sensitize people, the secretaries, the other officials who are not so conversant with the health technology. We are trying to make our methodologies better. We are trying to shorten the period. We are trying to have kind of adaptive HTAs where we do not have evidence available. So there are a number of things that, as we discussed today, we would be able to have some kind of maybe solutions also. There are also lots of discussions about cost thresholds, that does HTA mean cheap technology? No, it does mean quality technology. So we are also trying to have different kind of thresholds for different kind of diseases, for different kind of scenarios, cost thresholds in government sector, cost threshold in private sector. So we are trying to work on all of this, and we do need a lot of feedback and lot of participation from all the innovators and academicians and researchers. So I think I will stop now, and over to you, Dr. Sindhura. Thank you.
I get invited to panel discussions often, and I find them the most boring format oftentimes because it's too generic. So thank you for kicking off with very specific and informative opening to this kind of format. And I will start inviting my fellow panelists. First, I would like to invite General Madhuri Kanitkar. When I heard that she is going to be on the panel, I was pretty excited because she's a fantastic thought partner, friend, mentor, and one thing that always I can see when she is part of anything is fun. So, I mean, just a bit of background for those of you who don't know, which probably is handful to none in this room because she is pretty well known. Had an illustrious career in Army. Pediatrician by background, and after the Army career, instead of sitting on her laurels, she went and has transformed an university, MUHS, Maharashtra University of Health Sciences, and put that university, which is probably not known by anyone, probably now on a national and international map. So I've really enjoyed working with her, and look forward to having your thoughts on this, Dr. Kanitkar. Welcome to the panel. Next, I would like to invite Dr. Taruna Madan Gupta. She is a scientist G and head of development research at ICMR. And formerly, she was a scientist at IGAB as well, another very well-known institute in the country. And her divisions work on some of the most important aspects that I know happening in ICMR. I mean, MedTech, which is medical technology device, including MedTech Mitra, which was launched very recently with CDSCO. Very important area of work. And clinical trial network intent, an emerging area and an important area for the country's innovation ecosystem. And the most important, I think, when I saw this, extramural funding grant support. I have to say, Dr. Tarun, I travel around the country, meet with innovators who freely share their frustrations with funding and all of that. But one thing I have seen constantly in the last at least 2 years, people highlight they are getting grants from ICMR, it is timely, which really this is how funding could work, and they are very happy with it, which made me very happy. So congratulations on that, and hopefully that continues to improve and grow. Thank you for that, and welcome to the panel. Next, she is a pharmacist and immunologist by background, so those of you who don't know that. Next, I would like to invite Dr. Kavita Rajshekar. She works as scientist F in Department of Health Research. She has a MSc, MPhil, PhD in Biochemistry, Molecular Biology from University of Madras. I think probably the most important person in this panel because she's going to explain how it works because she's hands-on engaged in the HTA process in setting that up, coordinating all of that. And she has been involved in many other areas as well, including coordinating molecular oncology diagnostic service, and also has been involved in drafting policies, drafting Surrogacy Regulation Act, Assisted Reproductive Technology Regulation Act 2021. Welcome to the panel, Dr. Kavita. Next, I would like to invite Dr. Monica Puri. I had to look around who is going to stand up because we have not met before. Nice meeting you. She is a Chief Country Access and Policy Officer in Roche Pharma, and brings a very complementary skill set from the industry perspective here, and also has a public health background, extensive public health background. Previously she worked in Roche headquarters as global policy head. As part of that, she coordinated with many of the multilateral agencies, WHO, UNICEF, and others during COVID-19. She was at WHO CRO as a public health specialist and was extensively involved in setting up access to medicines initiatives in various countries. So that experience, I think, it will be very valuable to hear your thoughts today as a panelist. And her background, she's a MD Community Medicine from Lady Harding Medical College. So lots of medical professionals. I'm a veterinarian, so I compliment you. So welcome to the panel, Dr. Puri. So last but not the least, Anurag, Dr. Anurag Agarwal. He's a friend and a fantastic person to work with. Very soft-spoken, but very direct and clear in his articulation. He does, as a side job, he works as a dean in in Ashoka. The reason I say that is he's involved in so many things. He must be doing this as a side job. So he's a pulmonary doc and a physiologist by training, and many more things. He was the director of IGIB, worked abroad as a researcher and clinician for a long time, and I feel very hopeful when I get frustrated with my work sometimes, and it's all darkness. I think of people like him. It's going to be bright. We are in good hands. Thank you. So let's get started. Upfront, I would like to say we have planned a couple of rounds of just introductions or question and answers. Hopefully, we won't be the boring panel, so bar is high for my fellow panelists. And I would like to hold the time, so please be specific, brief, so that at last I would like to keep 15 minutes protected time for audience engagement. So if you go long, we will have shorter discussions. So that's how it will work. Before I start with the question, I see HTA, or this whole thing, in three categories. One is the innovation ecosystem, where things get developed through various mechanisms, whether it is in the vaccines, devices, that does not matter. Innovations, and it will change as now software is a product, cell and gene therapy. So it does not agnostic to, it's an innovation ecosystem. Then there is this process of assessment itself, the health technology assessment, which is the heart of what we are going to be discussing. Then there is a category of things where these things get utilized. The findings of HTA, the outcomes of this getting used for its intended benefit. Now, Anurag, I know you have to leave after this, which is why you arm twisted me, so I'll start with you. First of all, why should we even do HTA? So just say your thoughts on that. But I would like to hear your thoughts, because you have spanned all of these areas. How do these three segments interact? Anything you could share there?
No, I think, thank you first of all very much for the very kind introduction. My apologies, I'll leave early. I think the reason we do health technology assessment is to meet the goals that Anu Nagaji articulated. It's not just about cheap, it is about good. But perhaps if I were to use slightly different words from hers, I would say fit for purpose. Now, can something be good and not fit for purpose? Sometimes. You could take something that is 99% sensitive, 99% specific, deploy it for screening in an area that disease does not exist. It's not fit for purpose, right? On the other hand, something can sound bad by conventional measures, but could be fit for purpose. You could take something with decent sensitivity, low specificity, but even a healthcare worker can do it, and then you have an easy second test to stratify further. It can be fit for purpose. So the reason I think health technology assessment in a country like India is such an interesting and an important area is because you're trying to meet the needs of a diverse set of populations using sets of technologies with variously different abilities. Some could be very sensitive, very specific, very expensive, almost impossible to do, which really means for all practical purposes they could never be deployed even though they're very good. So the people doing the evaluation have to first judge the technology on the merits of technology. Then judge the technology on the merits of the fit, which again Anu Nagarji mentioned very well, because when she thinks of something being assessed and then taken forward, she's thinking all the possible contexts. And the last reason this is getting very interesting is because at least most things in this world have been able to be specified. Every engineering product in the world has specifications. You know an airplane will work for a simple reason. All specs can be written down. What I need in my airplane, what is the lift, what is the thrust. We are moving towards an area that because of artificial intelligence is becoming specification-less products. Whenever you have a product where you can't give precise specifications, the only thing you have left is evaluations and validations. And this evaluation validation system of health technology assessment is going to be such a massive challenge in the time to come that you would have to have dedicated bodies looking at this. And you can't leave it to everybody to do whatever they want. And because it is validation evaluation, it is automatically specific to context, which means validation and evaluation in the population in which you deploy the product, which makes this topic so much more urgently important than before. And to give a very clear example, if I were to build a PCR test of Mycobacterium tuberculosis, and we have them, right? I can take MTB from pretty much anywhere and expect it to reasonably translate to India. I may have to check for any weird mutations locally that could make the test go bad, but by and large, I could expect it to scale. Now I build a chest X-ray test for tuberculosis. You actually cannot expect it to scale. If you look at the history of these tests, CAD4-TB being the best example, developed in Africa, when the first time it came and was deployed in Pakistan as part of a trial, they were false positives to the rate of 30 to 40%. Why did it occur? Because we in the subcontinent have something called dirty lungs. Why do we have dirty lungs? Well, breathe the air around you, you get to know. And these dirty lungs were like tuberculosis to an X-ray trained on clean lungs. So which meant because of ICMR's efforts in giving Indian companies access to more data, we then built new algorithms for India. So without taking too much more time, I would say that's what HTA means to me. The quality of the technology, assist for the population, looking at local context, eventually only one answer, is it fit for purpose? And that's where I would leave it. Thank you so much.
Thank you, Anurag. Welcome to sit until you need to, or if you need to leave, please feel free to. Yeah, okay, yeah.
Thank you all so
yeah,
much.
Thank you. So I would like to move to Dr. Taruna, because I'm in the architecture of way I have been thinking and I articulated innovation ecosystem assessment and utilization. Could you say a little more about the efforts ICMR is doing? Because it's also big part of your department research division. How is ICMR trying to work towards facilitating, enabling innovation in the country?
So thank you, Sindhura, first of all, for your kind words and appreciation that ICMR is being appreciated as a granting agency and the kind of infrastructure that we are developing at extramurally as well as intramurally, as Anu ma'am had said. Yeah? Okay. Okay. So the thing is, this is all, with due respect to our leadership, it is their vision. Anu Nagarji, our secretary, Dr. Bahel, and then, other hierarchy. So we at different divisions are catering to the granting aspect of it. We review these grants. It starts with how to select the right committee. It starts from there. And Director General himself approves each and every committee. He looks in detail. And it is not the names only that we provide. We provide all the details about the expert, including we have benchmarks set for the H-index. We look at the, multidisciplinary activities being performed by that expert and their utility for the programs that we are going to review. And for each project, we have, number of reviewers. And we have a very beautiful scoring card for each project. And that's how we select. And we don't stop at the selection process. We actually take them forward because we have a concept called mentoring and monitoring committee. And that will have, the PI has his or her say in, informing us, this is the mentor they are looking for and we should have them on board. So we give them that kind of liberty. And that's how I feel that many of the PIs are feeling that change and they are accepting it. And of course, there would be always some who are not selected will have always questions. The idea is that we would like to inform them the committee's views, and most often we do. But the thing is that they have to take it in the right perspective and improve upon themselves. In fact, it happens that there is a deadline for our grant which is going on, and there is a call which is ending, and we are in the selection process. It is so much of hurry at our end that we should give them the decision so that they can apply in the ongoing call. So we are actually pro-PI system, and we are always thinking about their efforts to write a proposal and come to us, and we give every proposal its due. So the innovation starts from here, definitely, but there are other things that we have developed, as you rightly mentioned. We have created the Intent Network. Intent Network is a national network for clinical trial sites across the country. And I'm happy to share with you, we have 75 phase 2 and phase 3 sites that have been on board with ICMR. And in addition to that, first in human safety trials we do, and we have 4 clinical trial sites for phase 1 on board. And in fact, we are calling them as Center for Advanced Research. We are giving them the infrastructure to develop the phase 1 clinical trial center at the complying with all the regulations that we have in the country, and not only national but international. And then we are giving them the liberty not only to do the phase 1 trials for ICMR proposed programs, they are also free to take up any other programs which are sponsored by industry. So ICMR is building the ecosystem with a very broad vision and not, confined to only those people who are coming to ICMR for support. That is one thing. The other, as you mentioned, we have MedTech Mitra. This was again a vision of Dr. V.K. Paul sir, member Health Niti Ayog, and Dr. Rajiv Behel. And Dr. Rajiv Raghuvanshi actually joined us, and he said, I would like to be a partner, key partner to this program, because this has a game-changing impact on the... And in fact, we were interacting with one of the agencies yesterday, and they said it is kind of a lifeline for innovators, because we are helping the innovators at every step of the innovation. Starting from ideation, we are taking them to development of prototypes, proof of concept, helping them with Atal Innovation Mission Incubators, benchtop testing at AMTZ. Then we have our own preclinical networks, which ICMR centers are, and ICMR's biggest center, ICMR NARF-BR at Hyderabad, is going to be helping in not only the small animal studies, but the large animal studies, and they do have every possible animal model that you think of, including they are developing new ones which are where you have the genes being knocked off or knocked in, and these transgenic murine models will also be available to you. So this is the kind of network we have, and as Anurag mentioned, we have simultaneously other programs like the MIDAS program that we had with the ISC Bangalore. And in that, we have created data sets. We call them as gold standard data sets. And these data sets are about the images that you have, and TB was one of them. We also have onboarded them on AI Kosh of MITI, and that is for dural lesions as well as oral cancer lesions. So this database is available to you all. You can use it to develop your own algorithms. Thank you.
Thank you so much. Yeah, no, I have been to, please, yeah, no, I think that is it deserves a round of applause, because timely release of money alone goes a long way for the, I see a lot of head nods.
Just to tell you what time for release of money is, that we are actually asking the PIs to submit their annual report at 10th month, so that we can be ready to release their money on that. And this is all a vision.
Yeah, no, this is fantastic. And I've been to NARF-BR as well, and I was interacting with your DG, and we agreed. Supplying just animal models of dogs and monkeys alone will make the return worth it, which is the biggest constraint in developing innovations. So moving to, now I would like to go to Dr. Kavita. From innovation ecosystem, in very basic, simple terms, it would be good to hear how does this process work? Nuts and bolts of this HTAIN process work. And since you are heavily involved in basically making it work, so the basic process itself would be an important outcome of how we understand this.
Thank you for that. Hope I'm audible. Yeah. Thank you for that. So, Madam Anu Nagar already opened it, how HTA network has come across the country. The process that we actually follow under the Department of Health Research is that earlier we were taking topics on innovative technologies, programs, diagnostic devices, medical interventions, surgical interventions, all from state and central government. So we were only supporting the state and the central government. Recently, we have opened up a topic submission portal which is there on the department's website. The innovators have started submitting their topics. The moment they submit their topics, we look into what is the evidence that is available with them, call them for a meeting to understand what is the stage of development of this. Madam also mentioned that we usually take up the topic once they have obtained a regulatory approval. So the regulatory approval looks at the safety and the efficacy of that particular technology and gives them the regulatory approval. And what more does HTA look at? HTA looks at the clinical effectiveness and the cost effectiveness of that technology. Madam also said that interventions which are very costly, we look at what threshold. India today is looking at one-time GDP per capita. To look at below this threshold, we call them as cost-effective technologies. So once the innovator submits, we look at what is the evidence that is available, then undertake a very rigorous, transparent health technology assessment process. All through the process, there is an innovator who's going to be involved with us. We also keep a state government or a person who will then implement that particular technology, because not just doing an health technology assessment, the vision of Department of Health Research is that innovator has to go to the last mile. Madam added, during when we did for sickle cell screening technologies, only 2 imported companies were available. The moment we completed it, today there are more than 10 technologies, indigenous technologies, which have come to the market. Recently, we have also looked into it. We also support the innovator that once HTA has been done, we upload them on the GEM portal for procurement purpose, and that can help them in getting into the state and the central government programs. So we follow a very transparent and a rigorous process when we are doing health technology assessment. Many of the technologies have gone into about 98 studies have been completed, and they have gone into implementation by the state and the central government. We also look at different pillars where we can support the innovators. We sometimes help them in their procurement. We sometimes help the new technologies to get into the state programs. Sickle cell point of care test for latent TB diagnosis, telemedicine enabled otoscopy, digital photography for identification of diabetic retinopathy, hemophilia kit which is there, which can come into the market for point of care screening. There are also kits where startups, for example, it was a high performance optical spectrophotometry which was being developed by IISc Bangalore. We handheld them, did the validation, helped them in bringing, today is a part of the Karnataka program, 4 lakh kits have been procured and being distributed in Karnataka. There was another kit which is a Right Biotech. It is an antimicrobial sensitivity analyzer developed by BITS Pilani. We did an HTA for them and helping them to get into the system. International symposium which we had, we also displayed all the technologies that we have assessed, how they have been implemented in coordination with state and central government. So HTA is a very robust process. Now it is also a mandate of Department of Health Research to do an HTA for innovative technologies that can be supported by state and central government. Thank you.
Thank you. I think one of the innovation you mentioned, digital otoscopy for diabetic retinopathy, they have a stall. I just stopped by, very interesting product. And I asked them, have you gone through HTA? And they said yes. So it was interesting to see that happening already. I would like to take this now a little bit further down. Dr. Kanetkar, for you. You are a pediatrician. Once a pediatrician, always a pediatrician. You know, that is your part. From a clinician's perspective, do you get a sense that clinicians tend to know this? And if they knew this, would they give it any, would they give a damn? Do they care about it? And what is, do you think from a clinician's perspective, both to be involved in the process of doing this, but also utilizing it in their care? So I would love to hear your thoughts.
That's not going to be fun. I thought you said this panel was going to be fun.
It's not fun?
But just as a matter of interest, I'll start with some fun. I think if health technology assessment is, I think, about cost consciousness, is it a matter of coincidence that this panel is all women? So we brought that fun. So I think that is so very important, that value for money is what is inherent, and I think we imbibe by it. And I can assure you, this is not there in the training of a clinician. You are never taught to think, am I getting the money's worth? And this is even more important in the public sector, where technology, innovation, therapeutics, everything comes, someone is paying for it. So the awareness is not there. And I think it is very, very important. I mean, it took me years to even be aware of such a thing. So while, there's such amazing work going on, I think as a clinician and as an educator, I think this awareness needs to go down from the undergraduate level. We need to question and put that into clinicians, scientists, innovators' mind, that are we getting value for money? And my simple thing before coming here, I was discussing that most of it, when I now sit in the PM STIAC or look at research, I see there's 80% funds with 20% outputs, whereas I would love to see 20% funds with 80% output. So that would really be HTA for a clinician. And then again, how does it translate into whether we are using, when we say mass screening. For example, how I would as a pediatric nephrologist, should we have a school assessment program? I mean, as a clinician, I would be curiosity. How many have proteinuria, hematuria? And I start doing dipsticks on everyone. Now, if I think from the HTA perspective, I know what Anurag said. Is it relevant? Is it important? I mean, how much I'm going to spend and pick up how much? Am I going to think like that? So I think, therefore, it needs to be put into a clinician's mind while planning a research, while planning an innovation, that I think of cost consciousness, and this will only come where this, and I'm very happy and thankful to ICMR. It was because of long back as a faculty, they ran a workshop in AFMC. When I was dean, I took it to the next level, and today AFMC has one of the nodal centers for HTA where we are training, and we are trying to get from the young age medical professionals to get and understand it, especially because in the armed forces everything is free. So even when it comes to therapeutics, I think it matters, because I may think if I'm not paying for it, when the patient is not paying, I might want to give monoclonal antibodies straight away, you know, for a rheumatoid arthritis or a connective tissue disorder. But am I justified? Who's going to question it? The administrator will not. So unless it's there in my mind, and I think about it like that, I'm not going to give the correct decision. So I think it's excellent that now ICMR is putting that into a requirement. And the same thing when one looks at, you know, BIRAC grant, these things, you have solutions which are very PI driven, research which is very PI driven, and there is public funds which have gone into it. So I think we need to do an HTA on every research for that. I mean, is it relevant to India, or is just going to increase the H index or the citation of the PI? I think cost consciousness must come into every innovation and research. That is maybe it's the gray hair which came to it, but I wish it was when I was younger.
Thank you, Dr. Kanetkar. I will be coming back to you after one round, especially, and I would love to hear from you on how to integrate it with education itself. It's an interesting challenge. Dr. Monica Puri, I would like to ask you, you have been as part of the private sector. This is like my personal curiosity as well. How does industry view this? Because I'm going to post this as a tension, right? So industry, it's a business. There are profits involved. Maximizing profits at the end of the day is an important component. And the word I'm using, I'm going to make it a tension between the two by using the word that Dr. Madhuri connected, cost consciousness. Right? So when HTA process is involved, does it make industry nervous? How do they see it? And how does this tension play out and help illuminate the thought process from the industry side on how to think about this?
Thank you for this question. I think a very pertinent question, especially when that we have heard a lot from, you know, the public side of the world. I'll just start with a disclaimer. When I moved from WHO CRO to the pharma side of the world, my boss from WHO asked me a question: why are you moving to the dark side of the world? And as impromptu as I could be, the only thing I said is only to bring the light. And of course, at that point in time, I didn't know what it means, but now spending 8 years into pharma, I can share my perspective, which is coming more from a clinical, studies that I've done in my life as a doctor, treated patients, and then being in a policy maker position, and now industry. I mean, most of us know that 80 countries in the world have adopted HTA. Institutionalize HTA as a mechanism for reimbursement. Whether it is about NICE in UK or PBAC in Australia or Germany for that matter. But mostly the concept that it initiated from is like it is a tool for measuring cost effectiveness. which means you can find a way to justify price control. And that would make industry nervous. But we have moved many leaps now with the governments across the world to actually establish the real meaning of HTA. What is HTA? HTA is going to tell you, as a, ma'am has mentioned, multidisciplinary approach to assess the value of a new technology in its life cycle. Which means it's very important to realize that what is the value? The value to the payer could be cost, because the thresholds are set that way. If you look at the ICER value, and ma'am had mentioned that for India it's 1 GDP, of course it's now becoming more dynamic, as Anu ma'am has also mentioned. It is the cost that the payer can afford to pay or is willing to pay for bringing in that new technology to create the impact that they want to create. But that's the value for the payer. But there's a value for the patient also. If I am treating a patient and now I bring in the fact, ma'am, you had said the cost consciousness. For a patient, when he's going to a doctor, he or she is going to a doctor, he or she expects the best treatment if money is not an issue. Nobody wants in a family, a cancer patient to die just because they can't give immunotherapy, knowing that it's available but maybe not affordable. Everybody wants that. Nobody wants chemotherapy today if they can afford it. That's the value. I'm just giving one example. Nobody wants hemophilic patients to bleed and die just because you don't have anything to provide except factors. But when there is a therapy which can actually prevent bleeding. So that's the value to the patient. And value to the society, where the impact that your new technology can bring in delivering and actually shaping the healthcare system, which means if I have better treated patients, and ma'am, you very rightly said women, so I'll bring that perspective of gender equity also, especially in a country like India where just getting a breast cancer is a taboo. And imagine those women, if they could be treated with the best treatment, not only they live longer, they take care of their families, and they also look forward to receiving equity in terms of receiving healthcare. So that's the value to the society we bring in. If only we can bring all these aspects of value to the patient, to the payer, and the society together and say, yes, we have the right framework to assess the value of the technology. And if this is the vision that any HTA framework in any country would have, industry will never be nervous. I can tell you today. More so, it takes 5,000 molecules to fail to get one treatment out. I'm talking about innovative pharma. I'm not talking about once it's lots, it's patent and it's generic. And it takes 10 years for a research from a lab to come into market, to get access. It takes more than $1 billion to get a molecule, which could be an innovation today. Of course, in long term, it will become, generic. If someone is investing, he or she, that company is not investing just because they want to make profits. They also want some return so they can reinvest to look into disease areas which are still, looking at us for some hope. I mean, look at antimicrobials, antibiotics. Why are we struggling? Because it's been 40, 50 years. We don't even have any new antibiotic coming in. So who's going to innovate? Someone needs to put money. Someone needs to do research. And I'm very happy, and I must congratulate that Government of India, DHR department, ICMR, HTAIN, everybody is now coming together to make sure that we have more money to invest in research, and we have more technology framework to assess those innovations. So if you ask me today, do I feel nervous or feel contradicted sitting here? Not at all. I would say that there is a strength that government brings in, because of course they have the biggest resources to take care of 1.4 billion population. We are industry. We have the academia, we have the research, we have the labs, we have the capacity to scale, and we have the wherewithal to make sure that drugs are not just available in the western part of the world, they should be made available in the eastern side of the world also. And not only this, we have civil society, patients asking for it, waiting for it. So I think if we all just come together, nobody's going to be nervous. If that helps, I feel very happy being here. Thank you.
Thank you, Dr. Puri. Going to the dark side quite resonate because I had worked in academic research, and I also had the privilege to, when I was looking at my career, my advisor, industry doesn't do serious research. That was the common theme when I was doing PhD and postdoc in the US. I had the pleasure of visiting many of the R&D facilities of companies, and I was ashamed at the way I did research versus the rigor with which they did, the replication, the control on the inputs and the reagents, everything. It was, and the depth of research was quite extraordinary. So, so definitely thank you for bringing the nuance of when it can cross over to be actually inhibitory of innovation. So we need to be mindful of that. And I saw that example in another sector, in foot and mouth disease, where the lowering of the price was leading to industry not making any profit, would make loss. And you cannot expect innovation or investment when you actually reduce it. So now, thankfully, that has started to change. So I'll come back to one more area that I think going further down, Dr. Kavita, you reflected on it, but it's open to any of you, especially Anuji or Dr. Taruna. So how do states and others use this? And what do we need to do to ensure more and more usage, especially when they are defining RFPs and when they are defining procurement criteria? And the problem is, it's not just one place where you can go and it will solve. We have multitudes of states, multitudes of products, multitudes of RFPs being issued, procurements being decided. How do we tackle this distributed, which is a strength in a way, but when you have to scale it and cascade it, it's a challenge. So would love to hear any of your thoughts. So feel free to come in. Anuji, if you want to come in, please.
So we've really tried to engage the states on the concept of HTA, and we've tried to onboard them, and one mechanism has been that we've had a number of consultative workshops with them, and we also have nodal officers from each of the states on HTA, and now we are also in process of forming HTA committees in the states, and many of the states have actually come up with these committees wherein they meet every month, they decide these are the topics of relevance for which we need a new technology has come, or there is a new problem and there are multitudes of solutions, and they need to know which is the right way, and they need some kind of HTA guidance. So we are actually requesting every state to now have this, but some of them, the more progressive ones, the more receptive ones, have already started doing that. And we've been trying to answer their questions, we've been trying to respond to their queries. We've been also kind of hand-holding their resource centers. There are a number of resource centers in each state, and we are trying to empower them that they can respond to their queries and kind of help them. The biggest question that has come to us from the state government, and I remember Health Secretary of UP asking us, how do we procure them? Okay, you've done an HTA, but now what is the mechanism? So like Dr. Kavita said, that we are now trying to onboard all the technologies that we've done HTA on. We are trying to onboard it on the government e-marketplace, that is the GEM portal. We are also working on individual portals of other states, because many states do not use GEM, but they have their own mechanism. So we are also trying to onboard all the technologies on them. And we are also trying to sensitize the innovators on what do we need from you when you are trying to do some kind of when you want that HTA should be done, so that early on they are ready with the evidence, because HTA is essentially based on evidence. So early in their development they start working on the evidence generation part also. And we are also trying to kind of hasten our speed. We are trying to work on a different kind of HTAs. Sometimes we are doing an adaptive HTA when there are some kind of provisional HTAs. If the program requires that a particular HTA has to be done quickly, then we do a provisional HTA, and then we do a classical HTA when the evidence comes in full. So we are trying different kind of methodologies by which we can engage the state governments as well as the program divisions of the ministry.
Thank you. That's very helpful, and I guess it's going to be a progressive, continue to improve with, and once the state gets involved, I think within the state itself, dissemination process will need to take place. So, couple of questions. I think I see them as two sides of the same coin. One is to Dr. Kanitkar. How should we try to inculcate this thought process in the medical curriculum? And then the follow-up question will be to either Dr. Kavita or Dr. Tarun. One of you figure out who would want to answer it, because you have this from this perspective. There are many innovators in this audience and in the meeting. How should they be aware of? Because just like how you need to know the regulatory pathway very early on, now HTA also is something they should be. So these are two questions. Dr. Kanitkar first on the medical education.
Like I said, I think sensitization is something, and we can sort of start, I know it's difficult, but it will have to start with capacity building of the faculty. Because faculty, once the faculty is trained, they can get reflective practice in students from initial stage itself. Because adding a course would be a tick mark and would not achieve the thing in today's day and age. Because unless it's relevant and meaningful to the undergrad, he's going to just learn it like a short note and give an MCQ, which is not the aim of HTA. HTA is when they start reflecting on things, whatever I do, what is the impact of it, how relevant it is, and how it will help for the larger good. I mean, if we just start this habit, I think that would be a way, and therefore for that sensitizing, and I'm really grateful, like I said, the centers that have come up and the states who are getting into it, but involving the medical schools, involving faculty there in these processes, I think would be a way. Today, it is still a silo. I mean, you have the experts, you have this thing, but if it wants to come into everyday thing, it'll have to be the project is done by these centers, but there are different colleges, different students engaged like a project, and that would translate into a very good way.
Thank you. And about the how to sensitize, or how you are sensitizing the innovators, would you like to? Innovation ecosystem in India, there is like a broad innovation ecosystem who are developing products. How to get them to be aware of HTA, so that while they are developing the product itself, they are aware of it.
So as I mentioned, MedTech Mitra, so health technology assessment is an integral component of the pathway that we have for the innovators, if you see our website. So we do analyze the technologies before onboarding them, as ma'am said, with a provisional kind of assessment by the committee that whether this technology is, and that's how we are sensitizing the innovators, that we will be evaluating. So if they already have a predicate, so the benchmark that we have given by our Director General is 1/10 of the cost. So if 1/10 of the cost is being aimed for, that is going to be definitely a technology that is worth investing for. So
the ballpark estimator.
Yes, yes.
And for those who may not be engaging with MedTech Mitra, how do you, because not everybody in the innovation ecosystem probably goes through that. So how to reach to them?
Uh,
There's all these incubation centers,
we are holding workshops regularly, MedTech Mitra workshops. We have already held 9 workshops at different places. So one was held in Niti Aayog for the Atal Innovation Mission Incubators.
Okay.
One was held at IIT Delhi.
Mm.
The other one was held with the GEM people, the most recent one. We had 2 with the regulators because that is the key area where most of the innovators fall because they are not aware of the regulation. For example, I'll just give you an example, a very recent one, that an innovator comes to us and he actually gets a grant from us. And then he realizes that he thought that he's going to do an academic trial because both the components that he's using in his formulation for developing an anti-diabetic patch, they are already approved. But he missed that whenever you are combining 2 approved things, it becomes a new formulation. You don't know how they are interacting. And so safety studies are mandatory and CDSCO approval is. So there is one thing called IND, investigational new drug, and then we have a new drug or a new formulation. So at many times we have seen that if that guidance is provided at the first step to the innovator, they really, that smoothens their, often people say MedTech Mitra is a highway for innovators or something like that. So.
Yeah, no, thank you. So my job has been made very easy by targeted, informative ways fellow panelists are responding. So I'm going to do something by expanding the time available where we can have an interaction with the audience. So we have, so let's start hearing some questions, thoughts. Please be specific with your question and see if you are going to address it to anybody, mention their name. If not, just say anybody can address. So I'll start. I saw the hand back there, gentleman first, and then I'll come to you. We'll take 3 questions at a time so that there is a time for processing also while it happens. Please. And just say your name, who you and then.
Hi, my name is Nachiket. I'm from PATH. My question is to Dr. Kavita and Madam. In Europe, there is UNETA 3.0 framework, which looks at evaluating drugs beyond simple cost and health consequences, right? So in the Indian side, on the Indian side of HTAs, most of them are still revolving around costs. So is there a way that we are trying to mature to evaluating these technologies beyond costs? Because we looked at, health outcomes, now we are associating costs, but social, legal, technical, user acceptability, are we trying to look at these things going forward? Or at the crossroads of decision making, you guys are there on the panel, so are we still trying to make these decisions based only and only on costs?
Yeah, thank you. We'll come back. Thank you, Mr. Nachiket. So second question.
Thank you. My name is Harshal Kale. I am from the World Federation of Hemophilia, and thank you for touching the point of care and the industry aspect in the discussion. My question is more towards Anuji, that how can patient organization or civil society organizations play a part in HTA to make the decision and patients' voices heard?
Thank you. Very pointed question. I saw this hand first, and then next round we will come to you, please.
Hi, my question is actually for Kavita ma'am. So I'm a health economist.
So your name, please?
Aprajita. I'm Aprajita from NUS. What, according to you, is the best perspective to get started for HTA in India, considering it's such a complex and heterogeneous society? In the sense that, do you think that a health system's perspective is what most of the innovative technologies, like that is how you assess most of them? Is it only direct costs, or do you take into account opportunity costs or productivity loss costs as well? Because that obviously makes the model more and more complex. So what is a good starting point according to you? Thank you.
Since it is a fresh mind, you want to respond to that, or you would like to have some time? Yeah.
So that was a good one. To all the innovators who are here, for using or for doing a health technology assessment, you calculate something called as an incremental cost effectiveness ratio. It is a ratio between cost and quality, the health outcomes. And when you say cost, we are not only taking at price, we are looking at cost. So it is a health system cost that you're taking. For example, if it is FT engineered syringes, we are not only taking that 1 rupee of that syringe, it is actually that area where that immunization program, for example, if it is used in an immunization program, that area, the infrastructure for that, the human resource for that, the consumables for that, the equipments which are used for that, including overhead. So your question is, we do use direct, indirect cost. If it is an IPD procedure, we even take laundry. So all the indirect cost, management services, direct cost, human resources, consumables, equipments, all put together in that particular facility. For example, this is a facility, there are 100 people coming here through the year. So we do an annual costing for that. That annual costing is brought down to per person. So when we do an incremental cost effectiveness ratio, it is a comparison between the intervention and the comparator cost. It is divided by, it is a ratio between the cost and the quality. So the intervention, what is the quality it gains? The comparator, what is the quality it gains? Once you get this ratio, it gives an incremental cost effectiveness ratio. That we take it as our benchmark. We don't stop there. We also do a sensitivity analysis to see whether the cost is playing an overrole on that, is quality playing an overrole on that, is the equipment rate playing an overrole that. Without a sensitivity analysis, your study doesn't get completed. Thank you. I hope I could answer that.
I think that covered first question as well as so the question on civil society and Anuji, you want to?
We are seriously thinking of formalizing this arrangement, but right now our interaction point is the consultation that we do, the stakeholder consultation before we actually take the HTA study to the board. So before that we do a consultation, and we'll be very happy if you would like to join us. To the first question, wherein I'd like to add to the first question, when it was said that is it just the cost? It's not just the cost. There are many other factors also. And I remember a cataract study wherein although the cost was more because it was favoring women, elderly women who had maybe lost their eyesight because of working in the chulas and other things. So we kind of prioritized that. So it was not just a question of cost there. So there are different factors, and like she said, the value-based pricing, that also plays a very big role. Thank you.
Dr. Yeah.
I'd like to add that the civil society has a really great role in this, because advocacy comes from them. Advocacy comes from civil society. Is it right?
No, still off.
You can switch.
So I think advocacy comes from civil society, because like we started in the beginning, is it relevant, is it required? And a lot of qualitative analysis also goes into it, because the quality of life and outcome adds to the assessment for a health technology. So I think it's very, very important that, and a case and example, I'll give you rare diseases in pediatrics. I mean, it was advocacy which got even courts ruling, which overrode everything for government funding. And even for that matter, when we are doing RFPs, even the government system permits a dual of giving a quality-based, QBQC, which we actually put in the quality requirements. So I think that will have a very big role in the HTA's analysis.
Yeah, thank you. Dr. Puri?
Maybe one thing to consider, because it's a very pertinent question that you asked, but you had asked me earlier, so I'm just adding to that. One thing that other countries are doing now as a new thing is to add the societal value. And why am I saying this is, especially ma'am, what you mentioned in pediatrics, and ma'am has already hinted on, the cataract study. They have actually evaluated the increased workforce capacity that you add, the educational advantage pediatric population can have by getting treated early, and then the reducing the caregivers' cost also, and then adding to the component, like ma'am said, on gender equity, women, right? So if you can add that societal value component, and there are studies from Y4 Institute also now that have come, which are actually using this as a benchmark, then to say, yes, that's the sort of value assessment that will give a more comprehensive picture. So I think maybe the way forward, but of course we are already there, and I think it just needs to get more institutionalized, because that's really giving us the real cost, the hidden cost which is usually missed, to get included in the technology assessment.
Thank you, Dr. Puri. So gentlemen first, then Dr. Angela, you're second, and gentleman in the back third. We'll take 3 questions, so we'll come back to the next batch, please.
Thank you, Sindhura. One comment and then a suggestion to the ICMR panel. Thank you to the ICMR team, especially Taruna ma'am. We've been dealing with
Please mention your name. Just
Dr. Karunakar Reddy, a physician and come from the industry part of it right now. The ICMR does about 1,600 crores approximately of funding and all. And just suggestion to is that, it's not widely known that clinicians can be taken, how do we do it and all. A point to Dr. Kanitkar and Dr. Anu Nagar is, can we incorporate something like an FDA investigator? There's a 3-day program in the US, coming back from the US, where the US FDA does that for all the clinical investigators, potential clinical investigators, a 3-day program. Something can be emulated similar to that to the Indian society, so that there's an exposure to that, and as well as to the MedTech Mitra and all those things. Kudos to the job ICMR is doing. So we just hope that more and more awareness is given out or shared in the public domain. Thank you so much.
Yeah, thank you. Second question, Dr. Brand.
Yeah, Angela Brandt, Maastricht University and Mahe, and I've been working for 30 years in the field of HTA. And and knowing David Bunter from 30 years back, and I think he would amaze to see how HTA developed, and especially in India, because I think the approach in India is the most innovative from my perspective now. And I have one maybe question, suggestion, and because I was fit for purpose, the different needs we have to address, the societal impact we have to address, etc. And there's a small community, the health needs assessment community, and maybe to join, because I see as one system also ecosystem, the health needs assessment, health technology assessment, and then the health impact assessment, which is a policy side. The intervention we did, what we did it really had an impact? So maybe could that be maybe the next step? It's I don't know any country where it's implemented, but I could see really it could come together as well.
Thank you, Dr. Brand.
So my name is Dr. Paul Campbell. I'm the Chief Regulatory Officer with Health AI, the Global Agency for Responsible AI, and a former hospital clinician. So thank you very much to the panel. The comments were excellent. The insight was phenomenal. I have a question for you. You spoke about the time that it takes. Do it early, it takes 10 years. You spoke about the quality, the need for evidence and proof. And you spoke about the process, document it and have all the evidence, these steps that need to be taken and do the NHTA assessment. In the world that I'm in the world of innovation and digital, I hear lots of people saying, that all takes too long, we don't need to do it, this is a changing world, we just need to go ahead with it. Why do we need to even, they rail against regulation and evidence? Do you either have any suggestions back to them, or do you already have any processes in place to deal with this sort of more rapid approach? Thank you.
Yeah, let's start with the first question. Can we have a 3-day program, something similar to FDA?
I think, Dr. Reddy, it was a fantastic suggestion, and definitely capacity building, enhancing the skill set of our innovators is one of the key point for us. And we are in that process, but yes, something like formal, like 3-day program and 3-day initiation to that, we can definitely think about it. And I also wanted to add one point that I forgot in my first this thing that how innovation ecosystem is being evolved at ICMR. So there is one new grant that we have come up with, which is called First in the World Challenge. So we have really involved industry also as part of it. So the idea is to de-risk the industry so that we can support these studies, and then they can make these innovations available to Indian public and to global globally to other developing countries as well at affordable cost, to make them more accessible. So that is the one of the major Viksit Bharat goals that we have proposed. So this is what we are aiming for. Thank you.
Thank you.
I'll just add, taking Dr. Reddy's suggestion, I think it was brilliant, because today ICMR, thanks to them, like the postgraduates all do a BCVR, which is compulsory, and at the university level we put in certain courses like molecular methods, advanced research, GLP, GCP. I think we can definitely introduce it straight away.
Thank you. The next second question was probably the most interesting and very difficult. Like, how do you have the follow through to complete the cycle? Dr. Angela Brandt's question. Who wants to take that in the panel? Yeah. You want to take it?
I can only echo. No, because see, you're very right. The first step in HT assessment is horizon scanning, to basically understand what are the needs of the... So the first step... Yeah. Other session, yeah. No, so I was just saying that I can only echo to what you just said, because the first step of HTA is horizon scanning to understand the needs of the ground, from the ground, which meant that the perceived needs, the felt needs, and the unmet needs. Only when that you can take it to the next level of, multidisciplinary approach. Does this require, value assessment now? Does this require cost assessment? Does it require only quality of life assessment? And then moving on to the participatory framework. So from my side, of course, there's more that, we can have from the government side, but I totally echo the first step has to be need assessment.
Yeah. You want to add anything?
From the government side also, yeah. So we look at not only, so when we do the system costing, we look at the health system perspective. But Madam already added key, when we are doing the assessment, when we are looking at evidences which are available, it is completely societal perspective. We look at the evidence and then comes the final recommendation. So we put in both these things. Costing, of course, yes, we are still doing only the health system costing, but the perspective is definitely looking into the societal perspective also. Thank you.
Thank you. The third question was on how to speed it up. Anybody wants to take that?
Yeah. So, yes. So when we are looking at different kinds of evidence, so we are looking at evidences like, for example, a randomized clinical trial for that particular innovative product, an observational study, a cohort study, a study which is multi-centered study, a retrospective study, and a prospective study also. So all these are evidences which are put into it. So when we all do an health technology assessment, the most important thing that we have to understand is that the difference when you look at efficacy and effectiveness, there is a model which is being put when we are doing an health technology assessment. A decision tree model or a Markov model. Markov model, when one state goes to the other state and you come back or you keep rotating between the state. All these things, the transformative model datas, the transition probabilities datas, the risk probabilities datas are all being taken up from evidences which are published. Sir added that other countries are now looking at real world evidence also. India has not gone into real world evidence, but when we are working with a state government program, a TB program, or a maternal child health program, or a child care program, they already have real world evidence. For example, a topic came to us where they had a portable ECG machine being deployed in Ahmedabad district. They wanted us to see whether if you upscale it, is it going to be cost effective. So we already had data in Ahmedabad ki when you roll it out, what are the other things that it can do. Today, there are 371 machines being deployed across in primary healthcare centers. So data from real world evidence, data from published literatures, data which innovators, that's why we have a meeting with the innovator to identify what kind of data that he is already having. A comparative data. If it is a safety engineered syringes, he already has the sensitivity, specificity, comparative data with the disposable syringes. Data is available. We look at the quality of data that is put into the model. Model will finally give you the incremental cost effectiveness ratio.
Thank you, Doctor. And models get better over time. The more you do it, it gets faster. So there is that.
Let me add to what Kavita is saying. So we also have the advantage, the department also has the advantage of having a ICMR with us. So whenever we find that the evidence is not good enough and we feel that the product is really good, we request Dr. Taruna's team to actually find out evidence for us. So that is another aspect. Thanks.
Thank you. For you first, and then no, there is a lady behind you will be second, and after you will be third.
Hi, my name is Saurabh, and I am from India Health Fund, and my question is targeted to Dr. Kavita actually, and I wanted to understand how the evidence of HTA is seen by different payers in the health system. And why I'm asking this is specifically because India has so many payers. There are civil society organizations, there's philanthropy, there is government, of course, and then the large part is the patient itself, and there is a high amount of out-of-pocket expenditure. So when we say that the technology is cost-effective, how can we make a patient understand that it is cost-effective for them? Because for them, willingness to pay threshold is very different compared to what the willingness to pay threshold is for the government or for the philanthropy or for a hospital. So if you can highlight a bit on that.
Thank you.
Thank you.
Please pass the mic back.
Hello everyone. My name is Dr. Vasudha and I am one of the co-founders in a startup called Curexcel Technologies from Bangalore, and we have developed painless injection based on hollow microneedle technology. So Taruna ma'am, question is for you. You talked about the predicates, right? So my specific question is, now when we go through the CDSCO processes, the predicate can be from anywhere in the world or it needs to be from India only, because we recently had a meeting with the MedTech Mitra people and there we heard otherwise. But initially we felt the predicate can be from anywhere in the world. So I would like some confirmation along those lines.
Thank you.
And yes, the cost assessment, you said as a ballpark, it has to be in 1:10 ratio. And how stringent, yeah.
That's why it's called ballpark. Okay, good.
Yes. Thank you.
Important. Yeah, thank you. Yeah.
I'm Dr. Satish. I'm working in Vadwan Institute of Artificial Intelligence. My question is on the background of emerging technologies like AI, blockchain and all, and the speed at which they are hitting the market and a lot of pilots going on around. In such case, my question is to each of the stakeholders, academia, as well as to the regulators and to the industry also, how each of you are going to match with the storm which is coming like this, where industry is in hurry of releasing more and more better kind of drugs or software as medical devices. Regulators are having already one thing approved in March, but in 2 months, someone else is coming with much more affordable AI model and all. While the capacity building through the academia or the universities, how this is going to happen so faster. So each of you probably throw some light on it. Thank you.
Thank you. I think this will be the last round of questions we'll be able to handle, and then we will wrap up. Let's start with the patient. How do make patient understanding the first question in a patient's perspective?
Thank you. So I think when we do an health technology assessment, the first thing that we design for that particular research question is the PICO. The population, the intervention, the comparator, and the outcome. I'll take a small example. It was an intradermal, long-acting, reversible contraceptive. The population, the women in the pregnancy. But what was our outcome when we brought out our final recommendation? We do not just tell that it is a cost-effective technology. We also tell how many life years they will gain, what will be the out-of-pocket expenditures that will reduce, When you compare it with other long-acting reversible contraceptives, how many side effects you can prevent it. You will also tell comparative with not only long-acting, if it is short-acting also, how many injections you have to take, how many times you have to visit the hospital, how many outpatient facilities you have to visit. So all these things calculating, so the population will know what it is. For example, for this long-acting, we even calculated for the government. So for the civil society, the population knows ki out-of-pocket expenditures, how much I can save, how much of side effects will be reduced if I am going to do this. Civil society who are going to be giving this particular facility, we even said ki about 6,400 crores the government can save if they roll it out in this particular phase for this particular population in this particular districts. So that kind of recommendation, so our studies are all available on the website. The reports are there, the policy briefs are there, the recommendations depend on each of it. Finally, we also give a budget impact. For the government to roll it out, if their program is 2,000 crores, they will need an additional 800 crores for rolling out for this program for this population. So all these are there in our recommendations.
Okay, thank you. Second question, it's a very specific question. Predicate, India versus global accepted as well.
So the clarity on that is that anything can work as predicate only and only when it is approved in India. If it is approved abroad by US FDA or by EU, and if it is not approved yet in India, cannot serve as a predicate.
Thank you. And the third, yeah.
Absolutely. It'll be a new.
Yeah. Thank you. And third question, it's a bit tricky one to answer. How do you handle fast cycle of products coming with emerging technology? Who wants to take it? Maybe from the industry side, or who wants to take it?
I will go back to what Dr. Angela has said, the need assessment. That's very, very important. We may have any technology coming in. It could just be an incremental technology, which probably is not going to add a lot of value. But of course, it's a disruption in the sense that it's incremental. So I think going back to the cycle of need assessment, is this really the need? As any technology coming in, digital technology for that matter, is that the need for the, let's say, for the country right now? If it is a need, what sort of population will it serve to? Is that a priority population? Is that a vulnerable population? Then going back to the framework, multidisciplinary approach that we talked about, is this what a public health intervention will help in a long term versus is this only for a very limited set of population that it may impact? And then going to the cost, and the cost in terms of value again. What is the value it will bring for the patient and for the government to bring in that technology widely and assess it widely and make it. But the biggest challenge which I feel is the ethical consideration. Most of the time, and I would say that when I say we, I don't mean myself, but industry in general, which is innovating, is about ethical consideration. What are we trying to solve for? I think keeping all those aspects in mind will actually help making that decision whether we need to expedite the technology assessment for this versus other technologies, because of course with the landscape that we are in, every day we have a new technology coming in, and I think you can answer more ma'am, because you must be at the front end of receiving all these applications.
So there is always a prioritization we do. So, and prioritization is in that order, what are the national health priorities? And they are ordered, and we see what is coming, and then we compare what is available in the market already to the people, and then what is the need, as she rightly said, that we assess the need. So it is national health priority that always gets the prime rating.
I'll take the one on academia. I think it's very simple there, because today academia is not about giving them fish, but how to catch the fish. So if we, therefore, it comes back to training people to do their own analysis, just the way in postgraduate education we teach them how to review an article, evidence-based, how to derive that. And in fact, AI here is going to be positively helping them, because you don't
Thank you. I think we've come to the end of the session. Anuji, would you like to have one last word before I thank all of you?
It's working. It's working,
Working,
right?
yeah.
Thank you. So I would just like to say that we are all really very keen in the department to take up HTA forward, and our basic objective is to make our technologies more affordable, more accessible to the country, and there is a whole ecosystem that we are working on, right from what MedTech Mitra was explained by Dr. Taruna. We also have a patent Mitra to take it forward, and like Dr. Monica said that, if we all work together, there is no reason for anybody to fear. So we have to be all working together, and without industry support, there can be no advancement, there can be no HTA. So it has to be with you all and taking all your concerns. And you know that in countries like India, like England, like UK, HTA is kind of mandatory. Here it was a policy decision not to make it mandatory. It's an advisory thing, right? HTA we would be taking up as an advisory recommendatory role, and definitely we would like to take it forward. Maybe 10 years from now we might think that, oh, it has to be made in form of a law, but right now we feel that the time is not ripe. The time is to take everybody together. Time is for sensitize everybody. We are also, like ma'am, I'd also like to tell you that we also encourage a PhD program on HTA. We've just started fellowships last year. We have a UGC course now. We have about 5 universities working on HTA. So we are taking all this very seriously. We need to build the capacity of people, take everybody together. So I think this is all I would like to say at the moment.
Thank you, Anuji. And thank you, everyone. I don't know about all of you, but I learned a lot being part of this. So I have to thank Anurag for twisting my arm. And I think we learned and we had some fun, hopefully, and appreciate. And this is a start. Right? This is going to be a continuous process. And hopefully this will set off a conversation and an engagement from broad spectrum, which is what is needed for this process. So thank you for making me part of, let me say, all amazing women panel. So I'm privileged here. Thank you. Thank you. Thank you so much for allowing me. I worked with many of your colleagues, but I just didn't get to face with you. Good luck. Wonderful work. Yeah, no, look forward to follow up. Yeah. Nice work. So please keep on. My name is Dr. Varun. Actually, we do. Please, please.
Good afternoon, everyone. This session has been shifted to MR16. If you are waiting for this session, this is in MR16. मैंने अभी इन बच्चों को यही बोला था कि वहाँ जाके खड़े हो जाओ, पढ़े लिखे नहीं है वो। अब
बोल देते हैं
सर कह रहे हैं कि इतना बड़ा बड़ा लिखा है सामने।
Is it good? Is it good?
One picture like the same as like I'm seeing the video.
You can take multiple pictures, I'll delete.
Hello, check one, hello.
Hello, hello, hello. Check, 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 check. Hello, check, check, check. Hello, hello. Check, 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 check.
Hello.
But I don't see you. See you soon. Okay, bye-bye. Wow, we have a microphone for each desk. This is amazing. Hey, Kapana. How are you? Thank you for coming. Good, good. Good. Please. Hey, Darshan. How are you?
Actually, there was no session before the session. So that's why everyone was speaking. Just we will tell the audience to come. Your all speakers are present?
We're still waiting to speakers.
They will be arriving.
Test, test.
Hello. 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 Check. 1, 2, 3. Hello. Check. Hello. Hello, Tara. Can you hear me? Good afternoon.
My voice is clear now? Okay, thank you.
Yes, nice to meet you in person. How are you? Good. Thank you for the collaboration.
Thank you for the collaboration.
Good.
All set, do you need any help?
We need Angela.
I'm sorry, but I gave her the wrong room number, so I'm just trying to trace it. She knows exactly.
Okay, okay. Very good.
You let me know, I'll be here if you need
Thank
any
you
help.
so much.
Okay.
Can you take some pictures?
For sure, I will.
Very good. How are you? Thank you so much for coming. Thank you. Always thank you for sharing our sessions. Really grateful. You are the chair, but when I met you, I will also invite you to provide some comments, presentation, because you have many years of experience and I'm able to share your views, how we can coordinate surveillance. Yes. Yes. Thank you so much.
Pranay is there. You can supplement. I think Himanshu is.
Dr. Tini, can you hear us? Thank you. Thank you so much for joining us. Yes, yes. So you and Kamal will be speaking at the beginning. So maybe after 10, 15 minutes. Okay, very good. Thank you so much.
Hi, testing.
Dr. Lee Cheng. Hi. Good evening. Thank you so much for joining us.
Thank you for coming.
Yes, and I saw your very nice slides. And then, we will come back to you during this discussion session. you have anything you want me to ask? A question to you? Okay, okay. Probably I may ask you, how you really achieve the innovations, and then what lessons that other countries can learn. So let's see. But there could be some question from floor as well. So thank you. Okay, okay. Sure. All right. Thank you. And for the speakers in the we can start. Yeah. Yes.
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 Yeah, looking forward to the session.
Yeah, yeah, thank you so much. Very good.
Yes. Are you staying on for tomorrow as well?
Tomorrow I will come to join the Swastika session.
Okay.
Yes, so tomorrow I'm here.
Okay, I will try and catch you at some point tomorrow.
Okay, okay.
I'll leave you to get into the zone for
Okay, okay. We have 3 minutes to go.
Exactly.
Yes, yes. Yes.
Good evening, everyone. Thank you so much for being here. So we will start our session in about 2 minutes. So please be seated. And if you want to read more about our session, we already had some hard copy documents. You can take it for free for sure. Please, it's at the back side. Thank you so much.
Can you take pictures? Can you take pictures? TV?
Do ones which are highlighted in red.
Yeah, 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 okay.
Let's go outside, bro. Yeah. Because once the session starts, it will not be good to come here.
Really? Okay. But we have. Okay. Good evening, Rajan. Thank you. Really? Okay. Come on, let's get started.
Sure.
Okay, again, thank you so much. Good evening, everyone. Welcome to our session on advancing multi-source collaborative surveillance for public health intelligence and decision making. This session will highlight the importance of synthesizing information from diverse sources for effective public health decision making, especially in the face of pandemic, climate-sensitive diseases, and One Health challenges. Without further ado, I would like to invite Dr. Sujit as our chair. Dr. Sujit is a former director and advisor to National Center for Disease Control India, and currently with over 3 decades of experiences in public health, he has been very instrumental in shaping Indian infectious disease surveillance and response system. Without further ado, I would like also to invite Dr. Rajesh from the IGIB as one of our panelists. And there will be 2 panelists that will connect with us virtually, Dr. Li Ching from Singapore and also Dr. Dini from Indonesia. So for the first session, I would like to invite Dr. Sujit as a chair to open the session. Thank you.
A very good evening to all, and welcome to this important session on collaborative surveillance and its implications on public use in public health intelligence. In this particular session, we have very eminent speakers, not only from India, but across the southeastern region. And in this, we have very experienced person from CRO, Dr. Kato Masaya, and he has been the champion of collaborative surveillance. I must highlight that he has worked relentlessly to see that how collaborative surveillance is strengthened not only across various divisions of health, but also across various other organizations as well. So I think what has been instrumental is the multi-source collaborative surveillance, and how that particular multi-source collaborative surveillance has been helping the surveillance in a using it as all hazards approach, One Health approach, and seeing to it that how that impacts not only the pandemics or the outbreaks which are currently occurring and which are likely to occur in future as well. So I think we have, as already specified, we have altogether 5 speakers in this session, and in this 5 we have 2 online speakers, Dr. Tria Dinhari from Ministry of Health, Indonesia, along with Dr. Kamal Mustafa, and we also have Li Ching from National Environmental Agency, Singapore. So these 2 will be the online experts who will be joining us. Apart from that, we have Dr. Pranay Verma, who is the Joint Director at NCDC. He will be joining us soon, I think, or he will be connected online, I don't know. Dr. Pranay, okay, he is going to be here in 5 minutes. So he will be there representing the National Center for Disease Control, my parent institute. And we also have a very, very eminent person, Dr. Rajesh Pandey, who has been very kind enough to travel all the way from Bangalore in spite of his very, very busy schedule. And he is from the Institute of Genomics and Integrative Biology, IGIB, India. And he has been using the genomic surveillance for public health aspects, and he has been my very, very efficient colleague during the time of COVID. I think you all know, and many of us learned genomic epidemiology during the time of COVID only. So I think we developed this particular collaboration, and I think the experiences which we had during COVID-19 pandemic and which we are using currently also will be very, very helpful in taking this particular collaboration for all future endeavors as well. So I'll stop here and I'll hand over the mic to Kato Masaya for his further comments and taking the session forward. Thank you.
I will do it.
Right, use my stopwatch. Oh, I don't have to use this microphone. I have this. Okay. Good evening, colleagues. First of all, thank you so much for coming to this session despite so many meeting rooms. I'm glad you find this room to join us for the discussion of multi-source collaborative surveillance. We will try our best to make a very interactive and then exciting sessions. Before we start, let me provide some presentation to set the scene, overview of multi-source collaborative surveillance. So I use this. This one? Okay. Okay, so Dr. Sujit mentioned about the COVID-19 pandemic, which everybody remember. During this pandemic or severe emergencies, what we learned is that we cannot just rely on one single surveillance systems. Decision maker continuously face different questions for which they have to make a decision. When outbreaks start to happen, that decision maker may ask, is this true outbreak? Do we need to, or can we apply rapid containment? When we have more cases, higher incidence, we may ask, shall we shift response strategies from containment to mitigations? When cases really increase as hospitals get overwhelmed, do we need a lockdown? When we have vaccines, we have to ask, is our vaccines working? When cases start to increase again, is this because of new variants? When number of the cases peaked, coming down, we have to ask, can we lift public health and social measures? And then when we are getting to normal status, how to transition to the normal status? So one of the important lessons we learned was that no single surveillance system will be able to respond to all the information needs that decision makers need. So in a different stage of emergencies, decision makers probably rely on different type of informations. For example, alert phase, very often we rely on so-called event-based surveillance, which is probably quite timely in getting some signals of outbreak. Then when we move to the more grown outbreak or pandemic, epidemics, we will probably utilize in so many different types of informations. Not only number of the case and death, but how is hospitalizations. We ask laboratory, what is the test positivity? What is the genomics variance? We may ask hospitals, what is the bed occupancy rate? How you are overwhelmed? We may also look into outside of the health sector, such as the people's mobilities. When we go back to the transition phase, maybe we may go back and say, okay, let's monitor the situation through sentinel surveillance, notifiable disease surveillance systems. So multi-source collaborative surveillance is a dynamic process, and then depending on the phase of emergencies, we may need to rely on different types of information. And then this is why recent WHO guidance documents talks this multi-source collaborative surveillance. On the left side, first two are from the WHO Southeast Asia region. One in the middle is a bi-regional framework for UPRO and CRO. And then the right side, this is a global guidance document from our WHO headquarters. So what is collaborative surveillance? This headquarter documents defines the systematic strengthening of capacity and collaborations. So not just the strengthening system of capacities, but we also have to have an intentional collaboration among diverse stakeholders, both within and beyond the health sector, with the ultimate goal. Goal is to enhance public health intelligence and improving evidence for decision making. However, when we visit countries, we see many countries faces lots of challenges of implementing multi-source collaborative surveillance. For example, each data has ownership, limiting or posing some challenge of data exchange. Insufficient coordination may sometimes lead to fragmented systems. Lack of registration or procedures for information sharing, lack of interoperable information platform, or workforce constraints. So how we can address these challenges and then move toward more functional multi-source collaborative surveillance. This is why our CRO worked with different stakeholders, come up with this manual, operational manual. And we brought a few copies, but very soon we will put into our WHO CRO website. At this moment, not yet, but in case if you like to see a digital version, please let us know. We are happy to share with you. This is consists of a 6-step process, starting with selecting disease or disease groups, then mapping surveillance system stakeholders, identifying decision scenarios. Then we invite stakeholders for the workshop to clarify surveillance objectives, identify surveillance approaches, explore synergy and the gaps. We also identify priority actions, develop work plans, and after the workshop, we try to implement prioritized actions to strengthen MSCS and review implementation, and then we try to apply these lessons to other disease or disease groups. Core process of this MSCS, multi-source collaborative surveillance strengthening, is to think backward. What does it mean? When we do surveillance, we collect the data, we analyze data, and inform decision making. But when we try to strengthen MSCS structure, we think backward. What decision we might need to make during the outbreaks, epidemics, pandemics? And then we translate this into the surveillance objectives, and they really explore what is the most effective, efficient way of achieving the surveillance objectives, identify surveillance approaches, and then we try to identify what are the priority actions to really operationalize this MSCS. At the end of the workshop, depending on the countries, they may select set of priority actions. We usually categorize into 3 different groups. First is system design and performance. Try to streamline surveillance systems, standardizing procedures, and then enhancing information systems. Second group of actions could be governance and coordination, strengthening or amending the legal framework, mechanisms, SOPs, sustainable and productive funding. Third group is workforce capacities, including technical capacities, but also capacities to coordinate different surveillance stakeholders. And then we have started working with a couple of countries. For example, last year we worked with Indonesia and Nepal. In both countries, surveillance stakeholders from different departments, institutions, sectors came together to identify priority actions to enhance MSCS. And today we are lucky to have a representative from Indonesia to share with us their experiences. To summarize my presentation, these are our key messages. MSCS, multi-source collaborative surveillance, is a systematic approach to decision-making that integrates and synthesizes information from multiple sources, both within and beyond the health sectors. MSCS may require strengthening of not only capacities, but also collaboration, such as surveillance system design, governance, and coordination, and workforce capacities. Regional manual proposes 6-step process to strengthen MSCS, thinking backward, starting from decision questions, translating them into the surveillance objectives, and identify set of surveillance approaches. MSCS is expected to contribute to further enhancing national and regional health security systems and the health system resilience. And then I would like to appreciate all these people and many other colleagues in contributing this concept, but also this presentation. Thank you so much.
Thank you very much, Dr. Masaya, for setting up the stage. And I think he has very rightly emphasized that when the decision makers require certain decisions to make, they require scientific data or scientific evidences. And to have those evidences in place, we need to have multi-source collaborative surveillance and to inform them that what particular evidence can be used for guiding the future decisions. It may be pharmaceutical decision, non-pharmaceutical interventions, or it may be other community-based interventions. So thank you, Dr. Masaya, for giving us that particular particular overview. And now we move on to the first online speaker, which is Dr. Triya Dinhari, and she is from Ministry of Health Indonesia, and she will be sharing her experience of implementing multi-source collaborative surveillance for dengue in Indonesia. So, welcome, madam, and floor is yours.
Thank you very much. Sorry, maybe Dr. Kama, can you help me to share the
Screen.
Screen. Thank you very much. Good evening, college. I'm Dr. Dini from Indonesia. We are very grateful to be here and in the World Health Summit sessions. And even though I could not join in person, we hope that we can share our experience in implementing multi-source collaborative surveillance. Particularly, we implement the MSES for dengue disease. Next slide, please. The dengue is the seem like an old story, but keep repeating and we keep suffering from the disease, especially when the dengue season comes. Especially in 2024, we see a significant increase of incident, about 3 times higher. You can see in the red line here. And during the time, we discussed that we should go out of the cycle, breaking the routine to find more data-driven decision making, involving various stakeholders that also have similar concern from dengue. Next slide. Then WHO introduced us to the MSCS multi-source collaborative surveillance, and we selected dengue as our priority actions. MSCS implementation in Indonesia is a long and dynamic process, facilitated by WHO from determining priority hazard, define objective, mapping of surveillance system, stakeholder workshop in July, and now we are on the implementation phase on the priority actions. One highlight here is to thinking backward from that from what decision questions we have to what information are needed to help us answer of taking the decisions. Next slide. Here some pictures to show how dynamic is the MSCS implementation in Indonesia. Not merely about the workshop, but really starting from back and forth discussion to really think and how data. I mean, multiple data we are used to sharpen our decision-making process together with various stakeholders. We can see the first when we do the pre-workshop. We chose the one province in Indonesia, Central Java, to try the MSCS to dengue. We start to pre-workshop to go to the government to Central Java, PHO. And this, when we do the discussion, the group discussion with the various stakeholders, and we define priority action at the national, province, and district level, including its periodicity. Next slide. During the process, we managed to formulate priority action, and we categorize them into the short, mid-term, and longer-term action plan to cover 3 objectives that we decided during the preparation phase. The objective is to early detect outbreak, to facilitate its assessment, and to monitoring trend. Next slide. As my last slide, just to show that we learn a lot and we are progress in implementing it. We also managed to revise our hazard calendar using 10 years data to see seasonality and developing one-stop page using the HIAS2, incorporating all data relevant to dengue. And once again, I would like to thank to WHO Zero to giving us the opportunity and support to conduct this MSCS. And we will try to several other diseases which are prone diseases in Indonesia. Thank you.
Thank you. Thank you very much, Dr. Triya, for highlighting an important problem of dengue, which is not only a problem in Indonesia, but also in all of our countries, including India, Bangladesh, Sri Lanka, and all, and other countries as well. So I think this particular experience which you have shown and how you have used the multi-source collaborative surveillance and how you have defined the objectives, and after defining objective you have set the agreed upon priority action areas both in terms of short term, medium term and long term. I think that particular strategy will be very, very helpful and trying to see that how we can effectively control, because when you have been able to control threefold rise of the dengue cases, so I think that will definitely set a good example for other countries as well. So thank you very much, Dr. Triya, for your elaborated talk. Thank you. And please stay connected, because we may have certain questions for you at the end. So I'll request all this audience who are very learned audience, and they will to be ready with the questions to Dr. Triya. So thank you very much. So now we move on to our next speaker, who is also an online speaker. She is Dr. Lee Ching. She is from National Environmental Agency, Singapore, and she'll be speaking upon collaborative surveillance for dengue in Singapore. So, Madam, floor is yours.
Thank you so much. Hi, I'm Lee Ching from Singapore. Thank you for this invitation to share our program. Basically, I will be sharing about how we use data to drive policy and operation using dengue as an example. Next slide, please. So, in fact, if you look at progression of dengue transmission, dengue infection, there are several checkpoints where we can intervene. And in fact, the framework that we work, the principle that we work, has been very in line with what Masaya has just presented, because it is very problem-driven. It is driven by objective. The use of data is really driven by objective. What is the outcome that we want? So if you look at dengue, there are three guilty parties, as I always say. There are mosquitoes, virus, and people. If you combine these three, it becomes a case. A person gets sick. And if you don't take care of this case, you don't protect this case, or you have all these three, if you are in a place with mosquito, with a lot of Aedes aegypti vector around, then this case could develop into a cluster, means it will spread in the community. And if you don't control this cluster, it becomes an outbreak. It spread across the country, it becomes an outbreak, or across a town. So if I look at this progression, there are really several intervention checkpoints. Firstly is outbreak. We want to be prepared for the outbreak. So we want, what we would like to do is to have an alert system. Can you push the button, please? If I just say next, yeah. So in fact, it's very important for us in a program to have early warning so that we can be prepared, whether it's materials, insecticides, manpower, or even it's very important is actually communication for social mobilization, to get people to do their part, because dengue is really a community disease and the solution comes from the community. So if you click on the early warning system, in this aspect, next please, clicking on the early warning button. I can't, yeah. So in terms of the alert system, we have got a dengue forecast that is built on a lot of data collected, multi-source, really multi-source. You can see the variable here, besides cases, we have the virus serotype distribution, we have the weather, we have vector population. And when we put this into models, in fact it's an ensemble model approach now, we can get an early warning to tell us how bad dengue is going to be this year. So this is really conducted in the beginning of the year. It's tracked through the year, but in the beginning of the year, it's very important for planning purpose for the year. Yeah, thank you. Next, please. The second part is actually risk stratification here. So if I want to be able to control dengue, I want to be able to respond early. So we push the whole response up to earlier, as upstream as possible. So we go to cluster management. And in this cluster management, we want, in this kind of a reactive intervention, we want to be able to stratify risk. Next, please. So in this case, we do a spatial risk stratification. This is a publication that we had using random forests. We can identify places with high risk. In fact, collecting the case data also tells us where the transmission is going. And this is an example of a post of a banner that is in the community, sort of nudging people to take part in this prevention effort by giving them data. So it's empowering the community to take action. Next, please. Overall, if I want to, another very important usage of data analysis and multi-source surveillance is a monitoring and evaluation, including the cost-benefit analysis of the program. So, next, please. Evaluation, so for example, I'm just giving an example here about our new Aedes control tool, Wolbachia. We use Wolbachia technology to suppress the mosquito population in Singapore. This has several publications that we have on this results, but it is so important. All the surveillance data and the data modeling has helped us to evaluate and see the value of whether this tool is working. In fact, we have seen 90% reduction in vector population and 75% reduction in risk of dengue in general, especially from the RCT, the randomized control trial that we have conducted. So if you look at this map here, you can see how the Aedes aegypti has been cleaned up in the town of Yishun and Tampines in Singapore through the years. Another very important aspect of a tool, of a program, is actually cost benefit. How important, how is it beneficial to have a tool in comparison to the cost that we are bearing? So this is again an example of our work on the economic impact of dengue in Singapore, and how we have shown in this study that Wolbachia intervention is in fact cost effective. And all this data is really helping us to move the project forward. So whether it's policy or operation, we want to be driven by data. Next, please. Just a click. Yeah. Nope. One slide missing. Yes. So overall, just use an example. Trying to demonstrate how we use big data, and I think this is a really important subject, multi-source collaboration. It is not, in fact, dengue control, vector control is under the Ministry of Environment in Singapore, Sustainability and Environment. But our data actually comes from all sources. It comes from Ministry of Health, ourselves, even transport card data, infrastructure data. We find the age of buildings and number of units of homes are very important, very significant factors that drive dengue. Another bullet that we have, I haven't put it in here, is actually wastewater. Recent years, we have also incorporated wastewater testing, and it has been very useful for not just COVID, but actually other diseases such as Zika as well. Okay, so now let's just bring us back to the first slide. On overall, how we use data is really looking at the intervention checkpoints and say, where do we need action, and how then can we be guided by data. And overall, if you click again, double click, you will see, we see over here the importance of surveillance. Surveillance not just on case, but on mosquito population, on virus genetics, virus including the genetics, and people's immunity and population immunity as well. So overall, just want to demonstrate how data and multi-source data is important for us to respond or to prevent a disease like dengue. Surely this is applicable to all other diseases as well. Thank you.
Thank you very much, Dr. Lee, for highlighting how big data or with different data sources can be used effectively to generate not only the alert signs, Risk stratification, I think you very rightly highlighted that how risk stratification can be used for community empowerment, and then finally using it for evaluation, how to do the cost benefit analysis with regard to the new tools, and how these tools can be helpful in controlling this. So I think this will this will also be very, very helpful in the other diseases which are transmitted by Aedes, like Zika, like chikungunya. So these all diseases, after understanding the transmission dynamics of these diseases, I think this particular, the presentation which you showed and which have been very, very effective use of how the data can be used, multi-source data rather. So you are in your country, I think Environment Ministry is doing the vector control. So I think vector related data and how the human data, vector data, laboratory data, all different sources of data can be used for public health intelligence, and then deriving the policy makers, policy decisions on that. So thank you very much, Dr. Lee. And now we move on to the next presentation, which is by Dr. Pranay Verma, who is a Joint Director in National Center for Disease Control in India. And we are taking clue from your both presentations. He will be speaking on One Health collaborative surveillance and sharing the experiences of Nipah experience in India. So Dr. Pranay, please.
So thank you very much. I do not have a presentation, but it's going to be an experience sharing, so I hope that I will be able to communicate the message. So for our colleagues who in the audience who may not be aware, the Integrated Disease Surveillance Program, or IDSP, it is basically the main surveillance program for epidemic-prone communicable disease in the country. And we have been in existence since 2004. So it is only last year that we celebrated 20 years of our existence. And over the years, because the disease landscape has significantly changed, the mandate and the scope of the program has also evolved significantly. And one of the aspects that we have put a lot of thrust on over the years is basically how we can improve collaboration with our partner agencies, the people we are supposed to work on the ground during the response efforts. And that is been undertaken at both at the ground level, at the central level, and this is something that I will be discussing about in my presentation. And the reason for this emphasis on collaboration is because of the concept of One Health, as we all know. Because as we are all aware, in the last decade, all the emerging and re-emerging conditions that we have encountered, including COVID, they are essentially of zoonotic origin. So the collaboration that we have to undertake with our counterparts from the animal husbandry side, it has to be significantly improved over the years. And there are some conditions which are of very important public health importance because the mortality is quite high, and one of those conditions is the Nipah virus disease, which is the experience sharing that I am going to do in this presentation. So Nipah virus disease, the mortality is about 45 to 70%, and it is one of the highest, and in basically in any of the zoonotic conditions. And unfortunately, we have been seeing increasingly higher number of outbreaks in India over the years. And it is really fascinating how the epidemiology of this condition has evolved, because the first outbreak that we saw was in 2001 from West Bengal. And after the initial 2 outbreaks, the focus has now shifted almost exclusively to the southern state of Kerala. And from 2019 onwards, we are having almost, outbreaks almost on a subsequent year basis. So for example, we had one outbreak in 2019, then we had one in 2021, then in 2023. And that trend was essentially broken last year, because last year after 2023, we had again another outbreak in Mallapuram district of Kerala in 2024. And the containment effort for that outbreak was pretty long. It was from July to September. So the people were on ground and the containment was ongoing for a long period of time. And basically it calls regarding the complexity of the situation that is there in the ground and the importance of having better collaboration with our partners when we are moving in the ground and basically trying to undertake the containment efforts. So, there as the epidemiology of the condition like Nipah has, evolved, so has our response efforts. And there are two aspects that I will particularly like to talk about over here. So first is the concept of emergency operations center that we have at the integrated disease surveillance program. So as soon as a condition of public health importance like Nipah, even the suspected case happens, the EOC at NCDC is activated, and that basically allows us to have a bird's eye view on the situation at the ground, and basically collaborate with our partners at the highest level at the ministry, and any kind of logistic support that our RRT, the rapid response teams need at the ground, that is undertaken at the EOC level. Then realizing the importance of having a collaborative effort at the ground, the ministry has notified, the health ministry has notified NJORT, which is National Joint Outbreak Response Team. So when a condition like Nipah happens, the experts from different specialties, for example, animal husbandry and wildlife side, they basically move in the ground at the same time, and basically it basically ensures that we have the resources at the ground at the initial level itself, so that the RRT can hit the ground running, and basically the collaboration is there from the very beginning. So at the ground level, of course, the containment effort calls for collaboration at the very tightly knit level, and there is there are different stakeholders. For example, in case of Nipah, that we collaborate with on an ongoing basis. So there are 5 stakeholders in particular I will like to mention over here, with which we work very closely for a condition like Nipah. So we have the animal husbandry side. So we have intermediate hosts in pigs and cattle. It is not commonly seen in India, but of course we have to take the serum samples to see that if there are any possible cases in the animal side. Then there is the wildlife side. So bats are basically the reservoir hosts, and for catching bats we need the consent of the wildlife department. So that is to be ensured. Then we have FSSAI. So half-eaten fruits and importation and exportation of fruits is one of the aspects in Nipah that has to be controlled from that containment zone. So that is undertaken by FSSAI. The most important partner for us is of course going to be the ICMR, the Indian Council of Medical Research, who basically handle the lab aspect, and they have the National Institute of Epidemiology, who undertake some kind of higher level of research like source tracking. And of course, lastly, we have the WHO, because even a single case of Nipah that calls for an IHR, and it has to be, the condition has to be notified, and we are basically in constant touch with our WHO colleagues to make sure that the trade and travel is not that much hampered from the country. So this is basically the collaboration that we collaborating agencies that we have, and the collaboration is of course going to be at 3 levels mostly. So at the central level, like I indicated, it's the EOC that basically undertakes all the collaborative effort. Then at the ground level, we have the joint response team, which has the experts from different specialties, and of course the most important aspect is the state government, because in case of Nipah, there in Kerala, the almost daily meetings have been are being held under the chairmanship of Honorable Health Minister, because she ensures that all the basically the people who are at ground, they have the appropriate resources, and any kind of policy implementation that needs to be undertaken, it is undertaken as soon as possible, considering the mortality and the chance of spillover that is there in a condition like Nipah. So this is in the nutshell the experience that we had in regarding Nipah. So I will stop over here, and any questions that we may have subsequently, I will be glad to answer them. Thank you very much.
Thank you very much, Dr. Pranay, for highlighting all the aspects. And I think he very rightly started from IDSP, or Integrated Disease Surveillance Program, which has been the backbone of all the outbreak-related surveillance which is being conducted in India. So I think he very rightly highlighted the effect of, or the how the PHEOC coordinates at various levels, field level to the topmost policy levels and decision makers. Another important aspect is regarding the joint response teams, which he has very rightly highlighted, that how joint response teams are formed after having collaborative surveillance at the grassroots level from the different data sources, and how that data sources expect the decision makers at the top for forming these joint teams. And very rightly in the end he highlighted all the stakeholders which are really effective in this kind of. I must mention that he mentioned an important stakeholder, that is the wildlife. Because unless and until you have the relevant persons or the data from the relevant sources, then only the data becomes useful for making a public health intelligent decision. So thank you very much, Dr. Pranay. And now we move on to the next speaker, who is Dr. Rajesh. And I have already spoken about him, that he's a genomic expert, and he has been working with the hospitals. He has also been working with the environmental surveillance, and he has also been working with the public health surveillance. And all three sectors were efficiently coordinated by him, and he provided the valuable data during the COVID-19 pandemic as well, and he is doing a wonderful job. So I'll just request him to give his thoughts over the view. Dr. Rajesh.
So, namaskar and good evening. So, when I was sitting here and listening to wonderful global thoughts about the theme, and I looked left and right around me, and I found that there is ample example of multi-source collaboration on my left and right. And then I looked in front and I found more evidence towards multi-source collaboration. I have my students who are the pillars of whatever we have done in my lab. We have our funding partner from Gates Foundation, few people I recognize. I can see one of the co-organizers from Ashoka University. So it's strengthening that multi-source collaboration. That's what is the theme, and that's what potentially we are living every day. But also important in this theme, when I thought what should I talk in next 5-6 minutes, is not to scare 50 odd people here in terms of diseases, infections, problems. But I think some of the efforts which we do together can also generate some hope. And that's what we as a group try to do in terms of integrative genomics of host pathogen, and whether our insights can generate some hope going forward. And when we say hope, what does it mean? So some of the points which we think may be important, and again more factors can be added to it, is why do same or similar pathogen infection leads to dissimilar disease severity? That's a question which, when we were part of SARS-CoV-2 genomic surveillance for almost 3 years of our life, 24/7, and that's not in words but in action, 24/7. That's what we learned in terms of why different diseases have different severity, different medications have different outcome, and what are the factors around it. So for most of us who may be aware about genomic surveillance, but any of you, if you are thinking what is genomic surveillance, it's like if you go to a society or a residential area, we can count the houses, which is like incidence cases, कि कितने infection हुए. But there are, if you want to go inside a house and count how many individual items you have within the house, which can be anything and everything, that's something called genomic surveillance, where we look at every base pair of that organism and try to understand that why this base pair is different from the other one, and whether that is having any functional role in terms of the disease severity. So what you see on this slide is essentially a sequencing based understanding of 50,000 SARS-CoV-2 genomes over a 3-year period of time from different parts of India. And they emphasized us few things, and those are that we should be continuously doing it. Why? The reason why we should keep doing it is because, for example, when we all have lived through the COVID times, and we would have realized that when vaccination was started, we thought that we have sorted our life. but we started to see vaccination breakthroughs. And then we wanted to understand that why this vaccination breakthrough is happening in some of the individuals and not all. And one of the reasons which was identified was through genomic surveillance, that in those some of the individuals, the viruses had some different mutations which were making virus capable in terms of escaping your surveillance mechanism. So this is summarized through it, but then there is two aspects of it, that I can do few things in my lab at my home, but what and how it is important for the community at large. So what you see on top right part of it is something which is very dear to our heart in terms of doing point of care mobile airport sequencing at the Delhi airport 2 times during the COVID times, wherein during Alpha and during Omicron, for all the patient, for all the international travelers coming to India at Delhi airport, they were screened for RT-PCR, and then whosoever was positive, samples used to come to the lab at the airport itself. So it was a temporary lab in that sense. And all those samples were sequenced, and then the result was given within 24 hours in terms of whether it is Alpha at that point of time or whether it is Omicron at subsequent point of time. And this was key decision, which was a key point to make a decision that whether that individual would be hospital quarantine or can have a home quarantine as well. So when we go a step forward and think that, well, there are certain mutations which may have impact on disease severity, and almost all of you would also remember something about all those halchal around remdesivir, and you would have heard that in some individuals it works, some individuals it didn't work, and again genomic surveillance was very, very useful to know that in some individuals SARS-CoV-2 had certain combination of mutations where remdesivir was not able to bind at its particular position in the SARS-CoV-2 genome, thus the proliferation of the virus was not stopped, whereas in some individuals it did. And when we looked at what you see on top and bottom is basically the patients, SARS-CoV-2 infected individuals who survived and SARS-CoV-2 infected individuals who didn't survive, and what you see differences in terms of the pattern of blue is basically the binding efficiency of remdesivir. And it shows that in the individuals who recovered had combination of mutations which made remdesivir do its work, whereas in the people who didn't survive, remdesivir was not able to do its job. So this is again multifaceted collaboration or nature of scientific collaboration in terms of how same genomic data can be used to understand multiple aspects of it. So this was what we understand in 3.5 years of SARS-CoV-2 surveillance, and then we thought that, okay, what do we need to consolidate those findings, and then we have done for last 3 years a lot of dengue genomic surveillance work, and again looking from the perspective that why patients of dengue have different disease severity, and some of the key findings shows that in different individuals of different age group have different severity of dengue. And not only that, when we look at from the gender perspective in terms of male and female, and again within females in terms of different stages of their reproductive life cycle in terms of pre-menstrual cycle, during the menstrual cycle, and post-menopause, we see different incidences of dengue. And then there are certain mutations in the dengue genome which are associated with disease severity. So the investigation or the quest for looking into this doesn't stop there, and we then took it forward, and then we looked at a subset of individuals, again in collaboration with hospital partners, that why people infected with respiratory infections have different disease severity in terms of pneumonia and non-pneumonia. And then again we went back to genomics and realized that in the individuals who had pneumonia, they had antimicrobial resistance. And because the clinician was not aware in terms of presence or absence, he or she gave similar antibiotics, but in some individuals it did work and in some individuals it did not work, and in the background it was the difference in terms of the AMR profile which made the disease outcome different in terms of pneumonia and non-pneumonia. So that was something which you see normally, a trailer transporting stuff from one place to another, but that can be fabricated to do genomic surveillance activity as well. And lot of work which we did was also in support and collaboration with WHO. And what you see here is also a kind of acknowledgement of the effort in that at that point of time, in terms of how micro labs have been the key in terms of taking sequencing to the samples rather than bringing samples to the sequencer, which would be the normal scenario. So that's where we would stop, and with just leaving you with couple of thoughts. Think about economics of genomics. How can we do it better? How can we do it bigger? And whether we can move towards sustained, sustainable, smart surveillance. Sustained, sustainable, both words are very important, and think how we can strengthen it further going forward. So with that, I pause and thank you for your attention.
Thank you. Thank you, Dr. Thank you, Dr. Rajesh, for explaining genomic surveillance in a very, very simple way with valuable examples, both from SARS-CoV-2, how remdesivir did not work, how it worked, then going down with the genomics in dengue, and also mentioning a little bit about AMR, how genomic is helpful in detecting that, how this surveillance or the resistance is coming in the antibiotics, and what is the implications of the genomic. So thank you, Dr. Rajesh, for giving us that particular perspective. And now we move on to the next speaker. She is Dr. Angelina Chaudhary, and she is CEO of Swasti, the Catalyst, and her focus of talk would be enhancing multi-sectorial partnership and innovations to enhance collaborative surveillance. Particularly, she will be sharing the experiences from Swasti, the Catalyst. Madam, please.
Thank you, sir. So I'm going to be the oddball here. My name is Angela, but I think Angelina is definitely a cuter name. It's a prettier name. Swasti is a public health organization aiming to add 100 million healthy days in the lives of the most marginalized communities. And when we work in the region, our foray into surveillance was essentially attending a crying call during COVID, where our communities didn't know when they were at risk of COVID or not. They didn't know whether they could go out and earn their livelihood. Because testing, RT-PCR and otherwise, was only available to the hands of the middle income and higher than that. And so our foray into surveillance started from wastewater surveillance, when you read a few papers and said, hey, you know, this seems like an equitable tool, because wastewater seems to be available everywhere. So we looked at some of the slums with open drains and said, let's see if we are able to build out a surveillance. That led to many different experiments, and we failed many times and we succeeded many times. And then it eventually led to a 5-city environmental surveillance program. After that, we realized that there's a lot of stories that a lot more can be done with it. One is, of course, we expanded wastewater surveillance, but then it was becoming very clear that climate had a very important part in what we were seeing in terms of pathogens. So then we partnered with IMD and said, hey, can we do something together with health data and what we are finding in environmental? Before that, we started getting really interesting inputs, not only from India, but also from Philippines, from social media. And it was actually social media, Facebook Messenger, and Twitter, where communities were posting symptoms that they had, and we were able to see, you know, validation of what was going on the ground much faster than the clinical or the hospital information. We weren't the ones who thought that, I mean, when we first started, we were answering a crying call of the communities, but it looked like city municipal corporations and district health authorities, they felt that there's information sitting out there, but they didn't have a feedback loop to do anything. And they're not health people. They're responsible for the health and well-being of their population, but they're not public health specialists or epidemiologists. They don't understand genomics. They don't understand health data at all. And they were feeling upset that they were feeding in this information, but they didn't know what action they could take. That is why we developed what was called the Precision Health Platform, where we knew that there were excellent, best-in-class institutions. We had the AIMS and the IGIBs and all of the excellent in science. Then we had people who were excellent in communication. There were agencies that really knew how to deal with government stakeholders like municipal corporations. That language, when we saw scientists speak to municipal corporation and district health authority, we could see that they were in different universes. They didn't know how to explain the science. They didn't know how the science could help them. It was funny and sad at the same. It was tragic because time was being lost. Then you had the media who was taking any kind of information and publishing anything, and there was a mess over there. We had hydrologists, geologists who were telling us about, where is wastewater, what is the environment. We had people from animal husbandry who had so we said, so these are all best in class, superior experts all over the place. But no, the story is not really being told. So what we do as Catalyst is actually a platform that gets people together and translate the language of each other to something that is more meaningful and which is actionable on the ground. And when we say ground, we're talking about cities and districts, not really so much at the national and regional level. When we're speaking about multi-source, from wastewater to air to climate to even people. Earlier in the morning, we were at another surveillance conversation, and there are farmers that are feeding in information from what's happening in terms of their livestock. All of this builds a really beautiful, more comprehensive picture that leads to actionable insights, and that's what Precision Health Platform is about. So some of the lessons I would like to share before I hand over to you is that having a common purpose towards what you were saying, right? Start at the end. Who is the end user? What is their stake in making that action? And then co-creating and developing the solution, not going there with a solution and saying you need this, but co-creating the end user approach. So in the Philippines, we had a mayor of a city, and she wanted to find where zero-dose children are, why there were TB drug shortages in some of the places, why the schoolgirls were suddenly dropping out. And I think she had multiple questions. And it turns out that when there's a volcanic eruption, and you know that Philippines has a lot of volcanoes, active volcanoes, and typhoons, there are certain migratory patterns and certain livelihood patterns. And that is how we were able to track where the zero-dose children actually were. We were able to say, these are the areas where TB shortages, drugs are going to happen. Similarly here in a few states and districts that we are working in, the district authorities are really struggling with making meaning, but they're also able to get all of the information together. So we have IHIP, IDSP, RCH, all of it belongs, they're able to unlock it at the district level along with climate and geotopographical information that then tells them how can we prepare better. So end user perspective, we need to feel brave to experiment and give a safe space to experiment, because you want to experiment, fail fast, have a proof of concept, and then have a protocol around it. We need to be able to be open to everyone's languages, and therefore there needs to be a unifying goal and a unifying language so that people are talking to each other, or experts and agencies are talking to each other. And ultimately, I think that those are the elements for a successful multi-source collaborative, because the benefits have to come really quickly. We can't just extract information. We have to take the information, make sense of it, and feed it back for action. And once we do that, I do feel that the collaboration and the surveillance will be sustained. Thank you.
Thank you. Thank you very much for bringing that particular perspective. I think it is very, very happy in your scenario that you have been using different source information, particularly which the information from different community level like municipal corporation worker, end users, and also the climate related people. So they are all different and working in silos. But when their information or when their particular understanding of a situation becomes information, which information, when collected and catalyzed by the organization like you, and it makes it meaningful. And then I think that particular information can be used by the government, by the program divisions for enhancing of for their own data or public health intelligence. So I think that particular aspect will definitely, so these kind of efforts need to be taken in different organizations so that the government surveillance efforts get complemented by such efforts in the community as well. So thank you very much. And I think now we have time for some interactive session. So Dr. Mustafa.
Thank you so much, Chair. And now we would like to move to the next interactive session. Please prepare your phone before you ask. We have a quick Mentimeter exercise. So we would like to quickly demonstrate the implementation of the multi-source collaborative surveillance that you already heard from all the panelists here. The framework, the experiences, and the involvement of various stakeholders. So just to set the scene, is scenario. The scenario is the new pandemic of respiratory disease X had started in October 2026. We do hope it's not happened, for just scenario. And the number of cases rapidly increasing. And also many also got hospitalized. And the hospital get overwhelmed. And public health experts are calling for stringent public health measures. On the other hand, National Association of the Industry is expressing the concern on escalating public health measures that might cause economic disruption or damage. You are asked by the Prime Minister if we should impose lockdown or should use less stringent measure to preserve our economy. Okay, I hope you already got the scenario. Now I'll move to the Mentimeter. Please scan the barcode here. Okay. Okay, I hope everyone already get the barcode. Okay, I will just start in a few seconds, sorry. Okay, I'll just stop here and I'll show you. Yep. Okay, if you haven't scanned the barcode, I'll give you 10 seconds or 5 seconds. Okay, thank you so much to give the likes and okay, we move to the first question. What information would you need to guide decision making whether we should use lockdown or not? So we try to help the Prime Minister, right? So you would like to see like, okay, what kind of information that we need to help the Prime Minister to decide whether it's lockdown or not? Okay, it can be anything. You can put more answer, it's fine, yes. Okay, we see here 7 responses. Severity of data or information on severity of diseases, great. Mathematical modeling, bed occupancy rate, active rate of infection spread, maybe. Okay, what is this? Maybe you haven't finished your, yeah. So please take your time. Transmissibility, yeah. Incidence, reproductive number, more data. Okay, we just play along with it. We'll see, oh, not available, what happens? But anyway. Okay, we see here, number of cases. Okay, great. We move to the next question. Who are the key stakeholders who can contribute to provide the information that you need, that you already provide in the first question, to get decision making on lockdown? From where or from who you can get that information? Okay, so just recreating the framework that already been explained by all the panelists. We start with decision question, okay, lockdown or not. And then we start to find information, what information that can support my decision. And then if I already get this information, from where I could get the information. Okay, we'll see here labs, clinicians, great. Community, thank you so much. I think it's inspired by Dr. Angela's presentation on community. Universities, doctors, laboratory, great. Surveillance, public health intelligence, municipality, virologists. Great. No one really mentioning about the economists, the economic expert here. Anyway, it's fine. Maybe still thinking, no? Okay, great. Finally, somebody put that. Thank you so much. Okay. Okay, great. Yes. So again, as mentioned by all panelists, that the collaboration, it's not only like within health sectors, it can be beyond. Yes, you can get information from the economists, maybe meteorologists, as mentioned by Dr. Dini during the presentation, and Dr. Lee Chings. Okay, this is the last question. What are the enablers that facilitate use of multiple sources of information to get decision making? Please select 3 options. What are the enablers? Is leadership and governance, enabling policies and legal frameworks, effective surveillance design, emergency operation center or information hub, interoperable data system, or trained, and also the last, trained workforce. Okay, you see, competing here. All are correct, but we want to see the dynamic, okay? So it seems the leadership and governance really leading. Just to tell you a story, in 2023, we conduct an exercise, like what aspect that really have a leveraging power to all aspects. And then one of the statistical analysis that we did, actually leadership and governance really like have a leveraging power. You know, like usually we conduct like intervention, we conduct training every year. The same training every year, right? But then the people change, the turnover, and then etc. But then we haven't really touched or really intervened the governance. So I think that's assumption is really being like exercised, and it's evident that statistically, based on our exercises, leadership and governance has very strong correlation with other aspects. Anyway, thank you so much. I think this is the end of our interactive session. For the next session, I will hand it over to Dr. Masaya. Thank you so much.
Very good. Thank you so much, Kamal. Very interesting. I hope you had some essence how we are trying to facilitate this multi-source collaborative surveillance. Now, we would like to ask questions to the panelists. But before asking panelists, I would like to also ask a question to Dr. Sujit. As you know, Dr. Sujit has a very long experience of leading, advising surveillance response for epidemic as well as pandemic-prone diseases. And then I would like to hear from him his views, experiences, lessons, how we can really promote this collaborative surveillance.
Thank you, Dr. Masaya. I would like to highlight 3 or 4 important public health problems which have been bothering our country or India. Number 1, acute encephalitic syndrome in Bihar, Muzaffarpur and other surrounding districts, which causes mortality of small children in huge number, particularly during the season when you have got ripe chilies. Workers are plucking chilies, their children are lying there, they are all right in the day before, early morning they develop seizures, and by the time they reach the hospital, they are dead. We did extensive investigation from NCDC side. We involved ICMR, we involved nutrition because it was agriculture problem. Lychees are there. Every year it is a seasonal problem is there. As soon as rain comes, immediately the problem is gone. So in that particular aspect, multi-source collaborative surveillance was very handy. And finally, the collaboration between the international stakeholders, CDC, they helped us to identify the chemical which was there inside the lychee, and when eaten by the low glucose level children early in the morning, that resulted in death. So just a small this. Second important aspect is from the Nipah, what Dr. Pranay has highlighted. When we went to investigate the Nipah in Kerala, we never anticipated Nipah can come to Kerala, because altogether around the Bangladesh border, we were having previous, and we assess the threat. You assess the risk assessment you do, and then try to identify the hazards which are going to be common in that area. But when it came, when suddenly from the lab, first sign came from the lab, And that particular lab-based surveillance was one. Then we started investigating the bat population. We did not have the right stakeholder also. We thought it's an animal husbandry problem. Then we came to know that it's a wildlife. So how to catch those bats which are high up in the trees? So efforts, a multi-stakeholder collaboration was done, and then try to see that how that particular. Here I would like to highlight the importance of the hospital surveillance along with the public health surveillance, and then trying to see that how this surveillance impacts the decision makers. So all these things, because we have to go with the public health measures, stop people, educating people, empowering community that you please don't eat raw food, half-eaten foods, particularly during this particular season. When you go for the in the jungle, then don't try to go for this. That is. Now coming to the next two threats which are going to be a problem. CCHF in Gujarat, all the states are affected with CCHF, and we have tried to see, we are now seeing some spillover in Rajasthan state as well. So we have to see what is the cattle prevalence of these particular, in this cattle population. So we have to have collaboration between the cattle. ICMR is doing survey, that data needs to be fed to the NCDC, and then with the state government and with the animal husbandry department, including the community, you need to collaborate all these things to see that this particular problem is mitigated to this. Another important aspect is the KFD, Kessunur forest disease, which is there in Karnataka. It started from Shimoga, now it has spread to 51 districts of our country. And we should be vigilant about that, that it doesn't spill over from our country, or we don't export that particular infection to other countries. So here again, wildlife, human sector, laboratory sector, and other sectors need to play a very, very important role. So I will stop here, and just to emphasize that how we have to work together with other sectors. We can't stand alone. We cannot work in silos. We have to see that this particular multi-source collaborative surveillance becomes a reality, the way in which it has been very well described in the book. So I'll request all of you to go through that, and please try to see that how best all of you can, in your individual capacity, also help this. Thank you.
Thank you very much, Dr. Sujit. Very clear, strong message. We have to break silo. We have to really establish collaboration for better decision-making and public health. Okay, now I would like to open the floor. If anybody would like to ask any questions to the panelists. Okay, thank you very much. Let's start from here.
Hello, everyone. Really nice to speak to you today. So, Ms. Angela, you spoke about the precision health platform that exists and how we're using that data for rapid surveillance. And Dr. Pranay spoke about the IDSP as well. So while I believe that this panel is talking about a lot of sort of collaboration that is happening in surveillance, so how are these two platforms integrating and using that data for good surveillance in our country today? That is something I want to ask.
Thank you for the question. So with Swasti, I am not sure if we have any kind of formal system of collaboration, but we do have, collaboration with other stakeholders, including the private parties. So with, private hospital chains and laboratories, we do collaboration, and we have our integrated health information platform. I hope that you may have heard about it. So that is the platform that is being utilized not only by IDSP but by many other programs, and it is basically, it is anticipated that ultimately all the programs are going to one day report on this, on the IHIP platform. And what is the beauty of IHIP platform is that it is possible to fetch data to the API linkage. So we are doing it with at many state level, because many states have their own system of collecting data. So they do not want to duplicate this data collection process. So we have told them that we will take your data through an API. And if Swasti wants to share any data with us, and if they have a system, then we will be more than glad to talk to them. And if it's possible to take their data through the API into IHIP, we can basically explore this going forward. And of course, Angela can supplement me with any of her.
I'll explain how it works for the Precision Health platform. Our end user is the person who brings all of the information together. So our end user is a district collector who also has, her or his own, health folks. So they bring in IHIP as one source of information. They also have other sources of information, population, climate, geotopography, right? They have the sources of information, where the health facilities are, what are they doing, how many beds are there. So we operate at that level, where IDSP information is one source of information that adds to the overall picture, that answers the question of the end user. We are in a few districts. One district collector may have 5 different questions than the other one. The idea is the approach. Multi-source collaboration is a tool to answer a question for health action. And IDSP and other sources are that information that adds to it.
Understood. Thank you so much.
Very good. So let's start from okay, lady here, and then you.
You just mentioned, Dr. Pranay, about IHIP, integrating everything coming into IHIP and collaborating with private sector. But within the Ministry of Health, you have HMIS. So is HMIS, I mean, today, if someone has to look into for health information, looks into HMIS or IHIP?
So, ma'am, HMIS is also in IHIP. I have not looked at their platform, but I can see the link that is active. And you know, IHIP is developed by the WHO team. And so they have basically developed their platform also. And it basically shows up in the IHIP homepage. So there is possibility of, you know, collaboration is there between IDSP and HMIS. Right now, we are not talking to them, but this is something that going forward, we are going to have better collaboration, and there will be cross-linkage of data also.
Okay, thank you.
I thought you are raising hand, yeah? And then, just a moment.
Hi, I'm Dr. Giridhar Gopal. I'm an infectious disease epidemiologist working in the monitoring evaluation role in Chai, India. Just to understand the question, the perspective of, you know, the core epidemiological principles of time, place, and person. We speak about multi-source collaboration, right? So how or what kind of systems and policies have been thought of to address this issue of, you know, having the data comparable in these 3 elements? The reason why I'm asking is because we've been supporting the vector-borne disease program and the IHIP through our CHAI extended work. But it's just when it comes to, you know, linking different databases to understand and gain insights, it's been a challenge, which we can understand. But moving forward, what has been thought on this regard? Thank you.
I can take that. Yeah, you want to take It's a great question, and I will say through experimentation, sense making, and ground truthing, correlations take time, and causality is a whole different kettle of fish. I won't go there. But I think that if we sat outside and looked at all the data sets, we might paint a different picture. And one of the key approaches of Precision Health Platform is to get the owners of those data sets in the room and get the technocrats who are on the field also in the room to say, hey, does this make sense at all? And many times right at the beginning, it makes absolutely no sense. And then we go back to it and we start work on it again and again and again. Many times, of course, you see that the data pipeline is completely dirty. You can't trust it at all. So it goes to some data pipelines. And so it goes towards improving those data pipelines, which is very, very important. Once people start trusting their own data, it's really about getting the people in the room who are responsible for that data sets to say, hey, we didn't know if our data set spoke to their data set. We actually know what to do with this. And this is why it's important to clean and update the data set. Oftentimes people are just entering information and they don't know what to do with it. And it doesn't make sense to them. So sitting together, we were in a meeting in Tamil Nadu and speaking about surveillance, a favorite subject, and a key stakeholder said, let's see what's happening. And everyone said, oh, we're not doing much. Turns out they're doing a hell of a lot. They just didn't know what each department was doing. And it was really impressive to see that, but also a little sad because it wasn't coming together to paint one picture. It was painting different pictures. So I think that, you know, getting the sense makers and the people who are responsible in the room and not doing it separately and feeding it back and then ground truthing it. So there was a team who went to the ground to see, hey, are our assumptions true or not? And many times they won't be, and then you keep going. It's an iterative process. And only when those things are clear can those magical two alphabets called AI come in. But not before that.
Okay, thank you very much. I see Dr. Pranay and Dr. Angela is very popular. Does anybody have a question to other speakers?
I will just like to supplement to what Dr.
Okay.
Angela has already indicated. So yeah, she has covered most of the boxes, but I will answer your question basically point wise. You said time, place, and person. So in IHIP platform, all the three coordinates are basically addressed. Time is there; it is almost real-time platform. Place is there because all the data is geocoded, and person is there because it is granular data. It is patient-wise entry of the data is there. Now coming to a specific question regarding vector-borne disease. So only yesterday in NCDC we had a big program regarding malaria. So I think it was Malaria Day. So and in that also our directors are basically highlighted the same point because the National Malaria Elimination Program is also active on IHIP. And the data that is being collected by them is basically the same data that we are also collecting. Now there are certain other parameters that they are using because they have to collect data. They have to their mandate is basically control. Our mandate is surveillance. So they are also collecting information from private practitioners, and they basically get information from private practitioners, and it is uploaded at the district level. So they have more comprehensive data, but the source of data is more or less the same. So I hope that answers your question also.
Okay, thank you very much. Question to other speakers? No? Okay, let's go.
Good evening, everyone. Very interesting panel. I have a question for Dr. Lee.
Yes.
Very interesting talk, ma'am. So in your machine learning modeling slide, you have mentioned cases and viruses data. I have a couple of questions on that. So in case of virus data, are you taking from mosquito host or human host? And also, are you using that virus data for the for your ensemble model in the early prevention thing?
Yeah. Thank you for the question. In fact, yes, it is mainly from human host because it's a lot easier. When a person is infected, you get sick, you are able to go to the doctor. I always say that it doesn't cause the mosquito can't scream that they are infected, so you will have to screen a lot of mosquitoes to find the virus. So we prefer to use the human host because they signal to you that they may be sick. Yes, the data is in there. We use the serotype. We know that previously, before we came up with this ensemble model, we just used lasso without the virus, but it wasn't very, it wasn't accurate. It wasn't very good because the herd immunity component is not in there. The population immunity to the virus. So what we have observed that when we have a switch in serotype, when there's a switch in the predominant serotype, we get an outbreak about 3 to 6 months later. Presumably, this is due to the herd immunity, the population immunity. So we have tried for years and finally quite successful to incorporate this serotype data, which is a proxy for immunity, into the model. And it seems to be doing very well. Yeah. Have I answered your question?
Yes, yes.
Yeah.
Very good. Can I ask a question to Dr. Rajesh? You have been really using this genomics, really showing the power of this use of genomics. If we can go back to beginning of the COVID-19 pandemic, would you design surveillance in a different way? We have really experienced, severe impact of, for example, Delta variants. If we can go back to the January 2020, how would you design the surveillance system?
Okay. So one of the numbers for surveillance during COVID time was agreed about were like 5% of cases to be sequenced. What we did not factor during that time was like what is the denominator of that 5%. And what we have learned through this experience that when you are sequencing in a situation where there is really high incidence of cases, then you have two problems if you do 5%. One, you are sequencing too many samples. and then you are not having a best scenario of capturing the essence of surveillance, because literally you are sequencing the same thing over and over again, because the variant which is driving that wave is literally the same, and you are sequencing high number with not much gains. So if I have to go back to 2020 March 27, when we received first 2 samples of SARS-CoV-2 in the lab, I may revisit these numbers again, and it probably, when it is a peak of the wave, I may be bold enough to say that save your reagents. You don't need to do sequencing at this point of time, because they are not very informative for your decision making in terms of what needs to be done. But instead of completely shutting down, probably have that coordination with the clinical partner to see if there is any out of the normal symptomatic patient which needs to be monitored, but just only for those very, very limited cases. Otherwise, keep your arsenal ready for doing things when the tail phase of the wave is there, then you can capture the new variants. That's what I will like to do, and probably learning from that, not the genomic surveillance part of it, but then I have a young son who is 10-year-old, and I always thought, while seeing him go to school till class 5 in half pant, that was his school norm. So I had some engagement with his principal, and I said that, well, Delhi is an epicenter for dengue in that case. So from class 5 onwards, you have full pant, but below class 5, you have half pant, whereas you have dengue cases, many. Is it very difficult to make full pant for them as well? And then, to the good fortune of mine and probably the kids, the principal agreed that, well, we never thought about it. I said, well, if you want, I can share the data in the lab, what we have done. But he was kind enough and good enough that he took that suggestion from our side, and he has now implemented that in his school. So just on the social front as well, if you find anything which makes sense to say, be bold enough to say that. There would be takers around if it is told logically, and then it is beneficial. Although my son was saying that, Papa, you go and talk to principal too often. That's not required.
Thank you so much, Dr. Rajesh. Unfortunately, the organizer is advising us we have only 2 minutes left. So I would like to give a microphone to Dr. Sujit to summarize the session.
Just trying to supplement what Dr. Rajesh has said, because when you do a less number of samples, you have to very selectively identify the areas from where your samples are coming. All 5% should not be coming from the same transmission zone. You have to see that whether it should have representation from hospital cases, different severity, mild, moderate, severe, which genome is behaving in which way, number one. How transmission dynamics is playing role in community. In Chennai, we identified one vegetable cluster which was spreading disease to nearly 18 districts of Tamil Nadu. So in the initial phase of this is the help of with genomics by which we understand. Our lab was doing this. I was thinking he's doing something research-oriented thing. It has nothing to do with surveillance. But later on, when we go back, when we ourselves learned that new variant is driving the surge. It is not the normal variant. So just to say that you have to look at the community part also while collecting the samples. That see how your samples are drawn from what is the universe from where you are drawing the sample. So that is just a... Yes. No. No, I think we have very, very good audience. But only thing is that we are still what Madam has said, that a lot of things are happening in silos. Maybe IHIP also, a lot of people might have heard it for the first time. IHIP is a wonderful platform, back-end data integration. I wanted to ask Dr. Lee also that whether you are having an integrated platform where entomological data from the vector density so that you can get the alert from the entomological side rather than from the human side. When we get the cases, we get identified. So I think she's nodding her head. So I think that's so that is the beauty, that we have vaccine preventable diseases, vector-borne diseases, we have food-borne diseases. So all these data coming to the same platform, getting the data back and talk to each other, making it integrated, and how that integrated data gives us early warning signs, gives us alerts for the outbreaks, gives us response mechanism also, and better decision making can help. So thank you very much.
Can I add that?
Okay.
Can I add that?
Okay, just
Sorry.
one word. Yes, Dr. Lee Ching.
Yeah, can I add that? Actually, I want to, what Angela and Chairman mentioned really really resonate with me about empowering people with data that you use it for alert. So in our case, our cluster cases, whether it's red zone or yellow zone or a high mosquito population, they're all available on the website and an app that people can subscribe to. So I think the kind of communication is important to add value to your to the work of a multi-source surveillance. Thank you.
Okay, thank you so much to all the speakers, all the panelists, but all the participants. Thank you so much for coming. I really hope that this become an opportunity to continue to enhance multi-source collaborations. Thank you so much. Thank you so much, Dr. Dini, for joining. Thank you so much. Thank you so much. Thank you. Thank you so much.
Very interesting talk and like
Yes,
your
yes.
your example was